A very good morning to everybody present here. And it is my proud privilege to start today's proceeding, and we'll invite our President of Endocrine Society of India, Lieutenant General Narendra Kotwal, to kindly come to the dais and inaugurate and give his address to the audience.
Good morning, respected teachers, esteemed colleagues, delegates, and dear friends. As President of Endocrine Society of India, it is my honor and privilege to welcome you all to 54th Annual Conference of Endocrine Society of India. As all you know, Endocrine Society of India is a very vibrant society, spreading endocrine science, awareness, and patient education. Next 4 days are going to be cerebrally stimulating scientific bonanza, and I'm sure all of you would have a nice time. I wish all the success and declare this conference open. Thank you. Jai Hind.
I would request Dr. Shomik Goswami to kindly come and start the proceedings.
So after that brief inaugural address by our very respected President of the Endocrine Society of India, we move right into the scientific part of the program. We start the workshop. To begin the proceedings for the first workshop, I call upon the dais Dr. Shormishta Mukhopadhyay.
Good morning, everyone. Welcome to the academic extravaganza of ACCON 2025. Our workshop today will start with transgender medicine, a multidisciplinary approach for endocrinologists. And for this, I would request Professor Sanjay Kumar Vadada and Dr. Shailendra Vasin to please come to the dais and start the session, please.
Good morning. I'm Shailendra Vasin, Professor of Medicine at Harvard Medical School, and I want to thank the leadership of the Endocrine Society and the organizing committee for inviting me and Professor Vadada to chair this session on transgender medicine, a multidisciplinary approach for endocrinologists. So the first session is on the foundational principles of transgender care. And the first speaker in this first session on the foundational principles is Professor Anirban Majumdar, who's professor of endocrinology and head of the department at KPC Medical College right here in Kolkata. Professor Majumdar is well known to all of you, has received numerous awards from the Endocrine Society of India, and has written over 100 papers in endocrinology. So Professor Majumdar. He'll talk about introduction to gender identity and transgender health.
Good morning, and I convey my sincere thanks to both the chairperson for the nice introduction, and also my sincere thanks to the organizer for giving us the time to discuss about the transgender health for 3 hours time. So we are really indebted to the organizing committee. So when we talk about the gender identity, we need to understand that the identity is not a choice, it is who a person is. And as endocrinologists, our role is central not only in affirming the gender, but also affirming the gender with dignity. And if we look into our country, we have roughly around 40 to 50 lakh of trans population or gender diverse people. And we do not have much transgender service or gender directed service across our country. So that is why we need to discuss this repeatedly, and we increase the awareness about the gender and their disorders. So if we look into the difference between the sex and gender, it is rightly pointed out by World Health Organization that the sex is basically depends on the phenotype. So it is assigned at the time of birth, and it is assigned by somebody else than ourselves, either the doctor or the nurse or the family members. On the other hand, if you look into the gender evolves over a period of time. It is deeply rooted in our mind, what we feel about ourselves. So in most of the situation, this sex and gender actually correspond with each other, and we often use these two terms interchangeably. But in some of the situation, in less than 1% of the situation, the person's gender may not correspond with the biological sex. And that is what we are going to discuss here today, the incongruity between the biological sex and the identity. Initially, this was actually termed as gender identity disorder. It was in DSM-4, and the terminology actually evolved over the past 2 decades or so, and we find that in 2013, the terminology changed to gender dysphoria. And very recently, in 2018, the World Health Organization has said that it is gender incongruence. Because the World Health Organization suggests that it is not a mental or behavioral disorder. It should be discussed under the heading of sexual health condition. It is not a disorder, it is not a disease. So therefore, we should not be considered it under the heading of mental and behavioral disorders. And therefore, they want to remove the stigma of disorder, dysphoria terminologies, and we need to consider it under the heading of gender incongruence. Now, when we look into this gender and the sex, basically, gender has got 4 important dimensions. Number 1 dimension is biological sex, which is basically phenotypical, and it's not working. So, second is what is our identity, which is deeply rooted in our mind, that is in the brain. And third is our gender orientation or attraction, and that may be sexual, that may be romantic, that may be towards the same sex, that may be towards the opposite sex, that may be towards both sex, that may be towards none. So therefore, lot of permutation combination can occur, and with all these, the way we express ourselves to the community or to the society, we call it as gender expression. So, my first case is regarding identity. A 22-year-old assigned male at birth identifies as female. She reports being repeatedly harassed when applying for jobs and accessing services. So, the question is, what is the most appropriate next step? So, I want your participation. So, one is immediate gender affirming surgery. Second is supportive counseling, psychotherapy for cure or conversion therapy, start hormone therapy, and change in name in the identity documents. So, these are the 5 options. So, how many of you are in favor of A? Can you please raise your hand? Nobody? How many of you are in favor of B? How many of you are in favor of psychotherapy for cure or conversion therapy? Hormone therapy? No taker? Okay. Oh, okay. So I think you got very correctly. That is the supportive counseling. That is the right answer. Thank you. And if we look into the WPATH guideline, the guideline also suggests that we should go in this way, that we should start the psychotherapy, then change in gender role or real life experience. And third is the hormone therapy. Fourth is surgery. And last is the change in gender expression, change in name, identity, documents, so on and so forth. There may be some change between these, this change in gender expression can come a bit early. Sometimes we advise the surgery also early. But psychotherapy always is the first pillar. So whenever we take any patients with gender diversity, we start with psychotherapy. The second case is a gender diversity. A 23-year-old assigned male at birth identifies as non-binary. Student of master degree, very quiet, shy, distressed, with suicidal thoughts. Dysphoria because of facial hair. Uses razor 2 to 3 times daily to remove them. Had lot of cut marks on the face because of using razor. No attraction towards men and women. Not interested to develop breast or change gender. They seek partial feminization. So, what is the appropriate approach? Explain that hormone therapy is only for binary situation. Explore goal and discuss individualized dosing of hormone. Laser hair removal and electrolysis. Suggest cosmetic surgery. So, your participation. How many of you in favor of A? Hormone therapy is for binary, so you refuse the patient. Nobody. Okay, explore the goal and discuss individualized dosing. Good. So that is the right answer. So we often find the non-binary identity in our practice, and many of them do not want to have complete transition. It is because of the fact that anybody who is not heterosexual, not cisgender, are actually clubbed under the heading of gender queer or rainbow community or third gender, whatever you say. And not everybody, not all gender diverse individuals are binary transgender. Because it is a heterogeneous group of people. You find there are hijras, there are intersex disorder, transvestor, there are lesbian, gay, bisexual, transgenders, and there are two-spirited, asexual, bigender, and there are some questioning and queer. Some people where we cannot put them under any heading, we put them under the heading of queer. Suppose this particular individual will put them under the heading of queer because they are still exploring their identity, and that will develop over a period of time. Now, suicide risk. A 22-year-old trans woman rejected by family presents after a failed suicide attempt. Which factor reduces suicide risk most? Antidepressant, family acceptance, hormone therapy, psychotherapy, and gender affirming surgery. So how many of you are in favor of A? How many of you in favor of B? How many of you in favor of hormone? How many of you in favor of psychotherapy? 1. And gender affirming surgery? Looking into the data, the answer is family acceptance. So I find if any trans people come with his or her parents, then I am very sure that this child or this young person will not commit suicide. So therefore, it is a very important that family support is there with. If we look into the data, the suicidal thoughts, suicidal tendency is quite prevalent across the globe among the trans population. It is much, much, much higher than the general people or the normal people. And we find that even the transgender adolescent, very, it is very shameful on our part that very trans adolescent, they actually commit suicide across the globe. We don't have much data from our country. This is one data available to us, published in 2016, that 30% of the trans population have suicidal thoughts and suicidal attempts. We looked into our data, which is about 120 subjects, where we found that suicidal thoughts, suicidal attempts were there in 25% of the patient. And the average age of first suicide attempt is at the age of 16. So that is a very, very tender age. And we very recently we have published these two consensus statement about the medical management who are seeking the transition as female or as male. So many of us, Pramila and Shruti, Mallo, we are all part of this consensus guideline. My last case is about alcohol abuse. A 32-year-old trans woman assigned male at birth, identifies as female, has been on feminizing hormone therapy for 3 years. She presents with complaint of irregular follow-up, poor adherence to medication, and increasing fatigue. On evaluation, she admits to daily alcohol consumption 6 to 8 drinks per day for the past 4 years, which has worsened after episodes of social stigma and job loss. Laboratory tests reveal elevated liver enzyme. So what is the most appropriate approach? Stop gender-affirming hormone therapy permanently. B, address alcohol dependence with referral to mental health service and individualize hormone therapy with coordination from gastro department. Ignore alcohol use as it is unrelated to endocrine management and advise the patient to reduce alcohol intake but continue the same regime. So how many of you are in favor of A? How many of you in favor of B? And how many of you are in favor of C? How many of you in favor of D? Okay, so great. So all of you has given the right answer. So if we look into the psychological health and the substance use disorder, it is quite prevalent in the trans population across the globe. So many trans people have PTSD, anxiety disorder, depression, bipolar disorder, and we find much more substance abuse disorder among trans population compared to the average population. We don't have much data from our country. We have published this data about 2021, and we have looked into the addiction among our trans group. So we had a cohort of 120 subjects, and we find 50% of them actually involved in some kind of abuse, substance abuse. But fortunately, most of them are using either smoking and alcohol, and none of them were using marijuana or intravenous drug abuse. In this 120 cohort, it may be there otherwise. So with this, I will conclude by saying that the non-binary genderqueer identity should be recognized by healthcare service system. And lack of acceptance of non-binary identity is harmful because it leads to the suicidal attempts. Affirmative care saves life, and we need to create a welcoming clinical environment, not only for transgender individuals, but also for non-binary genderqueer people to disseminate right information and reduce the health risk. Thank you very much for your patient listening.
So now I invite the next speaker, that is Dr. Deep Malya Sanyal. Dr. Deep Malya Sanyal is Professor, Department of Endocrinology, KPC Medical College, Jadavpur, Kolkata, and is well-known figure in this area. I can say is the young but the experienced clinician in the field of transgender, and he is working in this area for more than 15 years. So without wasting much time, I'll hand over the mic to Dr. Deep Malya for the presentation. He is speaking on the feminizing hormone therapy for the transgender.
Thank you, sir. Thank you for the kind invitation. And also, after an excellent introduction by Professor Dr. Anirban Majumdar, we would be discussing probably one of the commonest variety. One is the feminizing and the masculinizing. Population-wise, it's generally found to be equal, but probably in India, because of certain social issues, we have more people who require feminizing hormone therapy, who would be seeking feminizing hormone care. So if we also have the Indian Standards of Care, which was published a few years back. We are updating that as well. So one is, with regards to care, individualization of care is very important, because as Dr. Majumdar says, some would prefer even non-binary status. Mental health assessment is important. Medical evaluation is very important, as is fertility preservation counseling. And the goals also have to be individualized. With regards to feminizing hormone therapy, primarily it is estradiol or estrogen-based therapy along with anti-androgens or GnRH. targeting cisgender hormone levels, and we need to also monitor cardiovascular risk, thrombosis risk, the hormone levels, and the liver functions, the renal functions, the potassium where necessary. Now, if you look at the Endocrine Society guidelines, which is about in 2017, there also it's mentioned oral estradiol can be used, but not ethinyl estradiol or conjugated estrogen because they are not measurable. Secondly, for patients with high risks, after 45 years, history, family history or personal history of VTE, transdermal or injectable estradiol is generally preferred. Now, with regards to the routes, which are very important, the oral, we have estradiol valerate, the ethinyl estradiol and CEE. The intramuscular, the estradiol valerate and cypanoate. And the transdermal, we have the gels, we have the patch as well as the spray. We are all aware that for suppression of androgens, we require, apart from estrogen, we would be requiring either anti-androgens or a GnRH. The options, which could be spironolactone or GnRH, which could be monthly or 3 monthly. Estrogens like estradiol, if we see the Endocrine Society guideline vis-a-vis the Australian guidelines, maximum dose of estradiol valerate could be up to 8 milligram. The gels, which are available between 1 to 2 grams per day. We have the patches as well as the implants as well, which have now developed in Australia as well. So if we look at the options in resource poor setting, we have the option of using anti-androgens like spironolactone along with oral estrogens or injectable. In resource rich setting, we can have the option of GnRH along with injectable or the transdermal as well, especially the patches or the gels. If we look at the dosage conversions, we can see it's almost similar with valerate and estradiol compared to, also we have the comparison with the transdermal as well as the transdermal gel and the patches as well. So that's very important when we are using in our practice as well. Now with monitoring, as far as the Endocrine Society guidelines goes, initially first year it should be 3 monthly, then 6 to 12 monthly with regards to the cisgender, female cisgender levels, that is testosterone less than 50 nanograms per DL, and the estradiol not to exceed, it's very important, the peak physiological level of 100 to 200, because lot of time this population would actually over-treat and would exceed the levels as well. Once we start spironolactone, the potassium also has to be monitored. The cancer screenings also have to be done as per the organs which are preserved. Now, we have reported that the most preferred regime is spironolactone with GnRH by about 68%. Only about 30% preferred with GnRH, but obviously the dose requirement of estrogen is less once they are on GnRH therapy. Very important, we have compared 3 groups with regards to patients who are on GnRH, who are on anti-androgens, vis-a-vis who underwent orchidectomy. Patients who were on GnRH or orchidectomy required the lowest doses of estrogen and were more effective in reaching the targeted level, especially the targeted androgens level as well. Now, this has also been previously reported. The average dose of 4 to 5 milligram in patients on anti-androgens failed to achieve the desired recommended estrogen levels. So most of the time it would be about 6 milligram or higher doses, pretty higher doses, compared to those who had undergone orchidectomy, where the dose requirement is much lower, so making it much safer therapeutic option, similar to what we have reported as well. Now, very interestingly, the recommendations for injectable estrogens, which are also available in our country, are much higher. Even the Endocrine Society guidelines suggest it should be somewhere between 5 to 30 milligram every 1 to 2 weeks, whereas it has been seen that even less than 5 milligram is suitable to achieve the targeted estrogen level. Not only that, even subcutaneous estrogen would probably require a much lower dose as well. So if we see, the dose requirement is about 30 milligram per week with oral estrogen with anti-androgens, less than 5 milligram per week with intramuscular estrogen, and for transdermal between 2 to 5 milligram per week is required. Very importantly, with a persistent level of estrogen which is maintained throughout 24 hours, transdermal is more effective in suppressing the testosterone level compared to even oral estrogen. So that's very important. And this is without anti-androgens, without background GnRH therapy as well. Now, which route is better in terms of not exceeding estrogen? Again, you can see compared to oral, injection and transdermal, it is the transdermal formulation where the estrogens level are not exceeded. Not only that, the proportion of testosterone suppression is also better, almost 100%, as has been reported with transdermal estrogen preparations as well. So obviously suggesting probably transdermal is the way forward, but there are difficulties with patches which we find in our humid climate. So how long to continue GnRH? Well, till orchidectomy in male to female, and after surgery it is definitely not required. Otherwise, the supraphysiological doses may be required. Now, is there any additional benefit of suppressing the testosterone level? Now, this was a very important paper in Journal of Endocrine Society 2024, which suggested that those transgender women who had adequately suppressed testosterone level had minimal coronary burden. So that's very important. So if we can suppress the testosterone level, that actually reduces the coronary risk as well. So that is very important. So not only is desired estrogen required, but also suppressing the testosterone level is very important. And probably, which is used, this is a formulation every 2 years, this is estradiol implant is used. They have also found that they have been able to suppress the testosterone level very well. So this was a study from Australia. So physical levels with hormone therapy are achieved over a period of 2 years. There is no difference between different regimens, but some aspects like facial and body hair may not be achieved. Even after 1 year of therapy, breast size may not be achieved as well, and serum estradiol levels may not predict breast size. That's very important to counsel our patient, because a lot of times they use the supraphysiological doses. Now, one reassuring fact with regards to safety, this is the ENIG data, the European data. I was fortunate to review this data, and it was found that over a period of 10 years, gender affirmative hormone therapy is safe in short and mid-term, not known the long term. Beyond 10 years, the data is not there. The commonest side effect with male to female estrogen is increase in prolactin, and long-term, however, safety data is still not there beyond 10 years. Now, why transdermal preparations are preferred after 45 years? Because again, studies showing, even the ENIC group showed that there was no single episode of VTE, venous thromboembolism, with use of transdermal preparations. Now, medical risks are basically venous thromboembolism, hypertriglyceridemia, hypertension, and diabetes, but we need to avoid supraphysiological doses. Where we need to stop, absolute contraindication is venous thromboembolism, estrogen-sensitive neoplasm, and chronic liver disease. Hypertriglyceridemia is a relative contraindication. So with estrogens, there can be some changes in blood pressure, body composition, especially fat mass is increased. There is some increase in insulin resistance, but whether diabetes risk is increased is still debated. Increased risk of stroke and venous thromboembolism is also seen, as has been seen in this meta-analysis, where you can see increased risk of venous thromboembolism as well as with stroke. But mind you, these were mainly with the older oral estrogen preparations that these studies were done. So transdermal obviously have, they do not pass through the liver, so no rise in the procoagulant markers and inflammatory markers, less affection of triglyceride level, and that's why they are safer. So if you look at safety, best is transdermal, then oral valerate or injectable. And then we have the worst, which is the ethinyl estradiol, which is definitely not recommended. But overall, if you look at VTE, which we are always scared, we have not seen any, at least I have in my 110 and probably total we have about more than 200 patients, we haven't seen a venous thromboembolism. 2.3 per 1,000 years, patient years. Absolute clinical risk is less, but we need to counsel, especially with regards to those who take tobacco or who are obese, and obviously move to other formulations like transdermal if there is a family history or personal history. So ethinyl estradiol again is not recommended, conjugated estrogen not recommended, and after 45 years or a previous history of VT, the transdermal is recommended. Very important as we see with regards to assessing risk, metabolic risk, more than 45 years, male at birth, that is all male to female, obesity, current smoking, and autism spectrum disorder, one need to consider primary prevention. Especially we need to monitor the lipids, the A1C, the hematocrits as well. With regards to prolactinoma, again something debatable, whether it is estrogen or cyproterone acetate induced. Again, conflicting evidence, and this was initially recommended by the Endocrine Society guidelines with regards to prolactin monitoring, but the recent WPATH guidelines do not recommend it anymore. With progestins, current evidence, there is insufficient evidence with regards to benefits, and definitely probably the harm is more than the benefits. So with regards to breast development also, the data is still not clear. So the jury is still out, but still long-term harm may be there. We don't have much data with micronized progesterone as well. With regards to perioperative period, estrogen has to be stopped 4 weeks prior to surgery. We can use a single dose of GnRH to decrease dysphoria during this interim period. It can be started 4 weeks post-surgery, and only transdermal should be used if there is a history of VTE perioperatively. In summary, so this is a stepwise procedure. It is multidisciplinary. First, we need to check the eligibility criteria. We need to monitor, initially screen, as well as monitor for adverse effects. This has to be done almost till the patient is receiving therapy. Before starting on the gender affirmative hormone therapy, we need to be actually counseling patients with regards to adverse effects, as well as expected time periods, and need to mention what are the irreversible effects. Most important is safety. Probably the evidence, especially after 45 years, a lot of patients are now coming after 45 years, they're coming out of the closet. So in those persons, probably transdermal preparation. And in our population, we are using gels a lot, and it's been used quite effectively, so they may be more convenient. And that may be effective and safe in terms of maintaining the hormones. And we have seen they can also suppress the testosterone level, so that may be an additional benefit. GnRH is probably a safer option, but it is more costly compared to anti-androgens. But obviously, as has been suggested, if we don't use gender affirmative hormone therapy, there is high risk of suicidal ideations, and so hormone therapy can improve psychological functioning, depression, and suicidal ideation. We need to monitor for complications, CVD, and cancer risk, and discontinue prior to surgery and restart post-operatively, and have a long-term follow-up. Thank you very much. Thank you for a patient hearing.
Thank you, Dr. Deep Malya, for this nice talk. And I now invite the next speaker. Next speaker is Dr. Pramila Kalra. Dr. Pramila Kalra is former head of department Endocrinology, Ramaiah Medical College and Hospital, Bangalore, India. And his numerous publications, numerous awards. Everyone knows Dr. Pramila. So before going much detail about the introduction, I request Dr. Pramila, she is already here, and she is going to speak on the masculinizing hormone therapy. Dr. Pramila, please.
So thanks, chairpersons, for the kind introduction, and I thank the organizing committee for giving this opportunity to be there for this transgender workshop. It's really a nice thing that they have thought about this and they have given 3 to 4 hours exclusively for this. So I'll be talking about masculinizing hormone therapy. Now, we have already had an idea about how we go about the diagnosis of gender incongruence, how do we take the decision to start the therapy. So I won't go into that thing, but I'll start straight away with the masculinizing hormone therapy. How do we go about it? Now, the first thing is, why are we giving this? Why are we treating? That's the question, because many times the patients also ask, and the family is also asking, like, why should we treat? What is the use to treat? So we know that they are having dysphoria, they are having distress, and they need help. So that's what we are basically doing it for psychosocial well-being, for the well-being of the patient, for the mental health for the patient. But we are also bothered about cardiovascular health, musculoskeletal health, body composition changes will happen, which the patient wants. But as doctors, we are also bothered about metabolic parameters. This we have already seen that we have this consensus statement. We also have the Endocrine Society guidelines, which have come in this issue of IgM. So everybody can go and have a look at that as well. When we talk about the scenario in our country, this is our data from our center. This was a long time back data. Now we have even more number of patients. But this is what we saw, that most of them are coming to us at a later age. But now what I have seen, the trend is the moment they become 18, on the first, the day their birthday is, they'll come to us. But previously it used to be like 27, 28. And the other group which is coming to us is 45, 50 plus. I have patients 60 plus who come to me for first time for starting gender affirming hormone therapy. So this is a scenario which has changed. They don't have the correct information. They get the information from their peer group and they rely exclusively on that rather than what we tell. So that's also very important, because we should not try to say that what information you have is absolutely wrong. Then their trust will not be there. The follow-up is very intermittent. You start the hormone therapy today, they may not contact you for 2 years, and then you may get a call because they want a letter for gender-affirming surgery. So these are the problems. It is still there. Many are not educated. I have patients who are engineers, doctors, physiotherapists, but I have patients who are begging on the road also. So there's a huge variety of the patients. Family support is still less, though it has improved. What we have seen over the past 17 years of my practice with gender incongruence, I have seen that the family support system has improved, but still it is not up to the mark. Many a times I see that the parents show, I should not say that word, but I see that the parents show that they are supportive for the child, but when you talk to them alone in the clinic, then they will say, please do something, I don't want all this. I'm just supporting my child so that the child does not leave the home and runs away. So there are lots of things which we have to keep in mind when we start this therapy. So we have to see what the individual is wanting, what the family is wanting also is important, because family support is very, very important. Counseling regarding the realistic expectations is very important. Medical history is very important. Sometimes they may not tell you the medical history and they may think that's not very important for you. So we have to ask what exactly happened in the past or anything is there. Informed consent we always take in our OPD for the reason that it's better. We take a consent that the patient is aware that these are changes which are happening. Some of them may be irreversible. There may be side effects which the patient has been told about. And we also tell them that there will be some psychological changes sometimes which might need treatment. All these things we write and take a consent. So it's always a better idea to do it so that the patient is aware and everybody is aware. It's not mandatory. Now, we also have to tell them about the adverse effects, because infertility may set in. So sometimes they're not aware. They may think that I'll take it now. They might come to you for some reason, and then they say, we don't want it, and I want the reversion of all the things, or they want detransition. Because now I have a huge number of patients who but maybe not treated by me, but treated by somewhere else, or on their own they treated themselves, and now they are coming for detransitioning. So that's another group of patients whom we have to be aware about. So we have to do the initial evaluation where we talk about all the initial physical examination also is important, but it's not like that we have to do a genital examination for all patients. If you have a doubt, if you have a query, if you have a doubt about the DSDs, we should do with the patient's consent, not force it on the patient. Because if you force it, then it may be a problem. So we have to do with the patient's consent as and when mandatory. We have to talk to them about the substance abuse, the sexual orientations, and what all they want, their fertility desire, and what type of therapy they are looking for. Then the baseline evaluation should include a complete blood count, metabolic parameter screening, including the patient's glucose profile, the lipids, and all those things. Hormones are to be checked because that will give you an idea what exactly is happening. I had a lot of patients, especially not the trans males, because there you will see more features coming up physically, but in the trans females, sometimes they start the therapy and they don't tell you. And they say that I'm not on treatment. And when you do their levels, you get a shock that your levels are coming like this. And then they tell you, no, I have been taking treatment. So this all we have to keep in mind. And we have to also see for sexually transmitted diseases, because many of them may have STDs. So that also needs to be looked for. Some of the things which are optional can be done, like HbA1c. Karyotyping, I preferably do it. It's there in the guidelines. It's not, like, still it is not very a norm in our country, but I preferably do it because especially if the patient's parents are very apprehensive, sometimes it is a good idea to do all the investigations and then start the treatment to be safe and to be sure also. And we also have to see if we need a bone screening, a DEXA scan. Now, fertility options have to be discussed at every visit. I had patients who told me after 1 year that you never discussed it. So it was discussed on day 1, but maybe it was not discussed at the subsequent visit. So we have to discuss it at every visit because they might like to rethink about it. So what are we giving these hormones for? We are giving these hormones to reduce the endogenous sex hormones and give the hormone levels of the desired gender or what they want to be and give the phenotypic characteristics of the desired gender. So that's what we are giving, and that we use the terminology gender-affirming hormone therapy, but we also use the terminology cross-sex hormones. But many of my patients don't like the word cross-sex hormone. They said that this is not cross-sex. This is what I want. So we don't preferably use that terminology. These are the different preparations which are available, but in our country, we use testosterone enanthate, which is once in 3 to 4 weeks. We have undecanoid preparation, 1000 mg once in 12 weeks, but we don't use it much frequently. We also have subcute preparations now available, testosterone, which can be given. Patient can self-inject. That also, Dr. Deva Malya has data on that. So we are using in some patients that as well. And we are using a lot of gels. So many of our patients don't want to start with hormone therapy as injections, or they are traveling outside and they can't take the injections. They don't have access to taking injections. They are comfortable either taking the subcute or they are comfortable applying the gels. So many patients, we are using gels also. Though with the gels, the effect takes a little bit of a time. But overall, when we see that I have patients on gels for 2 to 3 years now, and they have got the desired changes. Monitoring, we have to monitor for side effects. We have to monitor for the hormone levels. So for the hormone levels, we have to check the testosterone midway if we are giving the enanthate. If we are giving the undecanoid, we have to check before the next shot. And we want to keep it in the range of the male. That is 400 to 700 is preferably nanograms per DL is what we try to keep. Also, if we are using gels, then at least the patient should have applied the gel for a week, and we should check it 2 hours after the application of the gel. We have to tell them that there's a time frame for the changes. There will be skin changes first, oiliness will happen, some fat redistribution will happen. Clitoral growth will also start subsequently, so that we have to tell, because some of these changes may be irreversible. Voice change will also start. So in masculinizing hormone therapy, it's very, very important that we tell about these two things, the clitoral enlargement and the voice change, because the voice change will not go back, and then the patient may decide after 1 year to stop, and then they say, now I don't want to do it. So then we have to counsel that these changes may not revert back, and you might have to live with these changes in case you decide to stop, or sometimes they have not informed the family and they start, and then they say, now my family is saying that they'll not give me the property share. I had patients like that, so who decided that I don't want to do it. So you can have multiple reasons, so you have to be very, very careful, explain properly. The only way out is explain. To stop the menses, mostly it stops after 6 months to 9 months once we reach the 250 mg dose. But if the patient is very, very dysphoric, because I had patients who were so dysphoric on day 1 that they wanted the menses to stop, then you can give a GnRH agonist or you can give a medroxyprogesterone. So both the options are available. You can decide and talk to the patient and accordingly decide. But some patients say, I don't want progesterone. I don't want any female hormone sort of a thing. So they go for leuprolide. So we have to see what the patient wants, tell them this is what I'm going to do and this is why I'm going to do it. And this may not be needed for long. So we know that testo may have different effects also, metabolic effects. We already discussed few of them. We have to monitor for all these. First, initially every 3 to 6 months. Later on, once in 6 months after the 1 year may be good enough. But hemoglobin, PCV, SGPT, SGOT is good to monitor every 3 months initially, because these are the parameters which may need watching initially because you might have to decide about therapy with this. So this we already discussed. Erythrocytosis is very important. If the hematocrit is crossing 55% or the hemoglobin is more than 17.5 grams per DL, then you have to decide to hold for some time and let it come back. Maybe reduce the dose later. Once it is a little bit better, phlebotomies can be done. They can do some bloodletting, and that can actually help the patient to bring down the levels. Smoking, if it is there, should be stopped. Passive smoking, we have to see. I had patients who were doing passive smoking, and they said that they are not smokers. And when we took care of that, it became all right. So hematocrit, we have to watch. This we already discussed. BMD, if possible, we do it at baseline, but in individuals who are at risk, we might like to repeat it 2 to 3 years later. And after 50 years, in most of my patients on gender-affirming hormone therapy or who are gender incongruents, I preferably do 1 BMD. Cancer screening is another important thing. Now, when to consider this surgery, it's a patient decision. It's not a mandate. It's not a mandate for the patient to go for surgery, so that we have to be clear in our minds. Stopping before going for the surgery, we tell them it is not necessary to stop the therapy. If it's a high-risk case, then or clotting disorder or something, we can think about stopping a month prior. But if it is just a usual surgery, we tell them that 15 days prior to the surgery, they can take the shot. They can plan their shot like that. This is normally what I do, but there is no guideline to stop the therapy before the surgery because it can cause more distress. Cancer screening is important. Cervical tissue, if it is retained, we have to monitor. Breast tissue, mammography we have to do. And we also have to do subalveolar and perialveolar annual breast examination, even if the mastectomy is done. Treatment, how long to continue? Once the full masculinization has been achieved, you can decide to reduce the dose. After 50 years, preferably I use a low dose only. So these are some of our center data where we have found that there was not much change in the insulin resistance. This was a follow-up for 6 months to 1 year after starting the masculinizing hormone therapy. And we did find some changes in the subcute fat. We did not find much changes in the visceral fat in our study. And we also did try to see the HbA1c. We did find that there was a little bit of an increase, but the insulin resistance did not show much change. So maybe now we are following up those patients after 3 years, we'll get the final answer. And body composition, subcute fat was the 1% which changed, and the whole body fat. This was one of our study which is under publication at the moment. So this, we tried to see the body composition as well as the muscle strength. And we found that in trans males, there was an increase in the muscle strength after 1 year of the hormone therapy. And this is what is important for sports, because where should they be considered? In which category they should go for? Bone health, we found that in trans men with testosterone therapy, there was an improvement in the bone health. So this is an important thing, because whenever in trans males you give testosterone, what data we have till now for our BMD for the patients at 1 year also, we have data now, we have data at 2 years also, and we have found that there's an increase or betterment of the bone health in these category of patients. This is one thing which we never discuss, the sexual dysfunction. And we did a study which is under publication again at the moment. So in this study, we found that there was a sexual dysfunction in almost all these trans males, irrespective of the surgery. So this was very important because we never discussed this point with them, and we just tend to negate that. So the take-home messages is, first, diagnose correctly. As Dr. Anirban pointed out, that we should be sure of the diagnosis. If you have a doubt, review your diagnosis. Stop the treatment, take a consult with a psychiatrist. If you're not able to judge, take 2 consults, no worries. But don't treat unnecessarily, because you might unnecessarily give the therapy. That's also not right. Take psychiatrist, psychologist help, no problem. Documentation is very, very important at every step. Authenticity of records. I had patients who showed wrong Aadhaar cards. So they were 16 years and they showed 18 years. It's not my fault, but I have to check, because tomorrow the parents may come and question me. And the dose of hormones should be escalated slowly. We should never try to be overzealous with the hormones. Realistic expectations, and tell the patient what's going to happen. Never forget to discuss the fertility option at every visit. Not at the time of the diagnosis only, but every visit and just before surgery also, because after the surgery, we may not be able to do anything. We regularly organize these health camps with our transgender population to make them aware of it. This question I leave to the audience, like, can anybody tell me? Everybody must be knowing about this, not the experts. Anybody can tell what is this? Alcazar, yes. So a very candid observation which my daughter made, she said, why all the women are taller and why all the boys are shorter? So this was because obviously they are all trans, so they are all trans males who are shorter, and the others are trans females who have started obviously the therapy after they had their full puberty, so they're all taller. So that's what, this is the Alcazar show in Bangkok. Thank you.
Thank you, Dr. Pramila. Please join me here on the dais. And I'll also invite Dr. Deepmalya Sanyal and Dr. Anirben to join on the dais for the question-answer session. So, to set the ball roll, I have a question to Dr. Deepmalya Sanyal. Would you prefer the spironolactone versus dutasteroid?
Yes, sir.
The spironolactone versus dutasteroid.
So, basically, spironolactone, especially with regards to dutasteroid, there are some issues with regards to depression, worsening of depression, and also sexual dysfunction, which has been reported with dutasteroid. So, spironolactone with adequate monitoring probably may be preferred, and also with regards to testosterone suppression. There is testosterone suppression has been seen with spironolactone, but dutasteroid cannot suppress the testosterone level, rather the testosterone levels become elevated.
Let me add. Sir, the issue is that most of the data with spironolactone, there is hardly any data available with dutasteroid. So that is why we use spironolactone. The guideline also suggests to use spironolactone. Huh?
RCT on that?
You know, some patients, sir, would prefer because of their scalp hair. They come and they request because of the data with regards to scalp hair and body hair. So sometimes we have to add along with spironolactone.
Sir, can I have a question? So for gender affirming, sir, Shubhodip here. So for gender affirming therapy in trans women, how long do you give estrogen? You said after 45 years of age, you prefer transdermal estrogen, but how long?
So generally, up to the age of 55, we can continue. Up to 55, we continue. A lot of patients actually are coming up after the age of 40, 45. After, you know, nowadays especially, I've had about 7, 8 patients now coming up late reporting when they're coming out. So there we start only with the transdermal as well.
Well, another question that, although you mentioned you never came across with VTE for any patient who are on estrogen therapy, but let's say if somebody develops an absolute contraindication after starting estrogen therapy and we need to stop it, how do you manage those cases?
So first we need to check out the reason for the VT, like whether it is perioperative VT which has occurred, whether there is underlying like cancer, or there is a family history, or there we can go for a genetic testing also. If there are reversible factors, then after the condition is reversed, we can start, but obviously we have to start only on transdermal. Sometimes we can, the recommendations are we need to continue the coagulation therapy. Along with that, we can start with the transdermal preparation, albeit at a lower dose and monitoring, adequate monitoring.
Okay, thank you.
I have few questions. That was an excellent session. Thank you. Now the guideline says any clinician can diagnose gender. So I know we have a protocol to get psychiatrist evaluation also for depression, anxiety, substance abuse. So I want to know your take on that. Whether would you be still comfortable diagnosing it without the psychiatrist help? That's number one question. Number two question to Deb is, with estrogen injections that are now available, it's not available in the pharmacy, but people directly, and some of my trans women get it from the supplier. It's actually not from the pharmacy. Is it legally okay for me to write it in the prescription? Because a lot of estrogen enanthate injection, enanthate is also available, cypionate, enanthate, and valerate injections are available that they purchase it from the local dealer. Is it okay for me to write it in the pharmacy, my script? Because it's not available from the pharmacy yet. They are using it through other sources to procure the injection. So I just want to know the legal, I've been doing it, I don't know if I'm doing something wrong. I want your expert opinion on that. So these are my...
Okay, Shruti, the first part I would like to answer. So if you look into the recent, development, so the transgender or gender diversity need to be diagnosed by the primary care physician, because primary care physician must be aware about this condition, and number two, they must recognize, and they must start the communication at least, even if they are not entering into hormone therapy or surgery. But communication is very important. You know that somebody who has a gender dysphoria come to a physician. They may not come to a endocrinologist. They will come to a physician. And if it is not recognized, if the physician refuses to give any support, at least mental support, then there is every possibility that this person will go for suicidal attempts, because he is not getting any support from the family, neither from the society, nor from his or her friends, and came to a physician for some support. So that is why we, Professor Bhasin has actually taken the initiative to develop a video of how we should go about it. So this video we expect that will be there in the Endocrine Society of India website, and across India, anybody, any physician can have the access to get some understanding about the transgender issue, and we expect that every physician know little bit about it, should start the communication, if not the diagnosis and the treatment. And for the second part, then
Yes, probably to add to that, I would say that finally, before starting treatment, we probably require, after the psychiatric clearance, we probably require an endocrinologist to start, because we have seen, at least I have seen quite a number of patients coming with DSD and underlying DSD which has not been diagnosed. So that is something we need to stress. And with regards to estrogen, generally I prefer using oral or gels because of the availability, because most of the time, as you rightly pointed out, they are not available, so it's difficult. Having said that, all, whether it is testosterone or estrogen, they are all off-label use. So that is something we need to work on, even with our Endocrine Society of India as well as everywhere, because these are all off-label use as well. So that is something where we require actually an indication use, because it's all off-label. We are using all these preparations as off-label, something which is important to understand. In some patients, they come who are insistent on taking estradiol valerate. I have only written estradiol valerate, and because I see only one brand which is available in the internet, which is available, but I haven't seen any store having this pharmacy giving any estrogen injections.
And Dr. Shruti, just to add to your point, like why the psychiatrist opinion is important, for the reason that many of them may have psychiatric disorders which we may not be able to diagnose. That's the most important thing, because I had patients who had depression, who had suicidal tendencies, and sometimes only after elaborate counseling from the psychiatrist we come to know that actually that they have psychiatric disorders. And also it is important that when we start hormones, it may go both way, whether be it estrogen or even if testosterone, sometimes they are not very, what they expect and what exactly happens and how the peer support is or how it is in the family changes the whole picture, and that can actually sometimes make it better, sometimes it can make it worse also. So that's why it's a very important thing that we keep the psychiatrist in the loop. Also, it's important that we don't rely just on the psychiatrist, because I had so many patients of DSDs, as Dr. Deva Malya also said, that who were actually diagnosed as gender incongruence. I recently had a 5-alpha reductase who came to me and was insisting that a very reputed psychiatrist has given gender incongruence, why aren't you starting the treatment? And I said, no, this is not at all gender incongruence, this is 5-alpha. So that is why both of us together have to work. So that's what we have made the SOPs in our hospital, that it's just not one person who certifies, that both people, once they are sure that the because I may look at from the endocrinological perspective, they will look at from the psychiatrist perspective. Though we don't mandate it, many patients tell us that it is not mandatory. Why are you asking? I just tell them I'm just asking it for the reason that I want any other psychiatric thing or anything which can happen in future to be taken care of, just for support.
Yeah, one last brief question, please.
Thank you so much, all the speakers, for such an insightful and comprehensive talk that has really clarified many aspects of this complex corner of endocrinology. My question is for Promila ma'am. Ma'am, how do you approach testosterone dosing in borderline metabolic syndrome? Because cardiovascular risks are always a concern there. And the last question from my side is, sometimes after initiation of the testosterone therapy, the patient might come with complaint of acne or hair loss, or even sometimes persistent breakthrough bleeding.
Yes.
So what will be your stepwise approach at the OPD? Thank you, ma'am.
Yeah, so it's very pertinent question because now I am seeing a lot of patients who are coming for masculinizing hormone therapy having pre-diabetes. And the reason is not that all of them are young, some of them are coming at 35, 40 first time. So if they are above 30, 35, I do a cardiovascular assessment also as a routine. And then if I have to start, suppose the patient is already a pre-diabetic, then I always start with, anyways we start with a low dose. So we start with 100 mg once in 4 weeks. And then in such patient, I may not escalate the therapy to the full dose. I might not keep the levels between 400 to 700 for that patient. Maybe in that patient, over a period of 1 year, I may escalate the therapy, monitoring the glycemic parameters, telling them about lifestyle modification, and still the things are not okay. I have to treat that as well because I have patients who are on anti-diabetic drugs or on statins as well and are on testosterone therapy. But in such cases, I don't escalate the dose too much. I keep the levels like 350, 400 max. I don't go beyond that. And I give a therapy of like 200 mg once in 4 weeks if they are okay and the parameters are not getting deranged too much. And then I follow them up and see how the metabolic parameters are. Likewise, also counseling for the diabetes and the dyslipidemia goes on with that. And the second question you asked was for the complications. So acne is a very, very common side effect. We tell these side effects acne and the hair fall. And the hair thinning is very, very important because they are all like females now. So though they are trans males now, but they don't want their hairs to go off. And the hair thinning is a very, very common problem which we see in these patients. Supportive therapy helps in some of these patients. And also for acne, I give topical treatment. And also we take dermatologist opinion for supportive therapy. Minoxidil and all has a good role in these type of hair fall therapies. And also biotin and all also plays a role. So that also we add in these patients. And along with that, metabolic syndrome parameters and other vitamin deficiencies like B12 and all, ferritin deficiency, all that can be also the reason for the hair fall, which needs to be looked into. But acne can sometimes be very severe. I had patients whom I had to halt the therapy or for some time because the acne had gone to a very bad state and then restart at a lower dose. So sometimes I de-escalate. If they get the breakthrough bleeding, then I give them either the option of leuprolide or medroxyprogesterone. Most of them opt for medroxyprogesterone injection once in 3 months. It happens for a short time, but if you have a patient who had no periods and now all of a sudden bleeding has started, you should always do an ultrasound pelvis to see if there is any fibroid or endometrial problem which is causing it, and then give medroxy, not give it just like that. So initial stage when they are very dysphoric, you can start off with that, but later when you are giving it, ultrasound pelvis is a good thing to do, and I always do it before I give the medroxyprogesterone or the leuprolide. I discuss it with the patient and tell. As I told that progesterone some patients may not want, so they may go for leuprolide, but most of the time they opt for progesterone because it is cheaper.
So that we bring this first session to close, and I want to thank the speakers for their outstanding presentations, and I invite Professor Majumdar to open the next session.
So they must stay back. So, এটা কোথায় প্রোগ্রামটা কোথায়? এজেন্ডা?
Okay. For the next session, we will be having Dr. Anirban Majumdar sir and Dr. Devmala Shanal sir as the chairperson.
So we are move on to the multidisciplinary perspective in the second part of our session. And for this, I would like to invite Dr. Shuja Sukumar. Shuja, okay, so you are here. Shuja is a consultant endocrinologist. He's from Renai Medicity, Cochin. And she's also member of IPATH and WPATH also, many achievements. So without going much detail about her achievements, so let I invite her and start her deliberation regarding the thrombotic events with estrogen therapy. What do you, Shuja?
Thank you, sir. Thank you, chairpersons and organizing committee for giving this opportunity to be here. I'm a native of Kerala, and we celebrate Onam today, tomorrow, and next day. So a very happy Onam greetings to everyone. So on that festive note, let me go into the topic. This is actually a continuation of what Devmalya sir was speaking about with the transfeminine hormone therapy, the thrombotic risk associated with estrogen therapy. So we all know for years, ever since that WHI and all, we know that estrogen do carry a risk of venous thromboembolism. Even it is well documented in cisgender women, because we know the data from combined estrogen containing OCPs and also from the postmenopausal HRT therapies. So why? Because we know there are several mechanisms by which estrogen can increase the thrombotic risk because of the increase in all these prothrombotic factors like 2, 7, 9, 10. Similarly, the fibrinogen levels will be increased, the von Willebrand factor is increased, protein S levels are increased, there is resistance to protein C. So there are a lot of mechanisms by which estrogen can lead on to thrombosis. So what we learned from this cisgender data with regards to hormonal contraceptives is that most of these contraceptives pills which contain the ethinyl estradiol or and progestins, they do have an increased risk compared to non-users of these pills, and the risk is varying depending upon the type of estrogen and also the type of progestin which we use in these pills. For example, this desogestrel containing progesterone containing pills will have more risk. Similarly, ethinyl estradiol definitely carries an increased risk. So despite the increase, if you look at the rate of venous thromboembolism in OC pill users, actually it is lower than what we see during the postpartum period and pregnancy period. Similarly, if you look at the data from menopausal HRT, this is another, not the WHI, but the Esther study. Actually, it showed that oral estrogen do increase the VTE risk, but if you change it into a transdermal type of delivery, definitely the risk comes down. So Devmalya sir was also talking regarding the same thing, like transdermal estrogen, because of its bypassing the liver effect, it does not pose a risk of venous thromboembolism. So let's see the transgender data. So these are the meta-analysis, various meta-analysis. So I'm showing 4 meta-analysis data here. In the first data, as you can see, the Maraca et al. Data, where the venous thromboembolism risk is there, it was higher among the female, male to female, that is transfeminine therapy, compared to the androgen therapy. So usually the risk varies from 0 to 5%. And the next Khan et al. Data, if you see, again it was in transgender women on estrogen therapy, it was around 2.3% of this. And usually the transgender and cisgender women on estrogen therapy, they had similar rates of VTI. Similarly, the next study, which is the Totaro et al. Study, here they looked at another parameter also, that is the age cutoffs also they studied. So what they could see was that the prevalence of VTE in the transfeminine therapy, it was increased when the age when you use it in age more than 37.5 years. That was the cutoff that they derived from this study. So it was 3% when age was more than 37.5 and 0% when age was less than 37.5 years. So meaning by that, as age advances, there will be increase in the risk of VTE. Similarly, the length of estrogen therapy. Usually in menopausal hormone therapy, what you see is the risk is much higher in the first year of therapy. But here with transgender hormone therapy, the risk increases as the duration of therapy increases, especially more than 8 years. There is another study, which is the Kotamati et al., where they again found that it is almost around 4.2% incidence of VTE. So these are the risk factors, like depending upon the type of estrogen. So that is why we don't use ethinyl estradiol anymore. We don't use conjugated equine estrogens also these days. So what we use currently is 17-beta estradiol, which again carries a small risk of VTE. But with transdermal estrogen preparation, the risk is practically nil. And these are the rates, odds ratio for venous thromboembolism depending upon the route of administration. So as you can see here, the transdermal patch and transdermal gel, it doesn't carry a risk of venous thromboembolism, whereas the other one will vary between 0 to 5%. Now, most of these, this hormone therapy is not the only risk factor which is leading on to VTE. We have to look at other risk factors. As I discussed earlier, age is one factor. As age increases, definitely the risk increases. The second one is smoking. Other comorbidities like hypertension, dyslipidemia. Family history is one important factor of all these thrombophilic disorders, or a personal history of venous thromboembolism in the past. Some recent major surgery or immobilization or any central venous catheterization, obesity, malignancy, all these are risk factors for venous thromboembolism. So what to do if your patient whom you are planning to initiate on estrogen therapy has these risk factors? See, the thing is, routine screening is not actually practical or recommended for all these thrombophilic disorders. So if your patient has a personal or family history of venous thromboembolism, then you can get the help of a hematologist and do the screening. Because as such, there is no data available to support any specific thrombophilia testing in these people who have any history of thrombophilia in the past. Now again, withholding gender-affirming hormone therapy for all these people, actually you are imposing a negative mental health impact on these people. So it is actually, if you give the hormone therapy, giving it will outweigh the risk of VTE. We don't know. The risk versus the benefit should be compared, and we should never withhold the GHT is what today's recommendations are. And there is no such recommendation that you can give a primary prevention prophylaxis to these people also with anticoagulants or antiplatelet therapy. Now, so that is why if you put the risk into perspective, like there is a risk, which is relative risk is there, but the absolute clinical risk is always remaining low. All those who are practicing in this area would know, like of all these people we have treated till now, you may not have come across, even in my data of 300 trans women, I didn't have any occurrence of venous thromboembolism. So even if it is there, if you treat at least 1,000 people, you may get one venous thromboembolism. That is what data says. So now after, suppose this question was answered previously, somebody asked this, like what if your patient had a thrombosis while on gender-affirming hormone therapy? So what do you do? Immediately, definitely you have to discontinue the gender-affirming hormone therapy during the event after an acute episode, and as per cisgender guidelines of treatment of thrombosis, you have to initiate all the anticoagulation recommendations, usually with direct and oral anticoagulants, or even you can use low molecular weight heparin. And if it is a limb-threatening or such kind of thrombotic event, again you can go on for thrombolysis. And now what to do after this? After treating that initial episode of venous thromboembolism, can we re-initiate the gender-affirming hormone therapy is the question. So this is actually challenging, but Malia sir answered this question, like you can always make a shared decision making in this, because those who wish to continue the gender-affirming hormone therapy after this, and after evaluating for all those reversible causes of this thrombophilic disorders and all, those who wish to continue, actually they can reinitiate only on transdermal estrogen therapy along with oral anticoagulation. So full intensity anticoagulation should be continued along with gender-affirming hormone therapy on transdermal estrogen. Similarly, another challenging time is when these people go into surgeries, like preoperative, perioperative, and postoperative management. So usually, even in general population, actually the risk of venous thromboembolism is less than 2% during any type of prolonged surgeries. So we don't have any actual trial to demonstrate is there a difference if you withhold GHT prior to surgery, or if you continue GHT before surgery, is there any difference between the two groups? But there is a single study where before the gender-affirming surgery procedures, some people were asked to withhold the GHT 3 weeks, 2 or 3 weeks prior to the surgery, and there were another group who continued hormone therapy even just day prior to surgery. And what they found that one VTE event occurred, but that occurred in patient who had stopped estrogen perioperatively. So we don't have direct comparison trials to demonstrate the risk. What data says these days is if we take adequate venous thromboembolism prevention prophylaxis during surgery, like perioperative period, there is no recommendation to stop GHT is what the current recommendations are. We need more data into this, but what we practice these days is to be on the safer side, we do ask them to stop estrogen at least 2 weeks prior to a major surgery. So, this is how we go about the venous thromboembolism. There is definitely a risk around 0 to 5% incidence will be there, and the risk always increases with, one is the duration, more than 8 years, yes, the risk increases, increasing age, increasing BMI, smoking, and with the type of estrogen, that is mainly ethinyl estradiol and CEs pose the major risk. Higher dose again, because supraphysiological dosage, self-dosing is very, very prevalent in this population, so that again increases the risk, but the lowest risk is with the transdermal therapy. And this is how we go about before initiating a gender-affirming hormone therapy. What we do is we evaluate patient with history for the thrombotic risk factors, and also by examination also we assess the risk factors, and always use the lowest effective estrogen dose. Don't go for supraphysiological dosing, and better if there is a risk factor in your patient, if you feel that your patient has a risk factor, always go for a transdermal estrogen therapy. And in case a patient develops a thrombosis during GHT, withhold the hormone therapy for a while, do the anticoagulation and treatment of thrombosis, and then consider the risk versus benefit, and if patient wishes to continue GHT, you can reinitiate with a transdermal low-dose estrogen. So these are the recommendations. Always avoid ethinyl estradiol, and the progestins also, we don't have any data to support because it always increases the additional thromboembolism risk. So this is what the clinical recommendations are, and in future, maybe even we don't know, we need to study more about this transdermal delivery route of estrogen, because does that also have a dose effect? We don't know, we have to study about it. And the dosage, with transdermal dosing also, does it have a dosage effect? That also we have to study. And more data is needed with the role of progestins and anti-androgens also. So with that I conclude. Thank you for your patient listening.
Next, I would like to invite Dr. Shruti Chandrasekharan, and she would be talking on CV risk with androgen therapy. She is consultant Dr. Rela's hospital in Chennai, as well as IIT hospital, and she has several publications as well. Over to you, Shruti.
Thank you very much.
Thank you for joining us.
Yeah, thank you. A very good morning. It's a blessing to be here. Happy Onam to everyone. We're also celebrating Onam. I'm from Chennai, but we all celebrate Onam for Sujat today. So I'm going to be talking on the cardiovascular risk in androgen therapy among transgender individuals. I have no conflict of interest for my presentation today. So gender-affirming therapy, we have listened in the first half of this workshop, is central to the medical transition process, is a key. It improves the psychological well-being. For transgender men, testosterone-based androgen therapy is the mainstay of therapy. And it's prescribed. We heard from Pramila in the different ways it's been recommended for care, injectable, transdermal, oral, buccal effect to induce masculinizing changes. So now I'm going to be specifically showcasing on the cardiovascular outcome or what happens in terms of the CV safety with androgen therapy. But if you look at the androgen therapy specifically from the transgender perspective, this is not from hypogonadism or from the other data. This is primarily from the transgender data of use of masculinizing hormone therapy. There is a mild, very subtle increase in the systolic blood pressure of 3 to 5 mmHg over a period of 2 years. No change in diastolic blood pressure has been reported. Again, in terms of lipid profile, there are variable data. There are Japanese data which look at very differently. But the meta-analysis shows there is a slight increase in the LDL, a reduction in the HDL cholesterol, and overall an increase, a marginal increase in the triglyceride by 10 to 20 milligram per deciliter. The more recent studies have shown there is not much of difference, so the data is not very clear, but overall the meta-analysis shows a mild increase in LDL and triglyceride, and a reduction in the HDL cholesterol. There is no direct effect of hormones that has been reported with BMI. We also saw Pramila presenting about her data on improvement in the muscle mass in her group of patients, but there is no direct effect. But this is something that we should routinely monitor for our patients when they do come for follow-up. In terms of insulin sensitivity, no negative effects have been reported in meta-analysis, even in women who have PCOS phenotype. Before we put them on testosterone therapy, even in those women, there is an improvement in overall fat distribution and skeletal muscle changes, and there is no negative effect or no new onset diabetes or worsening of insulin resistance reported in patients who go on testosterone therapy for transgender. In terms of vasculature, there is a slight reduction in the flow-mediated vasodilation. Again, in terms of long-term high dose of testosterone therapy, there is some postulate that it can cause some endothelial dysfunction and arterial stiffness. The data of that is not very clear. And in terms of ECG changes, when I don't routinely monitor ECG for my patients, but this is done from a study perspective where they found there is an elevation in J point changes and changes in T wave, more of male type ECG pattern is reported. Whether this increases the cardiovascular risk or risk of arrhythmia again is not very clear. So these are the effect of testosterone androgen therapy on CV health in patients who are on transgender care. But again, more than the hormone care or the more from the hormone perspective, what is actually spoken much about the cardiovascular risk in transgender population is the non-hormonal risk for the cardiovascular risk. One is the psychosocial factors, the lack of family support, or the socioeconomic conditions of trans men. Smoking is quite rampant, so it's very important. As Pramila said, it's just not active smoking. Passive smoking is something that we see. In fact, in my practice, I see a lot of polycythemia, increase in hematocrit, where I need to go back and readdress the dose every single time, or talk to them about smoking. In fact, I had one patient who developed a cortical venous thrombosis and presented with neurological dysfunction in a major tertiary care hospital, who was also a smoker and was on testosterone with supraphysiological dose, who lost to follow-up. So it's very important that we educate them about the risk of smoking, not just active smoking, passive smoking. And none of the papers that I've studied or I looked into for the preparation, polycythemia has not been studied in great way in terms of the cardiovascular risk or the thrombosis risk in patients who are on testosterone therapy. But that is something that is very, very important. CBC monitoring is routinely done to look into the hematocrit and sort of adjust the dose and to counsel our patients. Substance abuse is on the rise, which again is very important. Sedentary lifestyle, so it's very important we advise them to regularly exercise, lift weights, have adequate protein intake, prevent all the necessary things, in terms of healthy lifestyle. Minority stress and mental health stigma has been associated with cardiovascular risk. HIV risk is very common. Again, healthcare disparities. So sometimes they just don't seek help because of discrimination or, how they are treated in the clinics or in the hospital. So that's again a risk factor for not just cardiovascular risk, but also for cancer risk and all the other complications or that we sort of talk about in our patients. So now if you have to extrapolate all these things and say, does this cause say cardiovascular event? What about this? So most of our patients will ask, ma'am, if I take this preparation of testosterone, especially when we see now parents coming for consultation or siblings coming in for consultation or their partners. I have partners, I mean husband and wife coming in for transition. You know, they usually ask what is about the cardiovascular risk, cancer risk, thrombosis risk with estrogen. So it's majority of the studies that has been done or the meta-analysis have been done have conducted for a very short follow-up. So we know we need longer follow-up for the cardiovascular risk events. And most of these cohorts were between 20 to 25 years. So the absolute risk of CV events we know rises with age and comorbidity. So at this point of time, there is no strong evidence supporting increased CVE with one route. We talked about in estrogen, the routes of administration. That makes a difference in terms of venous thromboembolism, whether it's transdermal versus oral estrogen. But in terms of testosterone, the studies that I've looked into, whether it's parenteral or gel formulation or different routes of testosterone therapy, again, I've not found any strong evidence supporting an increased CVE risk with one route of testosterone administration over another, and that's how it sort of differs from the other transgender therapy that we use. So to sort of sum it all, so CVE with androgen therapy at this point of time remains unknown for a recent transgender men undergoing strict medical supervision according to the guideline managed care. So this is the most important thing. I underline that it has to be done with the medical supervision, with the guideline managed care, with maintaining testosterone levels, not in the supraphysiological range, whichever route of testosterone preparations that we use to sort of prevent the complications. So this has to be talked with all transgender individuals in every single clinic visit, and this is exactly what I counsel when they do come for the first time, the parents, the partners, the sibling, that a regular follow-up is very, very important. And looking into the death, there is not much of death registry, but Netherlands has a death registry for transgender, comparing with cisgender men and cisgender female. Most of the deaths that were reported were due to suicide. There were no higher risk of cardiovascular or cancer-related death that were reported in Netherlands. But again, suicide were the common rate cause for death in transgender, and that's what Dr. Anirban was talking in his very first presentation this morning. So what can we do as clinicians? We need to have a proper risk assessment. So even though we are not very sure, we don't have a long-term data on this, we need to get a good history, family history, a family history of cardiovascular disease, how we do for our diabetic patients or our general population, social history, a smoking history, alcohol, substance abuse history, very, very, very important, even passive smoking, BMI, blood pressure, lipid profile parameters, fasting blood glucose, whatever Pramila had, shown in her slides of what is the first initial, the 0.0 evaluation that we do, and also screening them for fatty liver. I don't use it for all my patients, but if I do have something, I might use a FIB score, and if that is sort of abnormal, I might evaluate them for fatty liver screening as well. Periodic monitoring is very important in terms of annual reassess for major risk factors during therapy. The guidelines recommend every 3 to 6 months for the first year, and then after that, every year, patients should be followed up for blood pressure, BMI, social history, everything. So the take-home message is regular counseling is the most important thing to prevent whether it's VTE or cardiovascular or cancer risk or, any changes in the metabolic profile. So in terms of prevention, use the lowest effective dose and avoid supraphysiological testosterone dose, because a lot of our patients self-inject. They also get preparations from social media and Amazon and also take them along with the preparations that we give in the prescription. So it's always important to sort of counsel them, saying that it's not the right thing to do. That's very important to prevent supraphysiological testosterone level. Aggressive treatment, so if they have hypertension, I have a lot of my patients who are on statin, with a genetic hyperlipidemia. So it's important, we need to put them on a high intensity statin if it's absolutely required, smoking cessation, weight management, keeping the HbA1cs at 6.5 to 7. So I also have patients who are on anti-diabetic medications, insulin therapy, and also on testosterone therapy. So it's very important. How we treat the general population is how we treat them as well. So the guideline management therapy should be followed in them. It's just not the testosterone or the levels that we are looking into. We also have to screen them for the metabolic parameters. So it's very important for a shared decision making in terms of the CV risk factors. And it's important if they do have dysphoria while they're on therapy or an ongoing mental health issue that needs to be addressed, they have to be in follow up with their psychologist or their psychiatrist and have that on a regular basis as well, because that's, again, we know the risk between depression, diabetes, and the metabolic risk factors. So we need to sort of look from the mental health perspective as well in terms of addressing that upfront and also following them for the mental health problems as well. And in terms of older patients and patients with multiple comorbidities, I have patients at 45, 50 on testosterone therapy. We need a very close follow-up, and you tell them that this dose of this is probably appropriate for them. And once they attain the level, it's not very important to keep the levels of testosterone higher levels, so you can use your clinical judgment to treat them. In terms of transdermal versus intramuscular, I use both in my practice. There is no clear evidence whether you use any preparations, whether it's transdermal or intramuscular. The cardiovascular risk factor screening and counseling has to be done irrespective of the route of testosterone that you're going to be administering for your transgender patients. And as I said, regular aspirin, statin, antihypertensive, and guideline managed therapy for diabetes has to be also sort of given priority. So what are the existing gaps in therapy? We don't have long-term data. That's perhaps something we could work from India in terms of collecting our data to see what happens in 10, 15 years for our trans women and trans men in terms of VTE and cardiovascular risk and also malignancy risk and all the other risk factors that we talk about. And in terms of confounding factors, in terms of social determinants, psychological stress, health access, again, might impact the study finding that, again, would differ from one state to another, even though each state government has doing a lot for the transgender community now in terms our government hospitals are coming up with programs in cardiovascular and cancer screening for these patients. It's important that we also sort of address the health access for our patients. And in terms of quality of evidence, again, we need a longer data, and many studies are mostly retrospective. And again, there are heterogeneity in hormone regimens and insufficient controls for the confounding factors that I mentioned about. So with this, I finish by saying testosterone therapy moderately worsens the atherogenic risk factors, but absolute cardiovascular event risk remains unknown. Routine cardiovascular risk monitoring is essential. The majority of the risk is modifiable. It's mostly non-hormonal. Informed shared decision-making and individualization of therapy and monitoring remains the best practice in any medical care, including transgender care, and these are my references. With this, I thank the organizers for giving me this opportunity. Thank you.
Thank you, Shruti. Can you please join us here? And now I'd like to invite Dr. Kaushik Sen. And Kaushik is an associate professor in the Department of General Medicine. And he's going to talk on the estrogen therapy on bone health in adult trans women. So over to you, Kaushik.
Thank you, sir. Good morning, respected organizers, my chairpersons, and all the delegates present here. It's really a privilege to be present here. I thank Dr. Debmalo Sannal, Dr. Anirban Majumdar sir, and all the others for inviting me. I'll be presenting, as Dr. Majumdar has mentioned, estrogen therapy on bone health in adult trans women. That's the bone accrual process all through our life. It starts from the fetal life, goes on to the elderly age. As we all are aware of, about 60% of bone accrual occurs at or just after the attainment of puberty. After that, up to the late 20s, it increases, where to reach a plateau, and then after the late 20s, gradual decline occurs in both men and women. However, in immediately post-menopause, there is a sudden drop in the BMD again, then it again plateaus to go on to the end of life. That's the normal bone accrual throughout our entire lifespan. In the sexual dimorphism, prior to the puberty, there is hardly any difference between men and women in bone geometry. Then start the role of estrogen predominantly in women, testosterone predominantly acting in men. At the end of the puberty, the men bones are larger, meaning thereby they are longer and wider. However, the cortical thickness in both men and women remains nearly the same. The cortical thickness is a difference between the pericortical diameter, as has been shown here in A, and the endocortical diameter, as has been shown here in B, but the difference remains the same. The volumetric BNP is similar in both, nearly in all the cases. Now, regarding the effects in physiology of estradiol in the bone, the traditional belief was it actually acts on the trabecular bones. However, later on it was conclusively proven that it does have its effects on the cortical bone as well. There is slight difference between the physiological and the pharmacological dose. At higher doses, it suppresses all the bone turnovers. Here is a data about 10 years ago when they tried to assess what happens to the trans women before the beginning of the GAHT into the therapy and up to the 10 years or more into the therapy with GAHT with estradiol predominantly. This is on our left-hand side. We have data from pre-GAHT. It shows a reduction in the BMD that can be attributed to several factors, including lack of proper nutrition, lack of proper exercise, as well as the significant emotional and psychosocial stress. However, into 2 years of GAHT with estradiol, there was improvement in the BMD, predominant in the lumbar spine, but that could not bring back it to the normal value. There are reasons behind that, possibly suboptimal estradiol dosage, and at or around the time of puberty, the role of different addictions. These are mostly the Western data. The role of smoking, substance abuse was also contributory. But it was later shown when these same individual group were followed for a period of 10 years, there was no further improvement, even with the continuation of the GAHT, and possibly a hint at the end towards a decline of BMD. That was a data about a decade ago. Now, people try to assess the safety of long-term GAHT on bone. This particular trial tried to assess whether it has got any relevance with the estradiol serum level. And they divided the serum estradiol level into 3 tertiles. It was shown over a span of 10 years of follow-up. The individuals, trans women who had maintained the lowest tertile had actually shown a decline towards the end over 10 years, in contrast to those who are maintaining the mid or highest tertile of the serum estradiol level. So with that, possibly scientists tried to assess the role of dose dependency on the bone health. This is a couple of years back from EJE. They tried to formally assess the role, prospectively, the dose-dependent effect of estrogen on bone mineral density in trans girls. They had taken 3 specific dosage forms, the oral 17-beta estradiol, gradually up-titrating to 2 milligram per day. Another group, in each group there was around 230 trans women. The second group was treated from the very beginning with 6 milligram of oral 17-beta estradiol, and the third group was being treated with ethinyl estradiol. We all know there have been several discussions that ethinyl estradiol is no longer recommended for the increased risk of venous thrombosis in this particular group of individuals. But this study had assessed them with ethinyl estradiol at a dose of 100 to 200 microgram per day. It was shown that at the end of the follow-up, those who were on 6 milligram of oral 17-beta estradiol, their BMD had improved more compared to those who were on 2 milligram per day of 17-beta estradiol. This one is a graphical representation. As we all are aware of, the last 2017 Endocrine Society guidance, as well as the IDEA consensus that got published in IJEM 2020, had suggested the serum estradiol level to be maintained between 100 and 200 picogram per ml. However, this particular study had assessed estradiol level in picomole per liter. For the ease of understanding, I have given these 2 green bars that we should be able to maintain serum estradiol level between these 2. Now, as is shown here, the individual group of 230 individuals, trans women who were on 2 milligram of 17-beta estradiol could never achieve the range that is desired, whereas those group who were put on 6 milligram of 17-beta estradiol had actually exceeded the desired level of serum estradiol. So they had suggested possibly a dose in between 4 milligram of 17-beta estradiol would be appropriate in maintaining bone health as well as maintaining serum estradiol level within the desired range. Here we do not have data of serum estradiol in those group of individuals who are put on ethinyl estradiol because that cannot be measured. Now is another one published a couple of years back, a conflicting data. I would suggest that all the data that is available even today are very, very diverse. Some had shown improvement in lumbar spine, some had not shown improvement in lumbar spine, like that, very diverse data. This particular trial on our left-hand side had shown, after initial reduction post-GnRH agonist therapy, the lumbar spine bone density could never improve over a span of 10 years. And others, the total hip and femoral neck had actually shown an improvement mostly towards the end of therapy. There was a short term, 5.3 years. There was a long term, 11.6 years follow-up in this particular trial. Towards the end, both total hip and femoral neck had shown some improvement, but the lumbar spine did not. So also, in keeping in mind the bone accrual process that I had discussed in my first slide, there was a suggestion whether age is one of the major determinants in the bone health in trans women. This study was published last month only, had assessed over a span of 1 year only if there is any improvement in the BMD. On our left-hand side, we can show that compared to the baseline value, the initial 1 year follow-up had shown some improvement, and that was statistically significant in the BMD, but others, the total hip and femoral neck, did not show any significant improvement. That's the overall data. But when they stratified the data based on the age at which the GAHT was started, it was shown on our right-hand side of the diagram. This was BMD of the spine. On our left-hand side of the diagram, this was BMD of the neck of femur. In both these, the improvement that is shown in individuals when they were started in less than 20 years of age. So that has been given the name as window of bone plasticity, possibly the time at which the bone health can be maximally improved with GAHT. Now, as I've just mentioned, the data is very diverse, so people tried to perform meta-analysis, but this group of researchers tried to assess the meta-analysis but could not do it because they say the data is extremely heterogeneous. So they had gone for a narrative review, but that has been shown that in most of the longitudinal follow-up trials had shown some improvement in the lumbar spine BMD. Whether given the BMD values, whether the fracture risk can be calculated, well, there are very, very little data overall on the risk of fractures. This is possibly the largest data that is available from Netherlands. That shows overall there is no increase in the fracture risk in trans women, but when they stratified the data according to the age of these trans women, when they had taken individuals less than 50 years of age, the trans women had more risk of fractures compared to the cis women. But when the age cutoff was increased to beyond 50, the difference between them is no longer there. They become almost equal. The fracture rate in trans women compared to fracture rate in cis women are similar. Possibly the main contributor in cis women increasing fracture is the postmenopausal osteoporosis, as they had suggested. That's the different guideline, Endocrine Society 2017, the last one, ISCD, the International Society of Clinical Densitometry Guidance as to whom to perform BMDs. The Endocrine Society 2017 had suggested at the beginning of GAHT, and after that post-orchidectomy, yes, if the individual is not adhering to therapy or is inconsistent or is not willing to continue therapy, for them assessing BMD is a must. I'm sorry, there is a technical glitch from that side. Yeah, possibly we are here. Now, while assessing the BMD Z-score, whether we should be using gender assigned to that individual at birth or that individual's gender identity is remaining till date a matter of debate. However, the ISCD official position statement of 2019 recommends that they should be calculated using the normative database that matches the gender identity of the individual, but they do also mention if the ordering provider suggests, one can also use the gender assigned at birth. So that remains still a matter of debate. The main reason behind that is most of the gender incongruent individuals present to the prescribers at or after the attainment of puberty, when most of the bone accrual has already happened, and that is in accordance to the gender assigned at birth. So that yet remains a matter of open debate. That's a ISCD recommendation, as I have just mentioned. Regarding the fracs, we do not have any meaningful data till date who had assessed fracs. So no scientific comments can be made on this regard, whether fracs can be calculated. In most of the occasions, FRAX is calculated with the gender assigned at birth, but possibly a better approach would be to assess with both gender assigned at birth and the gender identity of the individual and take some intermediate value till better data set becomes available. That is yet a matter of question. Now the single meta-analysis, because the data is so diverse, the single meta-analysis in this regard is from 2017 JCEM with 13 studies taken into account 247 individuals. That had shown at the end of 1 year and 2 years, there was a significant improvement in the lumbar spinal BMD compared to the baseline values. That's possibly the single meta-analysis on this regard that is available today. Another one is in preprint, so that I have not shown that in this presentation today. That's from UK. The data is yet to be available in public domain. I'll finish off by possibly the single data set that is available from India in this context, from Dr. Pramila Kalla et al. Fortunately, madam is here with us today. They are tested with 30 trans individuals. Among them, 16 were trans women. They studied only with estradiol validated, because goes without saying we do not have any other preparations. Transdermal estradiol is no longer available in India. And among them, very important revelations were there amongst the trans women. There was significant percentage of individuals who had low vitamin D levels. So that needs to be taken care of. And as I had just discussed, there was suggestions in which dose of estradiol level could be a determining factor. This particular study, they had tested with 4 milligram as well as 6 milligram of estradiol validated and found no difference between these two dosing sequence. With that, I'll come to the last slide of my today's presentation. Transgender women, lower bone mineral density prior to the start of GAHT. Estradiol may improve or at least slow the decline in BMD, but possibly does not bring it back to the baseline values. DEXA is a preferred tool. However, appropriate reference range for Z-score is still debated, whether a gender assigned at birth or gender identity should be used in Z is a matter of debate. Limited fracture data, FRAX is not yet validated. Taking into everything account, a healthy lifestyle, compliance, strict compliance to the GAHT, and possibly a higher estradiol dose would help in improving the bone health in estradiol-treated transgender women. Thanks for your patient hearing.
Thank you, Kaushik. Can you please join us here?
Thank you.
So I would like to open the this forum for any question. So anybody have any question? So yes. So Professor Bhasin here. Okay, sir.
Thank you. I want to congratulate the speakers for their very thoughtful and nuanced presentations. I had a question related to the risk of venous thromboembolic events, both during the gender-affirming masculinizing as well as the feminizing effects. One of the concerns about the available data in trans-masculine and trans-feminine people, as has been pointed out, is the very small number of events because of the small sample size in each of the studies. But we've looked at the Veterans Administration database in the US, which is, Veterans Administration is one of the largest providers of health care for transgender people in the US, with 28,000 trans people. And in that, these data are unpublished by my colleague Gunit Josija. Both trans men on masculinizing testosterone treatment and trans women on feminizing estrogen treatment had very high risk, substantially increased 10 to 20-fold. And in addition, many of the trans men and trans women have additional risk factors which further increase their risk. So in subsets of trans men and trans women who have 2 or more risk factors, the risk is increased almost 10 to 20-fold. So I think, you know, in your presentation, I think you were recommending consideration of prophylactic DVT. I think that's an important issue to discuss. So the cardiovascular risk, it's the same issue that we really don't have sufficient number of events in any of the studies to have enough statistical power, and that concern also persists.
Yes, sir. Thank you, sir. Definitely, because in that largest database, I think the previous years, previously we used to use more of ethinyl estradiol as the estrogen therapy. So that had a more prevalence of VTE, and later when it was switched on to more safer alternatives like estradiol valerate, the incidence has come down. And with androgen therapy also the risk remains. The risk of thromboembolism remains, especially with this polycythemia, as Shruti was telling, because we don't have data to correlate between the incidence of polycythemia and VTE. We have to look upon those kind of things. And from India also, we don't have much of these data with regards to the incidence. And even in cisgender population also, the risk of VTE is there during in women, cisgender women, especially during pregnancy, postpartum. Similarly, during perioperative, preoperative period, in general population also, the risk is there. So as Sir rightly pointed out, the prophylaxis, preoperative, perioperative period is very important, and screening those people with higher risk factors is very important. Thank you, sir.
Professor Bhadata, please.
Yeah, Dr. Suja, so you, in your clinical practice, do you do the coagulation profile in advance before starting the estrogen therapy or this?
No, sir. It's not practical and it is not recommended also.
Or not cost effective, it is not cost
Yes,
effective.
Sir. Even in patients with history of previous history of venous thromboembolism or any family history of thrombophilic disorders, actually supposed to screen them. That also we don't have a particular definitive protocol to evaluate. So it is better to get a help of a hematologist to evaluate in such a situation before initiating.
If I may add, I also don't routinely use coagulation markers, but I have a patient who self-checks D-dimer every visit. I don't ask for it, sir. So she self-checks, but there is no data for D-dimer monitoring as well. The studies have looked into D-dimer for monitoring for VTE risk, and they have not found any correlations on the levels as well. So routine screening is not indicated. I've told her multiple times, but she still would get that checked on her own, but no clinical outcome data on that as well.
Dr. Kaushik, nice talk. And do you recommend that for the bone health purpose, vitamin D supplementation adequate goes without saying, but I think we should mention that, as well as the good physical activity, that is yes, because they are depressed and most of them are not busy with that. That will help in the bone health as well as the metabolic syndrome issues, so that we can make a part of our treatment while writing this one.
Yes, sir, absolutely. Yeah. Absolutely. Thank you.
Thank you.
Sir, taking the cue from your question that regarding the venous thromboembolism, if we see the death across the globe and including our country, 1/3 mortality is because of cardiovascular death. We all know it. And among this 1/3 mortality, 1/3, it means roughly around 10-12% is because of some thromboembolic disorder. So it means the thromboembolic disorder is very important cause of death. Not the patient, those who are taking estrogen or testosterone, but across the population. So therefore, any kind of thromboembolism is a very important concern in front of us. Now, coming to the hereditary thrombophilia, the people have tried to look into those factors. And there are studies on trans population to look into that if we evaluate those factors, and if we design the estrogen therapy on the basis of that, and they found that there is, even if the factor 5 laden is the most common variety, even if you look into it, estrogen therapy or no therapy, and whether you have looked into or not looked into, the effect is almost same. So till date, we don't have any robust data. I don't know if we have more robust data, then possibly we'll come to know that whether we should need a screening before we starting the estrogen therapy or not. Till date, as Suja said, there is no any recommendation.
My question is that, is there any sort of screening or receptor study or any genetic marker for trans women who are on estrogen therapy, so that the high risk group can be detected early?
No, sir. Sadly, we don't have any such data on that. Only in known cases like previous history or family history, we can do such study.
Family history is the risk.
Yes.
Yeah. Thank you.
As we are discussing the estrogen and testosterone therapy, just a little curiosity placed to the august panel of speakers. What is the present status of SARMs? Is there any ongoing study on Indian population?
Oh, no. We don't conventionally use any SARM in the. No, not at all. Because SARM has been developed for the bone health, rather than giving more estrogenic effect or what we are looking for, that is the breast development and skin changes and feminizing effect. So it was basically developed to look into the bone health. Yes,
and also the thrombotic risk is not decreased at all. So that's also an important concern.
So, okay, if there is no any further question, I think we would like to conclude the session here, and thank you to all the panelists to do a very beautiful job, an excellent job. And with this, I would like to hand over to Debmalo Sanyal to conclude the session.
Thank you, and we had an excellent session. I would like to thank all the speakers, Dr. Shuja Kumar, Dr. Shruti, as well as Dr. Kaushik Sen for excellent talk and also excellent interaction. Thank you very much.
Okay, for the next session, we will be delighted to have Dr. Kaushik Pandit sir as a chairperson.
Good morning. Welcome once again. So now we'll have a sort of panel discussion, transgender medicine, a multidisciplinary approach for endocrinologists. And I have got the privilege to be the moderator, not the chairperson. I'll be sort of moderating the session, will be the bridge between the expert panelists and the audience. So let us start inviting our expert panelists into the dais. May I request Dr. Pramila Kalra? She is professor and ex-head of endocrinology of Ramaiah Medical College and Hospital, Bangalore. She is a renowned face in the whole of ESICON or the endocrinology fraternity in the whole of the country and beyond. Let us invite Dr. Shubhadeep Pramanik. Shubhadeep is a renowned face in this part of the country. He is a renowned endocrinologist in the eastern part, based mostly in Siliguri, but very frequently visits the city. So we have got the privilege of interacting with him quite frequently. Professor Debmalo Sanyal, I guess no words are needed for him. It's just to say that he is one of the pillars of this organizational capacity of ESICON 2025. Dr. Shuja Sukumar, she is a consultant endocrinologist at Renai Medicity in Cochin. She has already been introduced and you know her mettle. Professor Anirban Majumdar, once again needs no introduction at all. Dr. Shruti Chandrasekharan is also known to this audience. She is a consultant in Dr. Rela's Hospital, Krompet, Chennai. And we'll also have the privilege of having Dr. Shumik Sen, who is a legal expert He's a professor at the West Bengal National University of Juridical Sciences, Kolkata. He specializes in constitutional law, sports law, and media law. And he was part of the inaugural graduating batch of NUJs in 2005, so quite long ago. He has got quite a good amount of experience in this field. We are all awaiting eagerly for Dr. Shomik Sen's arrival. So without further ado and not wasting any time, let us go. Next slide, please. So we'll have these 7 specialists who will be dealing with 7 different aspects of the problem. Like Dr. Pramila Kalra will be talking about adolescent with early gender incongruence, where we'll have to use puberty blockers. What will be the decision-making tree there? Dr. Shubhodip Pramanik will be on fertility preservation options for trans women. Dr. Devmala Sanal will be talking on adult trans women with CAD and history of DVT, HRT challenges. Dr. Shuja Shukumar will be talking on trans man planning pregnancy, crossroads of testosterone withdrawal and fertility. Dr. Anirban Mujindra will be talking on non-binary person seeking partial medical transition. Dr. Shruti Chandrasekharan will be talking on assessment for readiness before the gas. Dr. Shomik Sen will be talking on the legal rights, NALSA judgment and transgender persons on Act, the legal act on 2019. So we will start with Dr. Pramila Kalra with adolescent and early gender incongruence, puberty blocker decision. So we'll start with a representative case. A 13-year-old assigned male at birth presents with persistent gender incongruence since early childhood. The adolescent identifies as female, has been expressing this consistently for the last 4 years, and experiences distress with the onset of pubertal changes such as voice deepening and increased body hair. The parents are supportive but are concerned about the long-term implications of the medical treatment. The child has no significant past medical history and is otherwise healthy. Mental health evaluation confirms gender incongruence and associated distress, but no other psychiatric comorbidity. TANA stage on examination is found to be 3. The family is seeking your guidance on whether to start on puberty blockers, that is mostly GnRH analogs. So can I ask Dr. Kalra about what are the clinical criteria for considering puberty blockers in adolescents with gender incongruence? Dr. Kalra, please.
Yeah, so this is a very important aspect because now we are seeing more and more children being brought to us for puberty blockers. So this is a very, very important question because we are getting children at the age of 13, 14 who are being brought to us by the parents because they have been having this gender incongruence or gender dysphoria for quite some time. And now the parents come to us because the child is insisting or the parents have read about it and there are multiple reasons they come to know and then they come to us. So now if we see this type of a case scenario where it's a 13-year-old male who has a Tanner stage 3 already, so that means the child has already entered puberty. So what happens in children when they enter the puberty? That's the time when the dysphoria all of a sudden increases. So this child has been not feeling okay and wanted to be as a female, and this has been there for almost 4 years. So in children it is very important that we don't diagnose with a short duration. So it has to be a long duration. That is the first important thing. So they need to have this for a long duration, and just not that they don't want to be like that, but they should have severe distress with their body parts. They are not okay with the pubertal development because now this child is developing the male characteristics, and that's why the child has become more dysphoric, and that's the reason the parents have brought the child. And also we see that patient is consistently wanting this for past 4 years. So the long duration is the most important thing. We had cases where the parents thought that the child is not comfortable with the gender which is assigned to the child at birth, but many a times when we go deep into the history, we found that that wasn't the case because the history was very short. So the history, most important in children is it has to be long duration, which is there in this child. When we are talking about the option of puberty blockers, it is after Tanner stage 2. So this child is already in Tanner stage 3. So this is also there. And along with that, if you see, this child is persistently expressing the desire to be a female. Now we are aware that if we don't start the puberty blockers at this point of time, this child is definitely going to have more distress, more dysphoria, because the child is going to develop the secondary sexual characters of a male. Now the parents have definitely come to you because they are worried. Now they want to know many things. The first thing, most of the times I see that the parents are worried about fertility. That is the first question they ask. After that, they ask about growth. After that, they ask about that how the child will adjust to the others, because the other children will develop puberty. Now, I'm going to give puberty blockers, this child will not have puberty. And what will happen in the long run for the child's mental health, psychological health, metabolic health, and cardiovascular health. So the first question is the question of the growth. Now we know that when we add the puberty blockers, we may have a problem with the growth spurt. We know that the child's growth spurt may be retarded. The growth of the secondary sexual characteristics will not happen. So the child may not feel okay in the school because other children will develop puberty. Now this child will be looking like a kid. So that is another problem which we see, because we are not going to give them the gender-affirming hormone therapy at this age. But this is the first counseling we have to do, tell to the child and the parents. Then we know that because the child is in Tanner stage 3 and we are going to intervene and we are going to halt the puberty now, at the age of 18, if the child persists to be gender incongruent, we are going to give the gender-affirming hormone therapy for a female. Estrogens will be started. Now this child will have fertility issues, so we can't do the sperm banking for this child. So that's another thing which we have to counsel the parents, because the parents may not be ready for this thing at the moment. So that options or what can be done has to be discussed with them. Also the bone health, because we know that this is a bone building age. Now we are going to give puberty blockers, so there will be problem with the bone development. We have to see the calcium and the vitamin D intake is good. We have to tell them that there may be issues with the bone development and the final bone strength may be affected because there will be a delay, and we have to follow it up with the bone mineral density or the DEXA in case if it is needed. We do a baseline and then we decide when to follow up. Also, this child may have issues also with the metabolic parameters or not. That answer we don't have, because we don't know that if the puberty blockers are started and later the child is put on estrogens. As of now, we don't have very clear data on this. But we can say that we will monitor and we will see if there is any side effect, we'll treat accordingly. That is how we answer, because that data is not very clear with us. But we counsel them about lifestyle modification, exercise, and to do regular follow-up with the doctor. That's also very important. And also when we talk about puberty blockers, we also tell them that this is a reversible form. Because when we give the puberty blockers, in case further the child is not a persister and decides not to progress with it at the later stage, we can always stop the puberty blockers and the natural puberty will set in. But in case at the age of 18, which is a legal age in our country to start the gender-affirming hormone therapy, in some countries it is 16, but in our country it is 18. So we can, after that, decide about whether to start or not as per what the child decide when the child becomes an adult. At this point of time, we have to take consent from both the parents and assent from the child. That's the most important thing, because the parents have to sign. Now, we had instances where the parents were divorced. Then what to do? So then I asked our legal team and they said that one of the parent who is the caretaker of the child can sign, and that should be okay. But they have to put the divorce agreement and say that the father is not taking care.
Yes, Dr.
Because that also is a big problem. So that is a very, very important
actually
issue.
a very, very good answer and a very elaborate answer on various issues like the short-term benefits of this treatment and the potential risks that one can have regarding the concerns about the bone health, fertility, and the neurocognitive development. Can I have a short and quick take on, say, what are the ethical considerations when making decisions for these adolescents?
Yeah.
The ethical considerations that we'll have to think of.
So what are the you want me to go with this fertility preservation or the previous?
I mean the ethical considerations of this treatment.
Okay, ethical.
Yeah.
So the ethical problem is that, like we are asked many times by the parents, is this right? That is a question one of the father asked me. This child was brought to me, this was a trans female only, and the child was brought to me at the age of 14 and a half. The child is in severe distress to the extent that child is not going to school also. So the father asked me that why can't you start the gender-affirming hormone therapy? Now the question is that we have the clear-cut guidelines in our country that we can only start it after the age of 18. Starting the puberty blockers and the child not getting the normal puberty is still okay, because we know that this is a reversible form of therapy. So ethically, if we are sure of the diagnosis, that's the first thing. Child wants it, the parents are okay, and you know that this is the correct diagnosis, then ethically we are not wrong, because this is as per the guidelines. But in the case that if the child decides at the age of 18 not to go ahead with it, we always have the option of stopping the puberty blockers and the child will have normal puberty. But we have to tell them few things, like I told about fertility preservation. There will be problems in the fertility. There will be problem with the growth also. There will be problem with the bone health also. Now 10 years down the lane, if this child has some poor bone health, now this child may not understand today. I had children whom I have treated with puberty blockers, and at the age of 17 and a half, they all of a sudden decided that no, this is not the thing which I wanted, and I want to live like what I was, and please stop the blockers, and I don't want to go ahead with the gender-affirming hormone therapy. So the ethical considerations are very difficult to answer here, but we have to see the pros and cons. As a health practitioner, our job is to do the right thing. If you think it is ethically correct, do it ethically. If you think it is not, then tell it is not. I tell many parents, because there was a mother who was a psychologist, and she herself made the diagnosis of gender incongruence in the child. And she said she had three girls, and she wanted one male child. And she said, my elder daughter wants to go to the restroom for males, and she wants male thing, and she was dressing her up as a male. And when I talked to the child, she said that I don't want this dress at all. I want a female dress, I want to wear a frock, but my mother is not bringing it for me. So the mother was forcing it on the child. And she was adamant that you start the gender-affirming hormone therapy, this is a boy. So then we came to know that, and she was saying, I'm a psychologist, I have made the diagnosis. So we have to be very careful. As a health practitioner, talk to the child separately, not like you're closing the door and talking. Talk to the child with your nurse or with whosoever you're comfortable, like whosoever has to be there as per the gender of the child. And then you also see what the child wants, because sometimes the parents may be pressurizing the child. So you have to be very careful with these aspects also in India.
Thank you very much. Thank you, and giving us such illustrative examples of anecdotes. Next, I'll come to Dr. Subhash Pramanik to talk about the fertility preservation for trans women. Here is a case vignette. A 22-year-old trans woman, assigned male at birth, presents to the endocrine clinic to begin estrogen plus anti-estrogen therapy. She has identified as a woman since mid-adolescence and has strong dysphoria related to facial and body hair. She is in a supportive relationship with a man and would like biological children in the future, but is unsure about timing. She has not undergone any medical or surgical transition. No significant medical history, body mass index of 23 kg per meter square, non-smoker, not on testosterone suppressing medications yet. She is seeking advice on fertility preservation before starting on gender-affirming hormone therapy. So I will request Dr. Subhash Pramanik to answer in short, should fertility preservation be completed before starting gender-affirming hormone therapy in this case? If the patient needs urgent dysphoria relief, how do you balance mental health benefits versus fertility preservation yield?
So yes, this is a very important aspect for a gender-affirming hormone therapy. Here this patient is a trans woman, so by birth is male. So for fertility preservation, we need to do sperm preservation, obviously. And as you can see in this patient, he has not been started with any testosterone suppressing medication as of yet. So if you see the WPATH guideline, the Endocrine Society guideline, even the IDEA guideline, everyone do recommend that yes, if we are planning fertility preservation, and we should, that must be done before starting the GHD, right? So in this particular patient, this is the perfect time where we should counsel and do whatever is required for fertility preservation. But at the same time, we have to understand that that can cause distress. Although taking sperm doesn't take a lot of days, only 2 to 7 days abstinence is enough, and they can give the sperm and preserve it. But still, if your patient is very much concerned about the gender incongruence, we have to counsel the patient that these things are required in future. If you wish to have a baby, then you can use this semen sample. However, some of the patients are not very keen to take fertility preservation techniques because of many issues, maybe cost issue, maybe time issues. There we need to do the counseling, but at the end of the day, it's the patient autonomy which is important. If the patient desires, no, I want to take the hormone therapy today, do not want to preserve fertility, we have to document, but we have to abide by the patient's choice. However, with some of the patient, we can offer bridge therapy, because if they take 7 days or 1 month even, we can give some bridge therapy where their gender incongruence symptoms are suppressed, but adequate time for fertility preservation.
Nice. Say, in this situation, you have given us a very good discourse on how to provide bridging care. If the patient wants to have a fertility preservation now, what are the documentations needed? Now, can you please tell us in short, I mean, if the patient decides to go for fertility preservation after starting, say, GHT, what do you tell patients about the reversibility of gender-affirming hormone therapy, related infertility, and realistic chances of recovery after a hormone pause?
Yes, so this is also a very important case because many patients do not want to preserve semen before starting the GHT. And often they change their mind after 4 years, 5 years, 10 years down the line. That time they feel they should have biological children, right? So historically, most of the guidelines do recommend that after starting GHT, the fertility chances are reduced. But recently, new papers are coming up that what happens...
Professor Shamik Sen.
Yeah. Listen. So we're discussing that what happens if we stop GHT, that is the testosterone blockers, whether the fertility brings back or not. So 2 years back, a paper was published. 9 patients were trans women on GnRH analog. The therapy was stopped, and they are followed up with semen analysis. And it was seen that as early as 3 months after stopping GnRH agonist, this patient had resumption of sperm production. And in the end of 17 months, 3 to 17 months, 9 out of 9 patients had sperm in their semen. So that indicates that there is still some reversibility if you stop GnRH agonist in those patients who are already on GHT therapy. And there is always a chance for future fertility in those particular patients. Although we have to counsel that the chances are pretty low as compared to if we do the thing at the very beginning.
Thank you very much.
Thank you.
Excellent answer. Now, may I request Dr. Deepmalla Sanyal to talk about, say, adult trans women with coronary artery disease and history of DVT, HRT challenges. He had already talked in some issues related to this one in his actual lecture. Now, let us give him a case vignette. A 45-year-old trans woman presents for continuation of gender-affirming hormone therapy. She socially transitioned 8 years ago and has been on oral estradiol for 6 years. Her history is significant for myocardial infarction at age 42, percutaneous coronary intervention with stent placement, hypertension, and type 2 diabetes mellitus. She also developed a deep vein thrombosis in her left leg 2 years ago, treated with anticoagulation for 6 months. Currently, she is on aspirin, statins, metformin, and an ACE inhibitors. She strongly desires to continue gender-affirming hormone therapy for psychological well-being and gender congruence, but is aware of her medical risks. Now, how do you approach hormone therapy in a patient with CAD with previous DVT?
So, if you see this patient, very important history. So that's why we need to individualize therapy. So you have a 45-year-old patient who is presenting to us. So per se, after the age of 45, even if the person doesn't have previous history, we need to consider transdermal hormone estrogen therapy because that is considered to be safer. Because age is one of the important risk factors. Again, another important risk factor is the male gender at birth. So that also increases the risk. So these are two important risk factors which are already prevalent in this person with regards to them. They should be on transdermal hormone therapy. Not only that, these are the people, especially 45 years and also male, where they are candidates for primary prevention as well, for prevention of cardiovascular disease as well. But in this person, and the patient is already on estradiol therapy for about 6 years. So the data suggests, as has been elaborated previously, that patients who are more than 37 years or 40 years and on estrogen for 56 months or at least 5 years, their risk of DVT increases. So long-term estrogen and also after the age of 40 years increases the risk of DVT. So basically, if you look at estrogen therapy, though there is no additional atherogenic risk with estrogen, but there is a risk of hypercoagulability as well as deep vein thrombosis with estrogen therapy. So after the age of 45 years, we definitely need to move ahead with transdermal preparation. And in this person, with a past history of cardiovascular disease, with a past history of DVT, so if the patient is already on background aspirin, statin, metformin, and AC inhibitors, so we need to, if the patient wants to continue the gender affirmative hormone therapy, the patient need to be on transdermal preparation, which could be either in the form of patch, or in our country there is also the option of the gel preparations as well, which are both available, and with the appropriate dose. Now, with regards to this age, we would like to use at the lowest possible dose, which would maintain the patient, especially from their gender incongruence, the dysphoria can be addressed. So we don't want to really target the cisgender level at this point of time, at this age, because the patient is already having a background risk. So basically we would go with the lowest possible dose, which addresses the dysphoria and also decreases the cardiovascular risk as well as the deep vein thrombosis. We need to also evaluate for other secondary causes of deep vein thrombosis. Here a genetic screening may be appropriate as well also, and if required, the patient may be also on anticoagulant therapy as well to prevent recurrence of deep vein thrombosis as well. So these are separate aspects which we need to assess, analyze with regards to treatment, not only with regards to gender affirmative hormone therapy, but also with regards to cardiovascular risk and DVT.
Excellent. And in your earlier lecture, you have also given us some insights about the evidence regarding the different estrogen preparations, especially oral versus transdermal versus injectable. So now here in this critical situation, can you give us a little bit of an idea about what are the roles of the anti-androgens, spironolactone, or for that matter GnRH analogs, in reducing estrogen dose requirements in such patients?
So especially if we see with regards to if the patient has not undergone any orchidectomy, as we have seen, we have published data that patients who have either undergone orchidectomy or on GnRH therapy, they would be requiring much lower dose, and that is also, there are also other published data as well. So if for average dose would be around 6 milligram per day with a patient who is on anti-androgens, vis-a-vis with GnRH or previous orchidectomy, it would be around between 2 to 4 milligrams per day. So a much lower dose of estrogen would be required. That would also significantly lower the risk of any future events, especially with regards to DVT in this patient.
Yes, and we also know the risks of the medical complications in such a situation. So can I just ask you, what monitoring strategies would you recommend in this patient, like lipid, coagulation factors, et cetera, and imaging, et cetera, whatever that is needed, in a quick take on that one?
So with regards to that, we generally, in this patient, we would be doing, apart from the lipid levels, where we would be targeting probably the LDL cholesterol to a level at least less than 55 or even lower. And we would also be probably doing a D-dimer assay also, and if required, we may start on anticoagulant therapy as well.
Thank you very much. So we would go to Dr. Shuja Sukumar to know something about trans man planning pregnancy on the crossroads of the testosterone withdrawal and fertility. Now, let's start with a case vignette. A 28-year-old trans man, assigned female at birth, has been on testosterone therapy for 4 years. He is in a stable relationship with a cisgender male partner and now wishes to conceive. He has achieved amenorrhea since starting testosterone, and last menstrual period was more than 3 years ago. He is concerned about stopping testosterone, its impact on his gender dysphoria, and whether his fertility will return. He is otherwise healthy with no significant medical comorbidities. Now here in this situation, how is the reversible fertility after prolonged testosterone use in trans men?
Okay, sir. Thank you for the question. So in this particular gentleman, as you can see, he has been on testosterone for past 4 years. So mostly, see the data with fertility preservation after years of testosterone therapy, we have data from mostly from the first thing I will say about this, what happens to the reproductive tract of female, biological female, after taking testosterone for longer periods. The data is mostly from the resected specimens after the gender-affirming surgeries in these patients. What they have seen is the uterine and the endometrial and the ovarian features are mostly resembling a PCOS type of morphology in these individuals. And there are data suggesting that the ovarian reserve in these individuals are quite comparable. Those who have been on testosterone are quite comparable to those with cisgender females. That is, the ovarian reserve is not actually decreased after taking testosterone therapy. The second point is that there are case reports of unplanned or accidental pregnancies of trans men who are taking on testosterone, meaning by that their ovulation or testosterone is not a real contraceptive which will prevent complete ovulation in a transgender male. So, by this, and there are recent reports, case reports, actually 2 case reports have come recently where this oocyte retrieval and has been done without even stopping testosterone. So the menstrual cycle, resumption of the menstrual cycles after stopping testosterone, that happens usually within the initial 4 months, 6 months itself. Many people, like around 8% of people, within the first month itself, it starts, the menstrual cycles. In the first and second month, almost around 40 to 50% will resume menses. So it takes only that much time for the resumption of menses to happen. So it's not very difficult even if the patient has been on a long-term testosterone therapy, we can ask the patient to stop the testosterone therapy for a while and give them this ovarian stimulation protocols and do the oocyte retrieval. And the new case report is actually very assuring that we don't even have to stop testosterone. That is, during testosterone therapy itself, they can do the stimulation and retrieve the eggs.
Yeah, thank you very much. That's an excellent answer to this. And I understand these are very critical points. Many times they are not discussed in the textbooks. And I can also give you a question which is not often discussed or not often encountered in the textbooks. I mean, how can, say, the clinicians support the trans men coping with worsening dysphoria during pregnancy?
Yes, sir. That is very, very, very relevant because initially itself, the best time for any fertility preservation would be before initiation of a gender-affirming hormone therapy. But most of these people, when we give them the fertility preservation option, only less than 10% attend this counseling, fertility preservation counseling, and only less than 2% will actually go for this fertility preservation options. That is mainly because they see this as a delay in initiation, their initiation of the gender-affirming hormone therapy, so that they have to live with the gender dysphoria for another few months before doing this. And another concern is with regards to the pelvic examinations, the transvaginal ultrasounds. Maybe they have to take the hormones, estrogen will be elevated and they will have dysphoria. So all these problems reappear when we ask them to just pause the testosterone therapy and do this ovarian stimulation to get the oocyte retrieval. They have to undergo pelvic examinations, they have to do pelvic ultrasounds, they have to take estrogens. So gender dysphoria definitely get exacerbated during these times. So they have to be adequately counseled and they have to be well aware of what they are having to go through. What we can do to minimize their gender dysphoria is, one is to minimize the pelvic examinations and as much as possible do the trans-abdominal ultrasounds for the follicle tracking and everything. And also the gender-neutral language that we adopt in our clinic is very important. And these days what the fertility specialists do is they add letrozole. During this ovarian stimulation, they add letrozole so that the estrogenic symptoms are very minimal with these patients. And again, once the oocyte retrieval is done, and if this person is not planning to do the pregnancy, if there is another carrier for this embryo, then restart the testosterone as soon as possible.
Thank you very much, Dr. Sujashu Kumar. We deeply appreciate your participation and sharing your views on a very important subject.
Actually, we have one successful live birth, sir, after this in a trans man.
We'd go to Professor Anirban Majumdar to talk about something, a very tricky situation of non-binary person seeking partial medical transition. Now, let us start with a case vignette. A 24-year-old individual who identifies as non-binary presents with gender dysphoria. They experience significant chest dysphoria and desire modest masculinization, like deeper voice, mild facial hair, but wish to retain the ability to conceive in future. They have no significant medical comorbidities, menstrual cycles are regular, and there is no psychiatric history. They report strong social support from their family and workplace, although occasional misgendering occurs. Their transition goals include partial medical transition and chest surgery, but they do not wish to undergo hysterectomy or oophorectomy. Now, what hormone regimens are suitable for non-binary individuals seeking only partial masculinization?
So this is the situation we not very commonly we encounter, but sometimes we do encounter, as I have already discussed one case during my presentation. So sometimes some of the trans people, gender diverse people come for partial medical transition. So in that case, actually, we need to discuss with the person concerned about their goal, and we need to discuss how far they want to go. So in most of the situation, they may require low-dose hormone therapy. That is the usual answer. As you can see in this particular patient, they want actually partial medical transition with some degree of change in the voice and facial hair. Now, we also need to remember that if someone receives the testosterone therapy, the change in the voice is almost always permanent. But the facial hair may decrease if you stop the testosterone therapy. So the person concerned must be very, very sure that they want some degree of transition or some degree of masculinization is really wanted. And being as an endocrinologist, we need to understand that this amount of therapy is necessary to control the dysphoria the patient is currently having. This third important aspect is the fertility issue. Even if you give, as Shuja was discussing about after the testosterone therapy, irrespective of the dose of testosterone, whatever you give, that will have significant impact as far as the ovulation and ovarian function is concerned. We do understand that if we stop the testosterone therapy, there is a possibility of reversal of the fertility, but we are not 100% sure. So patient must be counseled that you are receiving the testosterone therapy or androgen therapy, be sure that if you stop, the fertility may come back, but we are not 100% sure. The fourth important aspect is that these people who are non-binary, they keep on changing their goal. Now today they will say this, and after 6 months of therapy they will say, no, I want this. So this is an important challenge, and every time when they change the goal, we need to change ourselves as far as the treatment aspect is concerned. But basic answer is we need to discuss about the fertility. We need to be very sure that they really want this much of transition and which really help them to decrease the dysphoria, and then we have to choose some low dose therapy so that they get some degree of partial transition.
Thank you very much. I mean, we all appreciate that these are very difficult and tricky situations, especially if the gender congruence changes with time. So how do surgeons approach requests for chest surgery without prior hormone therapy?
Yes, that is, if you look into the guidelines suggest that if someone has got a significant dysphoria because of the breast, then they can actually go directly for the surgery without going through the hormonal therapy. That is possible. So we need to discuss with the patient. We get an understanding that how much is the amount of dysphoria. If the dysphoria is too much because of the breast, then quite naturally, even without giving hormone therapy, we can ask the patient to go for breast surgery, and the surgeon can readily take the patient.
Thank you very much. Now, let us ask Dr. Shruti Chandrasekharan about something which is closer to this one, assessment for readiness before gender affirming surgery.
Thank you, sir.
We'll start off with the case. Say 32-year-old trans woman, socially transitioned 5 years ago. She's on feminizing hormonal therapy for last 3 years, estradiol plus spironolactone. No major comorbidities. Body mass index is 27. Non-smoker, strong and persistent desire for vaginoplasty. Reports significant distress related to genital incongruence. She has good family support, employed, stable housing, no current psychiatric illness, though there are past depression, history of past depression, though in remission right now. She wants to understand the process of assessment before surgery and asks what criteria she needs to meet. Based on that, what are the key medical and mental health criteria for assessing readiness before gender-affirming surgery?
Thank you for this question. This is a very straightforward, easy clinical scenario, but unfortunately this is not something that we commonly see. But in this patient, she is clearly desiring a gender-affirming surgery, and she has no major comorbidities, and she is on feminizing hormone therapy for 3 years. The one thing that I learned from my practice is I never push anybody for gender-affirming surgery, even though the data is there for the estrogen dose after an orchidectomy. I let them take the call, and I want them to start discussing this with me. I usually talk to them in every clinic visit, but the patient should show, or the trans men or the trans women should show the readiness for gender-affirming surgery. It's not something that I initiate and I ask them to proceed. I think that's one important thing that I've learned from my own practice. Here, this patient is very, very ready for surgery. So in that perspective, from my side as a physician or a treating endocrinologist, I would make sure there is no medical contraindication to surgery. She is not a smoker, which is very good. I will also screen her for all the metabolic parameters, get a cardiac status evaluated, get her ready for surgery. And importantly also, from the mental health perspective, it is very important that we assess the readiness for the surgery to make sure there is not underlying social issues or underlying psychiatric issues like depression, bipolar, psychosis that could be a challenge in the post-operative period and taking care of herself or himself. So it's very important we also do not just the physical evaluation, but also a mental health evaluation. But here, as you have pointed out, the social evaluation is very good. She has a good family support, which is amazing. The parents could take care of her, or the boyfriend could take care of her. And financially, she's employed. So that again is a big constraint in majority of our patients who are going for gender-affirming surgery. Now, most of the medical insurances have started covering GAS, which is very good, very positive thing that we see in our practice, a stable housing. So this is all a very added advantage. So it's not just mental or physical ailments that we have to look into, but we also should look into the social, environment, financial perspective when we actually talk about gender-affirming surgery. And apart from all these things, in whatever discussion we have had from the case 1 to case 6 right now, it's very important that we document it. There is absolute importance because as Dr. Majumdar said, they will keep changing. And the outcome, some of the times the outcome may not be as they would expect. So it's very important that we actually educate them that this could be different from one person to the other, have realistic expectation, and sort of document this in your electronic medical record. I think that's the key message that I would say, sir.
Yeah, this is certainly very important, and we understand that all cases has to be individualized, and you have to take a decision based on individual patient, on the background, on the situation, social mores, and the social situation prevalent in that particular area. And can you just give us a very practical tips on how do we apply WPATH Standards of Care version 8 in the Indian context? Because we know that access to multidisciplinary teams is very much limited, at least in this part of the country. So can you show some?
I think, we have the WPATH guidelines, but I come from a state, Tamil Nadu. From Tamil Nadu, I think the government is doing a lot of service. Now we have government hospitals from Tamil Nadu and Madurai, GH, we have incorporated the WPATH setting into the government. I work in a private setting. In a private setting, we could have all the multidisciplinary care unit in a private hospital, and we could do the therapy, counseling, surgeon, reproductive endocrinologist, physician, all these things could be in the same roof. But now we have sort of doing that in a government perspective as well. I think that's a big advantage, sir. So we are incorporating what the WPATH is actually asking us to do.
Thank you very much. We really deeply appreciate your time spent with us and sharing your views on such a very important issues. Thank you, Shruti. We are indeed very privileged that we have Dr. Shomik Sen, who is a professor of legal rights in the NUJs, and a very renowned person on this particular aspect of this one. And needless to mention, we are not very given the opportunity of intermingling with them in various fora, just because our paths are different, so to say. So now let us take this opportunity to ask some very insightful questions about legal rights about trans men or trans women. Now here's a case like a 25-year-old transgender woman approaches an endocrinology clinic seeking gender-affirming hormone therapy. She expresses concern about her identity being questioned at her workplace and her difficulty in accessing healthcare due to lack of awareness about her legal rights. She asks, do I need a medical certificate to prove I am a woman? What are my rights as per Indian law? Now, sir, can you please briefly explain the key takeaways from the NALSA judgment 2014 that clinicians should always remember?
Thank you so much. Let's just go step by step. So, NALSA judgment 2014 is a recognition of a lot of things. Of course, it recognizes the third gender. A very important takeaway from NALSA, as in not specific to clinicians, but generally, is the fact that Article 15 of the Constitution, which prohibits discrimination on grounds of sex is being interpreted as gender in NALSA judgment, which is phenomenally important because we understand that the transgender community, or the third gender as it is colloquially known as, has always been, facing discrimination in the family, in the workplace, and everywhere else. Similarly, another thing that NALSA judgment does provide for is scope for reservations. But these are general, social, benefits of the NALSA judgment. Now, specific to clinicians and specific to the medical practice, what is important is NALSA judgment recognizes self-identification as the basis of a person's determination of gender status. Now, functionally, that leads to some difficulties. Of course, theoretically, a person can identify to belong to a certain gender, and that is sufficient as per NALSA judgment. But if you look at the Transgenders Act 2019, it takes this matter one step ahead, which will link us to this question which is being asked. That what if I need an identity document? What did I need a certificate? What did I need to, maybe I have self-identified myself to be of a different gender and I have undergone surgeries. Then what? What are the legal paraphernalia? What are the medical requirements? Now, these are certain things which the 2019 Act deals with, the Act and the rules of 2020. Now, I'll just very briefly go through some salient features of the Act which will probably be, answering this question. So, in this Act, first of all, Section 2K gives a very inclusive definition of transgender. It says it includes, which means, the ambit is pretty wide. Section 3 talks about protection against discrimination. Section 8 talks about welfare measures by government for purposes of inclusivity. Not just 8, 13, 14, 15, quite a few sections deal with it. Sections 9 to 12 deal with obligations of establishments and families. The obligations that they owe to the transgender people. Section 15 is something that I have a question on, so I will hold it for the moment. I have a question to ask the medical community. But Section 4, 5, 6 and 7 are what pertains to what we are discussing here. So Section 4 says that a transgender person has a right to be recognized as a transgender, and this right is basically a self-perceived gender identity. So, whoever identifies himself as whichever gender, that person has a right to be identified as such. But Section 5 and 6 are used for the purpose of issuing an identity card, right? So, in the workplace, if one, wants to be identified as a transgender person. So, what do these sections say? these sections basically say that you need to apply to a DM. The DM is just a verification authority. The DM under the law cannot conduct a medical examination separately. He is just a verification authority. It is true both under the Act as well as under the protocol. Now, it can be a physical application, or today you have the portal. So the portal, you can submit additional documentation. So a doctor's certificate, gender dysphoria certificate, etc., can be used as a supplementary document. But his, the transgender person's original birth certificate, PAN card, Aadhaar card, etc., need to be attached. The DM just does basic checks whether this person belongs, he resides within the residential limits of the DM's jurisdiction, etc., and issues the certificate. The doctors are not required under 456. Doctors are only required under Section 7. Why? Section 7 says, which is after you get the transgender card. So basically under Section 6, if you have applied in the proper format, if the verification has been found to be proper, you can get a transgender certificate, an identity certificate as a transgender. This does not require any kind of a clinical involvement of any kind. As in, of course, a doctor can, maybe this person is undergoing a parallel, therapy, set of therapies. Those documents can be attached, but it's not necessary, it's not mandatory. Section 7 has some degree of mandate for the doctors. What is it? It says that after you have got the card, so Section 6 is what, gives the card. If the transgender person is going for a surgery, a sex reassignment surgery, after the surgery, to change his gender from female to male or male to female, the person needs the doctor's certificate, the certificate of the CMOH, etc., etc. There are certain engagements with the, doctors and the hospital. So the question is, if I don't need these certificates, a mere self-identification is sufficient under NALSA. The engagement with the Act, the rules and the protocol are necessary only if this person needs a medical, needs a certificate of any kind, an identity certificate of any kind. So that's probably answering your question.
Thank you very much. I mean, you have gone into the details, including...
but doctor, I have a question.
Yeah.
I have a question.
On the protection of rights, 2019 as well.
Yes.
And we have also discussed about how does the Act recognize self-identification, medical or surgical intervention required or not, etc. And how do we also issue medical certificates, and how to change the, say, name and gender in the official documents like Aadhaar, PAN, or etc.
Right.
That's also something very important. Now,
no, but I have a question. I have a question for all of you. My reading of the Act tells me that there are certain obligations of the state towards the doctors. Now, I want to know from you whether the state actually adheres to these obligations. So Section 15 of the Act says that the appropriate government shall take, which is a mandatory shall take the following measures in relation to transgender persons, namely, A, to set up separate human immunodeficiency virus serosurveillance centers to conduct serosurveillance for such persons in accordance with the guidelines issued by the National AIDS Control Organization in this behalf. B, to provide for medical care facility including sex reassignment surgery and hormonal therapy. C, before and after sex reassignment surgery and hormonal therapy counseling. D, bring out a health manual related to sex reassignment surgery in accordance with the World Professional Association for Transgender Health Guidelines. E, review of medical curriculum and research for doctors to address their specific health issues. F, to facilitate access.
We would forget probably the A or B. So let us...
no, so my question is...
delegate the first two questions to Professor...
no, so my question is whether these are followed, because it's a mandate for the state to do vis-a-vis the medical community.
So can I ask Dr. Anirban Majumdar to kindly address this question, and the next two to Dr. Deepmalla Sanyal.
So
the first two to you,
I
sir.
think that the government hospitals different, and we work in a private setup, so that actually work in it differently. In our hospital, we have a good psychiatry department, so psychiatric counseling before, after procedure that you have raised is always being done. And we provide the hormone therapy also. But surgery, we don't have any surgical facility in our hospital. So usually patient go to other centers to get the surgery done.
No, but my question is that the state, and then see, it's not hospital specific, right? So it is the state's obligation. The state has to facilitate these. Now, how much of that is done?
So state means it comes on the government setup. So state means, it means how much the state is doing it, means the state government is doing it. So that is, so in our hospital, it is basically a private hospital, so I can't say that how much is a government doing as far as, but I don't think that any government support is there as far as in our transgender clinic is concerned. But they are working in a state hospital, I think they will give you better.
So each one of us will give our opinion because we are working in different setups. So like in Karnataka, there are not very strict guidelines about, like government doesn't have like clear-cut guidelines. So what happens that it's off and on. Like if we write letters, they go to the government, they get the clearance. So surgery is covered under the schemes also, and they get some benefit. But most of the people who are working in private setups don't get any benefit. They pay out of their pocket and they do surgeries out of their pocket. They are not paid anything. So this is in Karnataka. But at the moment we are having like meetings with Karnataka government, and mostly in another 2-3 months we'll have guidelines for Karnataka as well, where they will be given services at the district hospital. So now what government has decided is each district hospital there'll be a doctor who will be taught like at least a basic service. Surgeons will be there who can do basic surgeries like orchidectomy and all, maybe not the vaginoplasty and all, but orchidectomy, basic surgeries, hysterectomy in case they go for it, and if the patient opts for it, which will be done free of cost. And government has also decided to give hormones at the district hospital level, which they can go and take. But the problem was, our apprehension was the monitoring, because that can be done there, but who will decide whether this is the right thing to do? So that is why the talk is still going on. The guidelines are still not clear, but in Karnataka, as of now, we don't have clear-cut facilities available for transgender from the government side. They get the transgender ID card. For that, they get the reimbursement, like some schemes and all benefit, but not like everybody is paid. But Tamil Nadu and Kerala, they will tell.
What about
So in Tamil Nadu, all A to F that you mentioned are done in a government setup under one roof with surgery, psychiatry and everything. In addition to that, they also give Tamil Nadu government state health scheme is covering the surgery, and they also have reimbursement benefit. In addition to that, they also get monthly allowance from the government. If they have the transgender card, they do get monthly payment, and they also get employment opportunities. They have opened up employment venues in government. So in addition to A to F that you mentioned, we also do a lot of other things.
It's a very progressive society, no doubt.
So this is exactly the point that I'm trying to suggest here. That section 15 makes it obligatory upon the state. Now, public health is a stateless subject, so each state has its own, public health department. But the issue is, we can see clearly that between states, the level of engagement varies. Now, this is what the 2019 Act specifically mandates, that all states have to mandatorily do this. So this is food for thought for the medical community to explore and maybe, to agitate before the governments. Thank you so much.
I can also ask you or bother you with a question as to, are there any ongoing legal challenges or controversies you envisage regarding the 2019 Act, so far as the clinicians should be aware of?
Yes, of course. Every act has challenges. So the 2019 Act, right now, the issue is, the challenges that I can see are more legal than medical. So, for example, challenges are pertaining to adoption, whether trans people are allowed legally to adopt. There is a very interesting Kerala High Court judgment on this subject. There are Madras High Court judgments which are very progressive about, registration of marriages of trans. But, these are more legal questions primarily. Medical, as in clinicians, right away, I don't think there are controversies because the law is pretty settled. So far as the obligations of the medical professionals are concerned, it only comes in at the stage of Section 7, which is after this person already has a transgender certificate. If this person is going for sex reassignment surgery and then subsequently wanting to change his gender from transgender to male or female, that is the point of engagement for the clinicians.
Thank you very much, sir. We are indeed privileged to have you amongst us. I understand that there are many in the audience who are young endocrinologists are really roaring to go for questions regarding this one. This is not often we do encounter situations where you have got a galaxy of experts on the dais to answer your question. So any questions, anything regarding transgender care, the legal rights, etc. Yes, please. Yes, madam. Please identify yourself first.
Yes, sir. Good morning, sir. I am Dr. Shravya from Andhra Pradesh. Sir, I had a case of transgender woman who hasn't undergone any surgery. Patient is on hormonal replacement, hormonal therapy. The patient also had a gender identity certificate from the collectorate, local collectorate. The patient was asking me, actually the patient was a student of architect, so the patient is staying in the hostel. He was asking me to issue a certificate telling that the patient is a woman and requires a girls' hostel room. But now the patient was allotted in men's hostel. He already has gone to authorities. They said they couldn't give that. So he approached me for that certificate. The problem is patient hasn't undergone any surgery. He is just on, the patient is on GnRH therapy.
Okay, thank you. Thank you. We understand this is a difficult question. I'll give it to, yes, sir. Dr. Pramila Kalra first. The medical aspect and the legal aspect will be dealt by Dr. Shomik Sen.
So I recently had a patient with a similar scenario who had to go to a hostel, and it's a trans female who is not yet operated. I gave the certificate that the patient is a trans female, not yet operated. Now I left it to the principal and I talked to the principal. The principal said, I can say yes, but the parents are opposing, other girls' parents. So finally the child was asked to take a separate room. They gave the separate, there was a guest house room which they gave. Because the patient is not operated, the other girls who are staying in the hostel, their parents actually said, we can't allow this. So that was the problem. Not that the principal, because the guidelines may say it's okay, but the patient is not operated, the girls are staying, and the parents said, we will not let our girls stay there. So finally, after a lot of discussion, lot of letters, it was decided that they gave a room in the guest house separately for the child, and the food will be supplied there. That is how we managed.
I asked actually the patient.
Exactly.
What are the legal implications of such a situation?
Exactly, absolutely rightly said. So legally, your certificate is just another corroborative piece of paper, nothing else. Legally, it has no standing because the operation has not been done. It continues to remain in the realms of social issue. And socially, if the parents have an objection, in such cases, the only way out is probably a separate guest house or something like that.
Sir, actually, I was
So I'm just giving you
one
issue, that if someone is male, wants to become female, so first step is that that the needs to declare that I am a trans woman. So this is the first part. So trans does not mean that she is complete woman. So completion, or if you want to get a certificate of female, if you want to write female in your all identity documents, you need to have the operation done. Surgery is must. So till the surgery is not done, you are not female. So how someone can allow in a female, dormitory or female hostel? So you are not female. Yes, we agree that you are not male, you are trans. So that is why in the female, we cannot write female. The certificate you cannot give what you have asked, that whether we can give female certificate or not. No, we cannot give female certificate. They can self-declare that they are trans.
Thank you, sir. Thank you, ma'am.
Is there any other question? Yes, sir. Yes, please. Can you please put your question in short?
I'm Dr. Abhijit. I'm second year resident from Guwahati Medical College. Actually, my question is that some of the transgender patients that they are coming to our hospitals, we are giving treatment of estradiol and spironolactone. Still, they are not maintaining their estradiol levels in target range. So they will usually come and ask this situation that we are unable to maintain our estradiol levels in the target range. So what else should we suggest these kind of patients?
So again, if you see for a lot of our patients, if the dose escalation we can go up to 8 milligrams, but a use of GnRH hormone therapy would be appropriate as well, because that would adequately suppress the testosterone level as well. The option, as we have discussed also, is that we have the option of injectable estradiol, which are a little bit more efficacious as well. And there is data also which we have shown that probably transdermal preparations have a better, there is more fluctuation with the oral estrogen therapy compared to a transdermal. So the option of transdermal also has to be discussed. So sometimes the levels can be achieved with transdermal or injectable. And use of GnRH also helps in achieving the target levels.
Okay. Thank you, sir.
Thank you very much. Yes, Dr. Kaushik Sen.
Sir, a similar question that was being discussed previously. Sir, in such a scenario, I work in a government hospital. In a patient who is a trans female, who had to admit, whether to admit in general male ward or in a female ward. I had come across this very, very difficult scenario.
This is Kaushik. This is a very common question we encounter. This is a common problem we face in our hospital also. My answer is very simple. Get them admitted in a cabin separately, and that solves every issue.
We actually have a transgender ward in the hospital. So we have asked for it and they gave it, and we have a transgender ward which we use when we admit them. So the best way is to get a transgender ward. That's the correct way to do it for them, for small cave, like three, four rooms. So two rooms, two for trans females, two for trans males, but there are not so many admissions at one point of time, so we are able to manage. But otherwise, as Dr. Anirban said, we have to do it in a separate cave.
Yeah, thank you. We understand that not every
Question
place
I
is
would
as
like to
progressive
ask
as
Dr. Shane,
Karnataka.
Professor Shane, is that when a lot of patients come to us, especially after name change, now there is, I believe, a reason, especially we have had some legal issues also, which has been suggested. There are some legal areas which was reading that we need to have both the name, the initial name which was there and the new name the patient has preferred in the written prescription. Do we need to have both the names for better identification? Is there any kind of modification in the law which was there reported in the newspapers and some media reports also?
No,
is there any modification?
As far as I am aware, it's just a matter of convenience, because say this person, after he has, let's say, undergone the transformation, step by step, one by one, this person's documents will be changed. So there will be a time when, let's say, the Aadhaar card has been changed, but the passport, the old name stays. So in such a situation, just for matters of convenience, if both names are there in the prescription, it makes things a little easier. Just that. Legally, there is no obligation.
Thank you very much, sir. We are indeed very privileged once again, and we are really thankful that you have been able to spare some time with us and give us your insights on such a very important this one. And we are, I know that it's a very interesting subject, and we can probably go on for another couple of hours given the opportunity, but just we know that the time is limited. We'll have to stop here and thank everybody, profusely thanking Shruti, Shuja, Pramila, Demallo, Shubhadeep, and I cannot thank Anirban enough, because he is the brain and the heart behind this whole presentation. And thank you, all of you, for giving us this gift of such an excellent presentation, combined presentation on such a relevant and timely scientific aspect of transgender care. So thank you very much. will give us please give them a hand, and we'll go off to the next very short presentation and a video being released by Professor Shalinder Bhasin. I'll request Professor Bhasin to come here and present this one. Thank you very much, sir.
Okay. So actually, we have the certificate for the participants. I would like to, I would request the chairpersons and the speakers to stay back and to distribute the certificates to the individual participants. For this, we have first, I will call alphabetically, Avronil Dhor.
Avronil. Yeah, let us. I mean, the certificate certainly can be collected from the side. I mean, from the table. Let Professor Bhasin.
Thank you, Professor Pandit. So, I wanted to announce the inauguration of the Endocrine Society of India and IR Initiative's educational program on optimized healthcare of transgender and gender diverse people in India. As you know, to date, we don't have an online program prepared based on evidence-based information by experts in India. So this course was 2 years in the making. Its origins started in Jaipur at the ESICON meeting in Jaipur when Professor Badada was the president and Dr. Hari Kumar was the secretary. And they convened the executive committee, and the executive committee of the Endocrine Society of India directed Dr. Majumdar and myself to prepare this educational program on optimized healthcare of transgender and gender diverse people in India. So I'm happy to share the good news that this online course has now been completed, and it'll be placed on the website of the Endocrine Society of India. This course is free, totally unencumbered. It's a 4-hour course, and I'll just briefly give you an outline of this course. Dr. Badada served as a senior advisor and guided us on the selection of the speakers as well as on the content. So we were privileged to have a very distinguished faculty of experts in India and a couple of people from the US who are endophiles like myself. I'm a graduate of the All India Institute of Medical Sciences in New Delhi, a very proud graduate, and have deep affinity for all things Indian since I was born here and got very excellent free education throughout my medical school and even before at DAV College, Chandigarh. I don't have time to describe all of the speakers, but Professor Majumdar and I had great delight in working with this very distinguished panel of speakers. The table of contents includes 4 modules. The first module is on transgender communities, etiquette of care, and primary care, and it has 4 presentations. Module 2 describes gender-affirming hormone therapies, feminizing as well as masculine hormone therapies, and then the complexities of gender-affirming hormone therapy in transgender youth. Module 3 discusses the mental health issues and how to manage them as a medical doctor. And Module 4 talks about the general principles of gender-affirming surgical therapy. So this course will be available online and through a URL that will be placed on the Endocrine Society website, and it's completely free, and you can share this link with people, with other members of the Endocrine Society freely. I want to thank the leadership of the Endocrine Society, particularly Professor Sanjay Badara, Professor Hari Kumar, Lieutenant General Dr. Narendra Kotwal, Professor Kaushik Pandit, and Professor Anirban Majumdar, a number of family and friends, many graduates of All India Institute who were my classmates or who I had the privilege of having as friends at All India Institute or through my career. They contributed the funds which made this course possible, and these contributions were totally without encumbrance. Mr. Arun Puri, chairman of the India Today group, he supported the video recordings and made his staff available to us. And these people from the Aaj Tak team, they went to individual cities to record these in person. And so these video recordings were done by Anup Singh Gulnar Oberoi, as well as Vivek Malhotra and the Aaj Tak team of India Today. And I'm very grateful to all of these people. So please feel free to share this video with your trainees at your medical schools. And this is totally unencumbered and totally free. So thank you. And I thank the Endocrine Society of India for taking leadership in preparing this online course.
Okay, so the next session will be from 1 p.m. Now we have lunch from till 1 p.m.
Before we go into the post-lunch workshops, I'll call up the organizing secretary of ESICON 2025, Professor Sujoy Ghosh, for a very, very special purpose. And to reveal the purpose, here comes Professor Sujoy Ghosh.
Good afternoon. If I could request Dr. Kotwal sir, President of ESI, and Dr. Kaushik Pandit, President-elect of ESI, to come onto the dais, please. Maybe I could ask Kaushik to speak first and then sir to release a very special trailer of a docu-feature. Kaushik, if you could talk about the background of the docu-feature.
We had this rare opportunity of hosting ESICON after a long 12-year hiatus. And we thought that probably this is time that it may be an occasion where we can release a sort of documentation of what has happened over the past, say, 50 years of how endocrinology has started in this part of the world. And somebody must document it for the sake of the posterity, not for ourselves. It's for the posterity, so that if somebody someday want to write something on endocrinology or development of the science of endocrinology in this part of the world, they need some documentation. And needless to mention, it was the untiring efforts of Sujoy Ghosh. You know, I mean, how he can be. And so it was compiled for nearly 210 minutes of documentary. I mean, taking from all possible corners of the state, all possible the individuals who were or are associated with endocrinology, to give their version, so that this is documented with as much documentation as is possible to access in the public domain or otherwise. And this has been formulated to have a documentary plus a coffee table book. The coffee table book is yet not ready. We are going to release soon. The documentary has been prepared, and we have got an excerpt from that one for you to taste now for the next 5 days. And we have got the privilege to ask the President of Endocrine Society of India, Lieutenant General Dr. Narendra Kotwal, to formally release this documentary. Thank you, sir.
They will play it from there, sir. आप थोड़ा यहाँ पे आके कुछ बोल दीजिए. Sir, you speak for 1 minute and then.
Yeah. Good afternoon, everyone. I think what Dr. Sujoy and their team has done is fantastic. It's very important that we should know our history, what our elders have done, what our ancestors have done. We today are standing on their achievements and their landmarks, so we should know our history. I would request all the state chapters of Endocrine Society of India to document history in their respective parts. So that will tell our youngsters that where they stand, they are standing on the laurels of their seniors. And this is a very good step. Congratulations, Sujoy, and congratulations, team.
ওই যে স্টোরিটা স্যার বললেন না যে কি করে এন্ডোক্রিনটা শুরু হলো, যদি আরেকবার ছোট করে বলেন, ওরা রেকর্ড করে নেবে স্যার।
We are talking about that era. By the era, there was change in political change here.
Rome was not built in a day. Rome একদিনে তৈরি হয়নি। আজকে আমাদের ডিপার্টমেন্ট এত সুন্দর, একটা বীজ থেকে মহিরও হয়েছে, এটা আমার চোখের সামনে দেখা, এবং আমি খুব আনন্দ পাই এবং স্বপ্ন দেখি। আমার কাছে পিজি মানে হচ্ছে প্রেম জগৎ। পি ফর প্রেম, জে ফর জগৎ। এর ইট, পাথর, কাঠ, বালি, মানুষ, জন সবকিছু আমার কাছে ভীষণ আনন্দদায়ক। আমি যখন ফ্লাইওভার দিয়ে নামি, তখন আমি ভিক্টোরিয়ার দিকে তাকাই না, আমি পিজির দিকে তাকাই, কারণ পিজিটা হচ্ছে আমার সবকিছু।
The original, the founder of this department. Ours is a relatively small department.
And I was lucky to be the first woman candidate.
They told you won't get any patient, so why do you waste your time?
Endocrinology এমন একটা সাবজেক্ট যেটাকে সবাই অবজ্ঞা করে এসেছে।
আমি ধরুন এই সরকারি হাসপাতালের সাথে সাথে কর্পোরেটও যেখানে প্র্যাকটিস করি, সবার ধারণা এন্ডোক্রিনোলজি করে কি হবে, ওটা তো সাপোর্টিং একটা।
We used to go to the principal, talk in the college council meeting, what is my department, what is my room?
Department of Medicine helped us a lot.
In no other college in West Bengal, there is a specialized endocrine surgery department, and that is there in medical college.
কিন্তু যেহেতু আমি আরএমও ছিলাম, আমাকে ওখানে কোনোভাবে এন্ডোক্রিনোলজি ইউনিট বা ওপিডি করতে অ্যালাউ করা হচ্ছিল না।
Patient care, the clinical duties, the teaching of students, and not only DM students, we have another course, a paramedical course, that is DDCT, Diploma in Diabetes Care Technology.
Well, every Monday we do a journal club where we discuss the latest papers in the field of endocrinology.
So that is the first transgender clinic, not only in this city, not only in this part of the country, but I think this is the first transgender clinic in whole India.
When we passed out and people ask me, so what is your qualification? We used to say we are endocrinologist. এটা কি জিনিস? আপনারা কিসের ডাক্তারবাবু আছেন? We need to say sugar, thyroid, hormone.
তো এই পাবলিক অ্যাওয়ারনেসটা কারা করবে? সরকার করবে না, ফার্মা ইন্ডাস্ট্রি কখনোই করবে না, তাহলে করবে কারা? শুধু আরো ফিজিশিয়ানরাই করবে। সেরকমভাবে এন্ডোক্রাইন সোসাইটি অফ বেঙ্গলও তৈরি করা হলো।
15-16টা জেলাতে আমরা টাইপ 1 ডায়াবেটিসের যে সার্ভিস, সেটা কিন্তু একটা প্রত্যেক জেলাতে সেই জেলার টাইপ 1 ডায়াবেটিসের বাচ্চাগুলোকে আইডেন্টিফাই করে সেখান থেকে আমরা প্রত্যেকের ব্লাড সুগার মেজারমেন্টের জন্য স্ট্রিপস দেওয়া, মেশিন দেওয়া, তাদের অ্যাক্টিভ মনিটরিং করা, এটা অবশ্যই সরকারি উদ্যোগে। এটা কিন্তু একটা ন্যাশনাল পলিসি হিসেবেও রেকমেন্ডেড হচ্ছে।
Like to talk about 3 components. So patient care, teaching and research.
So endocrinologist, you need to have a very good clinical acumen, a clinical eye.
মেক ইন ইন্ডিয়ার গল্প করতে গেলে সবার আগে যেটা করতে হবে রিসার্চ ইন ইন্ডিয়া।
But things have changed today. আজকে নিচে ওপিডিতে পেশেন্ট আসলে বলে আমরা এন্ডোক্রাইনোলজিস্টকে দেখাবো। ইউ নো ইন 20 years back এন্ডোক্রাইন মানে কি হয়, আপনি কিসের ডাক্তার, আপনি ডায়াবেটিসের ডাক্তার। So okay, that's my experience.
With the coming days, they are also planning for an expansion, and I hope in coming days will play a more important role in endocrine service in the society.
I'm sure it will happen in the days or years to come.
If you do not look back, you can never move forward.
So, yes, those were good old days, and I miss them, and I look back at them with a sense of nostalgia.
There is no end of the story. It is the beginning of the story.
Through every challenge we have endured, the blows, the setbacks, the moments of contempt, and the strength of love, we have moved forward. We are still moving forward, and we will continue into the future stronger than ever. We are endocrinologists of Bengal.
Wow, what a video, it's really amazing. Now I request everyone to move on to the respective hall. Now in Hall A, with the advancement of the technology, insulin pump has been a part of the diabetes management. And now we have the session, one workshop on insulin pump. And for this session, I would like to call upon the dais Dr. Shoham Tarabdar as the chairperson.
A very good afternoon to this august audience. I welcome you all to ASICON Kolkata 2025. I am very thankful to the ASICON Organizing Committee for giving me this opportunity to moderate this a very important session on the insulin pump. Over the time, the history of insulin pump, over the development of insulin more than 100 years back, and started up the insulin pump from 1970s onwards. They were very bulky, and over the time they have been smaller, the devices have been invented, and along with integration of the continuous glucose monitoring, the closed hybrid loop is now the future. So our objectives will be to provide a general insulin pump therapy principles, understand the development of AIDs and the system components and the algorithms, share practical strategies, and discuss specific scenarios, particularly to exercise sick day rules, pregnancy, and advanced indication. We'd also like to provide a hands-on session with the pumps. So I would request everybody to shift to the first few rows because we have limited amounts of pumps, so we will only be able to provide in the first few rows. So I would request everybody from the back to please shift towards the first few rows. Thank you. I would like to thank Vinay and Medtronic team for bringing all the pumps and the materials. And we have a very esteemed panel of speakers, endocrinologists from all over India. So I would like to call upon all the speakers one by one. First of all, I'd like to call upon Dr. Sharvil Gadve. He is the Director and Chief Endocrinologist, Excel Endocrine Center, Kolhapur. He is also Secretary of the Maharashtra Endocrine Society. He has multiple research publications, presentations in international forums. He has been a pioneer in using the advanced hybrid closed loop in western part of Maharashtra, principal investigators in 11 global phase 3 trials, trained more than 100 physicians, and also the organizing secretary of MahaEndocon 2023. Second of all, I'd like to call upon Dr. R. Santosh. He's a consultant endocrinologist from Magnus Center of Obesity, Diabetes, and Endocrinology from Hyderabad, with area of interest in precocity, gender dysphoria, with multiple publications and 4 textbook chapters. He is the winner of the esteemed and prestigious Abdul Kalam Award for Excellence in Endocrinology. He has been the organizing secretary for ASICON 2023. Next upon, I would like to call upon Dr. Titu Umen, who has been a very stalwart and a joint secretary from the ASICON 2017 held in Trivandrum, organizing committee in multiple forums with multiple publications in international journals. Next upon, nobody who requires introduction, Dr. Uray Farkesar. He has been a fellow of the American College of Endocrinology. He's a director and the Endocrinology Diabetes Shayadri group of hospitals, and he has multiple publications in peer-reviewed international journals, chapters in RSSDI, textbooks, and postgraduate diploma guides. He's an advanced preceptorship in endocrinology from Johns Hopkins in USA, recipient of the Srimati Bhandarkar Award of Academic Excellence, part of team awarded Vivian Fonseca Award by ADA for conduct of the COSMIC study, an avid mountaineer and natural photographer. I'd like to also call upon Dr. Sachin Mittal, who has multiple presentations, winner of the Charaka Award in the ASICON 2010 in Vellore, Best Award in the ISPAD Science School 2013 in Sydney, founder director of We Care at Home Health Services startup providing home health services in Chandigarh, founder and director of We Care at Home Health, captain of Bhangra team of endocrinologists, and regularly writes for leading newspapers like the Tribune, Hindustan Times, and regional newspapers. Dr. Mayur Agarwal was not able to join due to some personal circumstances, and I would like to wish that everything gets better, and I will be presenting on his behalf. Next up, I'd like to call upon Dr. Beatrice Ann, who is the additional professor and head Department of Endocrinology, Nizam's Institute of Medical Sciences, Dr. Anil R. Sheth Award winner, and also the gold medalist in the DM Endocrinology exam, Best Research Paper Award in RSSDI, authored various national, international journals, and authored chapters titled Endocrine Receptor Chemicals in Endotext. Last but not the least, I'd like to call upon very eminent Dr. Mahesh DM from the Aster CMI Hospital, Shashi Advanced Health from Bengaluru, winner of the annual Torrent Young Scholar Award 2013, winner of the A.V. Gandhi Award for Excellence 2014, with publications in multiple national and international journals, and is featured as the chief endocrinologist in India Today 2022, Outlook 2022, 2024, 2025. So first of all, I'd like to call upon Dr. Sharvil Gadre sir for the introduction part for the topic. I'd request everyone to get settled down for the starting of the session, please. Thank you.
Good afternoon, everyone. I would like to thank the Endocrine Society of Bengal for giving this opportunity and the Endocrine Society of India. So my job is to introduce and set the stage rolling for this concept of insulin pump. Now, we know that managing diabetes is difficult, especially when it comes to type 1 diabetes, walking a tightrope. So on one hand, you have the hyperglycemia and all its complications, and on the other hand, you have hypoglycemia and its consequences. Now, when it comes to giving insulin to the patient, we have two options. Either you can inject insulin or you can pump insulin. Very soon we will have another third option. So all of us are aware that there is also inhaled insulin. But as of today, what is available to us is we can inject insulin or pump insulin. Now, what would be preferred? So if you look at physiology, pumping insulin is much more physiologic and it is closer to physiology. Now, let's look at a prototype type 1 diabetes patient. So there are 4 injections per year. That comes to 1460 injections, 4 injections per day. And that amounts to 1460 injections a year. So a lot of injections. So that leads to non-compliance, and that eventually translates into poor glycemic control in many cases. Why is managing type 1 diabetes so difficult? Multiple reasons. So if you enumerate the factors that can alter the blood glucose, there are more than 42 factors. It includes food, medication, activity, biological causes, environmental causes, behavioral and other causes. So multiple reasons why the blood glucose, there is so much of variability and managing it is so difficult. Now, if you look at the time frame of where we have moved on from 1921 to 2025, so this is the time frame. Thanks to the innovation that in the past century, 1921, we had insulin. Then came in the era of animal insulin, then recombinant insulin, and then subsequently we have now evolved in a better way how we give insulin, how we pump insulin into the patient. This is how the earlier insulin pump looked. It was quite different. This is one of the initial insulin pumps which was used. And this picture all of us have seen several times. So initially the insulin pump was a very big device and probably not very easy to wear and move around, but everyone was trying to put in some technology which can help us pump insulin in a patient in a better way. Then came the smaller devices. So this was the earlier Minimed 508 pump, how it looked. And then came the sensor augmented pump. So just having a pump doesn't suffice. You need to have a sensor augmented pump. So then came in these pumps which were sensor augmented. And then came in the hybrid closed loop pump. So you just don't have sensor augmented pump. You want to close the loop and try to mimic physiology. What is happening in a normal healthy person. Similarly, you want to mimic that. So then came the hybrid closed loop pump. Where we stand presently is the advanced hybrid closed loop pump. So you can see the pump You can see the mobile app that it gets connected to. You can see the sensor over there. So all this is what we presently have, the advanced hybrid closed loop pump. Now basically what is an insulin pump? It is a small computerized battery operated, allows the user to control exactly how much insulin is delivered. What are the components? So it has a pump reservoir. So you see the pump, that is the pump reservoir, and you have something called the infusion set, which they also call the quick set. So that connects the pump to the body. Now this is the pump available to us in India, commercially available. There are other pumps elsewhere which are tubeless pumps, but today we are discussing what is available to us. So this pump is what is available to us. How does it work? Insulin passes from the pump reservoir through the tubing into the subcutaneous tissue. And tomorrow, let's say you go to your clinic and you want to prescribe a pump. So I have put in 3 pumps that are commercially available. Many more may be available, but this is what is commonly available and which provides service post availability. So you have the basic insulin pump, you have the second option, that is insulin pump with CGM, and the advanced hybrid closed loop sensor augmented pump. So these pumps are available. Now let's say tomorrow you want to shift your patient, your type 1 diabetes patient, who is on multiple daily insulin, to insulin pump. So what you need to first do is to calculate the total daily dose, TDD. So you calculate the total daily dose because you need to calculate what will be the basal component of the settings in the pump. So usually there are different guidelines, but the consensus is reduce 10 to 30% of the total daily dose. The ISPAD and other guidelines, they vary. So roughly you can remember the figure of 10 to 20%. If good glycemic control is there, and if frequent hypoglycemia is there, you can reduce more than 20%. So you're shifting from multiple daily insulin to insulin pump. So that is the formula for total daily dose. And then comes the basal rate. So when you're basically starting a basic pump for your patient, you need to calculate and put in the basal rate. So you can have multiple basal rates. The beauty of pump, which distinguishes it from multiple daily injections, is that when you're giving a basal insulin to a patient, you cannot have multiple basal rates for the same patient in a day. But when you're using an insulin pump, you can set in multiple basal rates depending on the different time frames of the day. That reduces the episodes of hypoglycemia and hyperglycemia. So that is the advantage of the pump. You also have an option of temporary basal. That is when you set in when the patient is exercising, for sick days and so on. So temporary basal is another option. And then obviously you can give boluses. With a pump you can give multiple boluses because you need not prick the patient every time. So you just have to press the key on the pump. So you can give multiple boluses and you can also give multiple correction boluses. So these features are there for all pumps, the basic pumps as well as the advanced pump. And depending on whether your patient is an adult or is in puberty or pre-puberty, depending on the age group, there are different guidelines as to of the total daily dose that you have calculated, how much of that you will give as the basal. So this you will have to individualize depending on the patient sitting in front of you. And then you set the basal rates. Now the simple rule is when you're starting your patient on pump, you can simply start with a single basal rate. Divide the total daily dose by 24 to get the basal rate in units per hour, and you start with a single basal rate. And then you can increase or decrease the different basal rates in the different time frames depending on your patient's CGM data or the glucometer data. So that is how you start. So setting multiple basal rates. So this way you can counter the dawn phenomena, Somogi phenomena. If your patient has a problem with post-breakfast hyperglycemia, you can have a different basal rate. If your patient has some problem with hypoglycemia at a particular time, So all this you need to consider, and you can individualize this for your patient. And you also have this option, what I said, of temporary basal rate. So that is set when patient is, suppose someday patient is planning to exercise heavily, or some patient has change in their routine, medications, menstruation, illness, and so on. So that is temporary basal rate. Now coming to bolus doses, two key areas where a patient would use a bolus are: first, obviously when the patient is having meal, when the patient is having carbohydrates, at that time patient has to have a bolus dose, and to correct high glucose readings, that is the correction doses. So if your patient is on multiple daily insulin, so if the patient has few snacks, multiple snacks, so every time they have to prick. But here the obvious advantage is they just have to press the key on their device, and that is how you use. So this is the formula for correction bolus. This you can also use when you are using multiple daily insulin. Now in the pump, you have something called the bolus calculator, which does all this for you. So you have entered the insulin carb ratio, you have entered the insulin sensitivity factor, and the pump understands what is insulin on board. That is called as active insulin time. And the bolus calculator in the pump does this for you, rather than patient doing it manually every time. So that is the advantage. And insulin to carb ratio is important. Whenever you are starting a patient on insulin pump, your patient should have a basic, at least some understanding of what is carbohydrate counting. And even though it's very difficult to master carbohydrate counting, they should be roughly be able to judge how much carbs they are having in each meal. The good thing about the 780G, the advanced hybrid closed loop insulin pump now, is that even if your patient does an error in entering carbs, the pump can compensate for that, giving additional correction boluses and so on. So roughly, you need not tell your patient that you should be perfect in carbohydrate counting, but they should have some idea what is carbohydrate counting. That could suffice. And this is one term which all of us should be aware, that is active insulin time. So whenever you are starting your patient on insulin pump, the company person will ask you as a physician what should be the active insulin time. Now the simple rule is you can keep it as 2 hours, and then you can alter as 3 hours, 4 hours, or whatever you feel. Now what is this active insulin time? It is insulin remaining from previous boluses that still has pharmacodynamic ability to lower glucose. So basically here we are understanding the phenomena of stacking. So patient will have insulin in the physiology, which has been delivered with the earlier boluses, and that has to be taken into consideration when you are planning the next bolus. So that comes, that calculation comes into this terminology called active insulin time. So as a physician, you need to enter the active insulin time, what you choose. And as I said, the preferred active insulin time, if you want to enter a value, that should be 2 hours. Obviously, you can increase or decrease that. Now, how many of us sitting in this hall have actually used an insulin pump? Just a show of hand to get an idea. Yeah, so, yeah, many of us, and probably many of us have still not used and planning to use, right? And how many of us have actually started manually a pump to a patient? So probably quite a few of us, yeah. So I have made a small video to just get an idea to set the stage for today's workshop. So I would like to play this video.
Hello everyone, I am Dr. Sharvil Gadve. I am endocrinologist practicing at Excel Endocrine Center, Kolhapur. What is an insulin pump? So insulin pump is a medical device which is used for patients with diabetes. And again restart the insulin when the glucose starts to come back to normal or starts increasing.
I am fast forwarding the video just to save the time. So now I will show what the physically how it looks when you're inserting the quick set to your patient. We do have a hands-on in the subsequent session, so I'll quickly go through this.
So that is the benefit of insulin pump. in terms of reducing the risk of hypoglycemia, also reducing the number of events of hyperglycemia, and keeping the blood glucose in range. That is, achieving the time in range for every patient. How does an insulin pump look? What are the different accessories which come along with the insulin pump, and what are the different consumables? So this is how an insulin pump looks. This is an insulin pump. This is what we call the quick set. This is the inserter for the quick set. This is the reservoir of the insulin pump. This is the sensor for the insulin pump. This is the transmitter of the sensor. This is the charger of the transmitter. And this is the inserter of the sensor. So this is how an insulin pump looks. So these are the various accessories and consumables which come along with the insulin pump. Now we have our
We have a hands-on session, so everyone will be requested to come in the first few seats because we have limited pumps. So quickly moving on to how it is inserted. So I'll fast forward to, depending on your patient's requirement, you can set up as many basal doses as required. This is how the quick set looks. Now we are opening the quick set to apply it to our patient. So we have removed the quick set. We have to maintain all the required sterile precautions. Hands should be cleanly washed. And now we use the inserter and put the quick set into the inserter. So this is how the quick set is put into the inserter. And then we remove the adhesive that is given along with the quick set so that we can apply it to our patient. So this is how we have removed the adhesive. Now once this is done, we load the inserter. So this is how we have loaded it. So you can hear the clicking sound. Now once this is done, we can see here there is this device here, and we need to remove this blue colored thing so that now the quick set is ready with the inserter to be put on the patient. Now this is to be applied on the abdomen using all these sterile precautions. You clean the site, allow it to dry, and then the next step is to apply the quick set on the abdomen. This is how it is done. You apply it firmly, and then you can hear the click sound after you press the side button. And once it is done, you can remove the inserter. And you can see the quick set is nicely attached on the abdomen now. Once this is done, you remove this blue colored thing which is available on the quick set. So now you close this, and here is it. We have the quick set ready to be used for our patient. So that is how you attach the quick set. Now the next thing that you do is what is called the sensor. So I'll quickly go through how it looks. And so this is how once you put the quick set and the pump is attached, it will look. And quickly moving on to the next step, that is, looks. So like this is the inserter. So this is the applicator with the sensor. Now we are going to apply the sensor to our patient. So we firmly hold the applicator to the abdomen. The sensor can be applied either on the abdomen or on the upper arm. So here we are applying it on the abdomen, and then you press the green button. You see the click sound, and the sensor is now attached to our patient's body. Now we withdraw the applicator, and there we see the sensor attached to our patient. We then remove this plastic knob
which is present. Now we remove this adhesive, and here the sensor is now ready. We have to apply the transmitter now to the sensor. So this is how the transmitter looks. This is the transmitter. It has been charged. So a charged transmitter is now applied here on the sensor. Once this is done, we can start using the sensor.
So these are the two physical things we need to do. So apply the quick set, apply the sensor. We'll come to all this in the live session. So this is our journey till now. So we started with the basic pumps, and presently we are at advanced hybrid closed loop pump. In the future, we will have multi-hormonal pumps. So along with insulin, there will be glucagon. But as of now, we have this advanced hybrid. Just to close, just a prototype case. So this is one of our patients, 24-year-old male. He was multiple daily insulin. His HbA1c used to be quite high. So if you look at his HbA1c, it was 10.3. He was on basal bolus regimen. And every time we used to, at that time we were using this CGM, the Freestyle Libre Pro. And every time he used to come and his readings used to be chaotic. So it used to be very high. So eventually he agreed to go on this advanced hybrid closed loop insulin pump. And what used to be very bad readings, subsequently we were stunned to look at these findings. So this is less likely, but this patient achieved 89% time in range. He enjoyed the device so much that he learned everything and is presently using this advanced hybrid closed loop pump. And just look at the time in range. So very good time in range. This is how the report looks. So now subsequently we will have discussion on how to interpret these reports. So this is how the report looks. And his HbA1c now remains at 7% or below 7. So that is a good achievement. As we put more and more patients on insulin pump, we need to also probably discuss this or educate our colleagues in other departments. What is insulin pump? Suppose you have started a patient on insulin pump, your patient lands up somewhere in a surgery department or other department. So others should also be aware of what needs to be done when a patient is on insulin pump and they have some other problems. So this has to be kept in mind. And choosing the appropriate patient is important. So here we have said all the good things about insulin pump, but choosing the appropriate patient is important. Is this patient here an appropriate choice for insulin pump? Probably not. You can see the patient is very sick, elderly, and in this case, glycemic control, starting an insulin pump would not be a good choice. So that's important where we do not choose. To close, just a word on algorithms. The next talk is on algorithms. So what are algorithms? This is reinforcement machine learning. So your advanced hybrid closed loop pump learns every day what was the glucose, what was the correction given, how it should improve. It uses these algorithms. So just to name a few, it is the PID algorithm, MPC algorithm, there is this fuzzy logic algorithm, neural networks. So a lot of algorithms are in place. The most commonly used is the PID algorithm in pump. So this is also used in the aviation industry. Suppose you came by flight to Kolkata. So where your flight landed, at what time it landed, and exactly where it landed. So that is a calculation. Similarly, the pump does all these calculations for your patient to attain the time in range, to avoid hypoglycemia, to avoid hyperglycemia. So it uses these algorithms. If a patient with type 1 diabetes has to do well, there are almost 200 decisions that the patient has to take every day. So if you just look at this slide, so what is the glucose before meal, what will be the correction dose, how much carbs the patient is taking, what will be the basal dose, and so on. So many calculations every patient has to do. But suppose you put this patient on advanced hybrid closed loop pump, the number of efforts the patient has to do reduces. Although presently it doesn't become zero, but it definitely comes down from a large number of calculations to a simpler life. So I would say the present advanced hybrid closed loop pump is a very good option for the patient. It has this auto basal, auto correction, all these algorithms helping with this, safe meal bolus, meal detection bolus, and so on. So we'll come to this in the subsequent talks. And as a physician, you need to enter only these three values. insulin carb ratio, auto-basal target, and active insulin time. So if you enter these three and start the patient, it is very much doable. And what is the real world performance? So if you look at this slide, you realize that a good number of patients achieve the time in range more than 70%. Is there any survival advantage for your patient if they go on insulin pump? And the answer is yes. The severe hypoglycemia episodes reduce. HbA1c reduction, obviously, all studies show favoring using a pump. And what about mortality? There is also a mortality benefit, 45% reduction in these studies, in this analysis. So, lot of benefits. And
however, Dr. Sharvil Gadve, what about the cost of insulin pump? And don't forget my tariff, although I know that your government has given some relief in GST. Tell me the cost.
Yeah, so what is the cost of the pump? So all of us physicians, clinicians here do realize that cost is important. So this is expensive. So I put the cost of the 3 pumps that I showed. So the basic pump presently costs something like 2,45,000. Then the sensor augmented pump costs something like 3 lakh, and the most advanced pump presently costs around 6 lakh rupees. So I will stop here and hand over for the next discussion. Thank you.
Thank you, sir, for the wonderful presentation. Next, I'd like to call upon Dr. R. Santosh for the overview of automated insulin delivery systems, the components and the algorithm.
So I think Dr. Sharvil has given a beautiful overview of what is going to be presented. So mine will be more of a technical talk. So I'll be talking about components of an automated insulin delivery system and the algorithm. Now, if you have to take the basic prototype of an algorithm, it's very simple. There are 2 things which Dr. Sharvil has just said. There is supposed to be a continuous glucose monitoring system or a sensor and an insulin pump. What the sensor is supposed to do? The sensor is supposed to record the glucose data, and the sensor has to transmit this to the pump. There is an algorithm that is sitting inside the pump, or it may be sitting inside the smartphone which is connected to the pump. And the algorithm has to control, or it has to determine what is the insulin dose to be given. It passes on the information to the pump, and the pump gives the appropriate insulin. So this is a very basic thing. Sensor, it's checking the glucose, it is sending to the algorithm determines what insulin to be given. So before we go to the details, let's talk about some important terminology. Once we have started talking about sensor augmented pumps, that is, when sensor augmented pump means there is a pump and there is a sensor. Before that, what happened? Before 2016, 2017 in India, we used to not have sensor augmented pumps. We used to use only pumps, and the patient himself or herself used to adjust everything. But when the sensor augmented pumps came, that life started changing. The sensor augmented pump came with something called as LGS. What is LGS? Low glucose suspend. This was in 2016, okay. So whenever there is one set threshold that is kept, there is a threshold, if you have set it and the blood sugar has reached that threshold, suppose it has reached the threshold of 85 or 90 milligram per deciliter, the pump will suspend. It will not give insulin only. After some time, the next advancement that came was PLGS, that is predicted low glucose suspend. Now, suppose you have set up a threshold of 80 milligram per deciliter, and if the sensor is predicting that the blood glucose is going to 80 milligram per deciliter, it will suspend. So this was an advancement. So the first the low glucose suspend, when the blood glucose touched 80, it used to stop. Here, the second advancement, what happened is predicted. When the blood glucose is before reaching 80 only, it will stop. And this what helped is hypoglycemia started coming down, and it almost disappeared once the sensor augmented pumps came. The next advancement that came was the overnight closed loop. Overnight closed loop means the basal insulin was determined by the algorithm. It used to say, oh, sugar is high, I will give a little more basal insulin. If the sugar is low, it will give little less basal insulin. So the overnight closed loop was there. That means the higher the sugar, higher the insulin, lower the sugar, lower the insulin. And this helped in better time and range in the night time. Then came the hybrid closed loop. Why are we using the word hybrid? Nowadays we are driving hybrid cars also. Some of it comes from battery, some of it comes from petrol. Same thing. In hybrid closed loop system, what happens is, the basal insulin is determined by the pump. The basal insulin throughout the day will depend upon what is the ambient blood sugar. Depending on that, the basal insulin secretion will be more. If it is lower, it will be less. Whereas the mealtime insulin has to be given by the patient only. So whenever the person is eating meals, breakfast, lunch, dinner, or snacks in between, that has to be entered by the patient. And now we have come to the important stage that is called as advanced hybrid closed loop system. That is what is available, and that's what we are talking about today, where the basal insulin throughout the day is given by the pump, but there is one added feature that's called as correction bolus. Now what is this correction bolus? I will be telling in some time. And the mealtime bolus insulin has to be taken by the patient, but there is an added feature called a safe bolus. Now what is that safe bolus? I'll tell you. So two things have been added, and that's why the hybrid closed system has now become advanced hybrid closed loop system. Now this slide has been shown by Dr. Sharvil already. So 1920s insulin was invented. In 1980, the first insulin pump came. That man carrying a big backpack with a huge insulin pump, which was actually giving insulin IV, had come. There's no doubt why it did not become popular. Nobody will wear this sort of pump, is it not? So in the early 1990s, we started getting the subcutaneous pumps. Subcutaneous pumps were still large. They were like almost the size of a Walkman, like a tape recorder basically. In 1999, the first CGM came, and in 2006 only the sensor augmented pump started coming. Although India, we started receiving these things a little bit late. So the sensor augmented pump we started using in 2015, 2016, but it has been there in the circulation from 2006 only. After that, the advances came, the closed loop system, the hybrid closed loop system, and then finally the advanced hybrid closed system, which is now available in India from 2021. So we are using it for a multiple number of patients in then. Now look at this slide. Now this slide looks like a crazy slide, but it just tells us what are the different automated insulin delivery systems that are available in the globe. I think we should concentrate only on the first column because that is available in India, the Minimed 780G pump. The sensor that is used in the Minimed 780G pump is called as Guardian 4 sensor, and the pump is called as Minimed 780G pump. It has a reservoir which is around 1.5 ml. In the extended kits, we have reservoirs of 3 ml also. And the infusion set can last up to 7 days in the extended kit system. What is the algorithm that the Minimed 780G uses? It uses something called as PID algorithm. Dr. Sharvil briefly touched on it. I will be telling a little bit on this algorithm of PID. There are other pumps that are available in the world. You might be hearing the names from your patients who are coming from abroad. There is something called as the tandem glucometer, the insulin pump, Diabito Loop, Omnipod, so CAM APS. There are different types of insulin pump systems that are available. Those pumps, they use a different sensor. They use something called as the Dexcom sensor, and they use another algorithm called as MPS. What is MPS? What is PID? We'll come to it soon. Is there a difference between all these PID, MPS, all these algorithms? Mathematically, all the algorithms will calculate insulin infusion as a rate of function of time and change of insulin concentration. And the differences are in the way the parameters are taken into account and the extent to which the predictive glucose values are calculated. Basically, the end result is whatever the algorithm that is being used in the insulin pump. Clinical trials have shown that there is no difference if whether you're using the PID algorithm or the MPC algorithm. What is PID algorithm? It's called as the proportional integral derivative algorithm. Now, I don't think there is a point in us doctors trying to memorize this. Maybe you will probably, they'll ask you in the, in the theory paper during your final exam or something, but they're not, otherwise it's not going to be of use. But I remember 3 things which I studied in 12th standard. In 12th standard was probably around 30 years back, 25 to 30 years back. I learned about, in mathematics, they taught about proportions, they taught about integration, and they taught about derivatives at that time, PID. So proportion integral derivative is the one that is used in the 780G pump, and it is supposed to mimic the physiology closer. In physiology, what happens is there is first phase and second phase of insulin secretion. First phase of insulin secretion is the insulin will immediately change after the glucose changes, whereas the second phase, there is a more gradual increase in the insulin rather than a spike. PID algorithm also uses the same thing. So there is something called as derivative component. Derivative component is as soon as the sugar increases, there will be a change in the insulin secretion. If there is a sugar is increasing, the insulin will increase. The sugar is decreasing, the insulin will decrease. There is a component called as the proportional component. That means there is a steady insulin release for a long period of time. And there is something called as an integral or incremental component, where if the sugar is going up, there is a steady increase. When the sugar is going down, there is a steady decrease. So there are 3 algorithms. As Dr. Sharvil said, PID is not used only in insulin pumps. It's used in flights also. Next algorithm that is present is the MPC algorithm, which is present in other pumps. I will not go into detail, but it takes into certain considerations such as reference history, forecasted output, measured output, anticipatory input, past input. That means it takes a lot of data, past history, present history. It takes into a lot of artificial intelligence-based learning. Do you know where the MPC control algorithm is used? MPC in other branches of science, it is used in missile technology. And also, just now, I went to the US and came. I was sitting in a driverless car. And the car is driving exactly in the traffic. It knows when to stop, when to go, where to turn, where to left. That is all because of this MPC technology. MPC technology is not only in pumps, it's there in this technology as well. But to remember, we in Medtronic 780G pump that is actually present in India, we use the PID algorithm. And whatever the algorithm is, finally we want efficacy, we want safety, and we want effective diabetes burden reduction. If you look at this slide, it looks like a crazy slide. It looks like a slide that should be presented in an engineering class, not in a medical class. What does this slide say? That the pump is there to estimate the glycemic outcome, efficacy and safety. But that is a mathematical model. Once you attach it to the body, the human physiology also takes over. So what happens is, there is learning, new controller parameters, controller gain, time constraints, etc. will come in, and the machine starts learning in such a way that after 15 to 20 days, the pump which is attached to the person of type 1 diabetes gets so much attached to that body that that pump can be used only by that person. Now, Dr. Sharvil has told that the pump is costing 6 lakhs. And the problem with the 780G pump is if you sell it to another person, the second person cannot use, because the pump, because of its algorithm, has learned so much about you in the first 1 month, 2 months, that the pump can work only for you. It cannot work for the second person also. So that is the degree of artificial intelligence and learning that has come into the 780G pump, and it's making so much of difference. Now, when we talk about 780G pump, we need to know about 3 terminologies. And what are the 3 terminologies? Auto-basal, automatic basal insulin delivery. Second is the corrective bolus, auto-corrections it's called. And third is safe bolus. So why am I telling you these 3 things is once you know these 3 things, all the other lectures will become easier and easier. Now, what is auto-basal? So once you put the pump, again, Dr. Sharvil has told that at different times of the day, you can give different basal rates. In the morning, you can give a little bit lesser. In the early morning, dawn phase, you can give a little bit more. Again, you can reduce it. But after 14 days, it becomes redundant because the pump itself will start learning now. Auto-basal means you set something called as a basal target, 100 milligram per deciliter. What it will do is it will keep the blood glucose as close to 100 milligram per deciliter as possible. Now, I will use the example of Dr. XYZ. Okay, he's a hypothetical patient. Dr. XYZ is an endocrinology resident 2nd year. So he's using type 1 diabetes. He's having type 1 diabetes and he's using pump. And in the night when he is sleeping, what is happening is this. Whenever the blood sugar is going to below 100, the insulin pump automatically is giving lesser insulin, or it is shutting down only. Whenever the blood glucose is going to above 100, the basal insulin is going up. So it's a very simple funda. The sugar is going high, basal insulin increases. The sugar is going low, basal insulin decreases. But can this happen all the time? So all the pumps, they have something called as the maximum basal. So most of the insulin pumps cannot give more than 1 unit per hour actually, basal insulin. They will give 1 unit per hour. They cannot give more than that. Now, when the person is sleeping, when the person is not under stress, this is okay. Now I'll give you an example. Now Dr. XYZ has gone to the hostel in the morning, had a breakfast with 10 units of bolus insulin and has come for rounds. Now in the rounds, what is happening is, he's seeing a patient of acromegaly, and the head of department has come and said, what is the serum phosphorus of this level, of this patient? So doctor says, serum phosphorus, sir? Then the HOD gets angry. Come on, don't you know that there is phosphaturia and acromegaly? You should be measuring the serum phosphorus. This, that and all, he blasts. The HOD blasts the second year student. So the second year student remembers that in acromegaly, we are supposed to check the phosphorus level. But that is enough to cause a little bit of anxiety, a little bit of shame for the second year students. And the blood sugar has started increasing more than what it should have increased. That is when the auto-correction bolus will take over. So once the blood glucose goes above 120 mg per deciliter and the basal is already reached maximum, okay, it is already secreting 1 unit per hour, but because of stress, the blood sugar has gone above 120. There is something called as auto-correction. Now let us see what is happening to this patient. He is all right till around 11 o'clock. After 11 o'clock, the HOD takes a class for him. Blood sugar has gone above 120 because of stress. The insulin pump automatically corrects. Now it has gone above 120. It starts giving some amount of bolus insulin. Little by little, it starts giving bolus insulin in such a way that the blood sugar comes back to below 120. And once it comes back to below 120, the auto basal will take over. So the auto correction will start if the blood sugar has gone above 120. Below 120, the auto basal will take over. So this will ensure smooth blood glucose control. Whether the professor is shouting at him, whether the professor is not shouting at him, the blood sugar is normal only. But how does the insulin pump know how much correction to give? What if it gives extra insulin and the patient develops hypoglycemia? How does it determine all that? We have something called as the safe bolus module. Safe bolus module is artificial intelligence at its peak right now. Safe bolus module, correction bolus module, there are three components to it. I'll talk about the first one, is how it determines how much bolus insulin needs to be given. Now, when the blood glucose goes above 120, the correction bolus has to be given, but the pump will think, if I give this much units of insulin, will it actually cause the blood glucose to go below 80 milligram per deciliter in the next 2 hours or no? It will, all these features, they start kicking in after 2 weeks or 3 weeks of use only. It will not occur immediately because it's still learning for the first 2-3 weeks. After 2-3 weeks, the artificial insulin takes over. It takes care of this. It checks every correction bolus to see if it can potentially cause hypoglycemia. And it uses a prediction model to predict glucose trends that might result from a correction bolus. If a hypoglycemia is predicted, then the correction bolus itself will be reduced. Now just see in the diagram what is happening is when the professor is talking to the second year Dr. XYZ, because of stress level, the blood sugar has started increasing, but the correction bolus in light blue is changing. At one time, a little more is given, at one time a little less is given because the algorithm is kicking in and it is telling, oh, if I give this much insulin, this much sugar will go down. If I give more, it will go hypoglycemia. If I give less, it will go hyperglycemia. And therefore, artificial intelligence takes over and gives the correct amount of correction bolus only. How is the correction bolus determined? Number one, what is the present blood sugar? So present blood sugar has gone up to say 140 milligram per deciliter. What is the rate of change of glucose? Is the glucose rising very fast? Is it rising very slow? Is it coming down? So the machine will take. And also it will take into consider recent insulin delivery. What does recent insulin delivery means? I just told you that the resident has taken 10 units of insulin during breakfast, and then he has come to the rounds and the professor has scolded him immediately, and then the sugar is going up. The insulin pump will say, "Arey, you've already taken 10 units just 1 hour back. I will keep that into consideration and then only calculate the insulin now." And this is what happens. So you can see that at 140 milligram per deciliter, first the pump says, "Okay, I'll give 1 unit correction bolus." Then it says, "No, blood sugar will go below 80. Then it says, "Okay, I'll give 0.75. No, the blood sugar will go below 80. Then it says, "Okay, I'll give 0.5. Then it predicts that with 0.5, blood sugar will not go below 80, and it gives 0.5 units only. So this is artificial intelligence at its peak right now. Next is meal detection technology. So there is something called as occasional missed bolus forgiveness. Missed bolus forgiveness means ideally anytime the doctor XYZ eats any food, he has to enter the carbohydrates and take the bolus. But sometimes because of stress, anxiety, they might forget to take the bolus only. Now in this case, Dr. XYZ was shouted by the professor. He's feeling ashamed, anger, irritated. Then they go to the side room where chai and biscuits are being served. So he also takes the chai and the biscuit, but because of his irritation and anger, he has forgotten to enter the bolus. What the sensor will now detect, the blood sugar is again started increasing. But the sensor will say, when he was under stress, the blood sugar was increasing slowly. Now suddenly it has increased because he has taken Parle-G biscuits. Suddenly the blood sugar has gone up. So by taking the current and the past glucose trend, it will say, okay, this is not stress-induced hyperglycemia, this is a meal-induced hyperglycemia, and therefore the correction bolus which is given will be a little more aggressive right now. That is a very important thing to remember. That is again artificial intelligence at its best. But of course, we should tell our patients, don't rely too much on this technology. Please take the bolus regularly. Sometimes if you miss the meal, it will take over. My second last slide is this one, the safe meal bolus algorithm. Now, as Dr. Sharvil said, whenever we are eating food, we are supposed to enter the carbohydrates. Now this doctor, what he has done is, after the rounds, he has gone for lunch. And in lunch, he has said that he is going to eat 80 grams of carbohydrates. And according to his insulin carb ratio, he is supposed to take 10 units of insulin, okay? Now the safe meal bolus algorithm will think like, okay, now if I give 10 units of insulin to this Dr. XYZ, will he develop hypoglycemia? Because I've already given 2 correction bolus in between. Once when he was under stress, once when he took chai and parle biscuit, that time his blood sugar has gone. Already I've given insulin. But as per his calculation, he's supposed to take 10 units during the meal. Again, it will check whether the meal bolus will cause hypoglycemia or no within the next 4 hours and uses a prediction model to prevent hypoglycemia. So what happens is, when he's supposed to take 10 units of insulin, it will say, if I give 10 units, will it cause hypoglycemia? I won't give 10 units. Shall I give 9 units? I won't give 9 units. Okay, shall I give 8 units? Then it says, okay, when I give 8 units, his blood sugar will be normal. So although as per calculation, he is supposed to take 10 units, the amount of insulin which is entering the body is only 8. Therefore, hypoglycemia is prevented once again. So that's where the algorithm works very well. And you can see in multiple patients with all the esteemed faculty and all our people who are having, you can see most of them, hypoglycemia does not occur only once they are on 780G pump. And the blood glucose starts coming to 7%, 7.2%, 6.5% without developing hypoglycemia, which is an absolute boon for people with type 1 diabetes. So to conclude, algorithms are proven to be safe. Number one, safety is paramount. In type 1 diabetes, hypoglycemia should not occur. So safe, and it is effective in driving the insulin delivery, and it is shown to reduce the diabetes management burden. Especially if hypoglycemia goes away from your life, hyperglycemia can be a little more easier to manage. Hypoglycemia goes away from your life, it becomes very easy. And closed loop systems is a near-term reality. That closed loop means even the bolus need not be given. Even the bolus also, the insulin pump will also only decide. Then it is called as artificial pancreas. That is coming to a near-term reality. But right now, the advanced hybrid closed loop system algorithm is the best as far as what we can offer for type 1 diabetes. Cost obviously is the major constraint, but many people, after putting on a 780G pump, they never get admitted to the hospital only, neither with DKA nor with hypoglycemia. So they save a lot of money because of that. But to explain that to a patient in a limited time in the OPD is very difficult. We need to master that part. So I'll like to conclude by just asking one question. After listening to all these algorithms, I'll give you 3 scenarios, okay? There is a European living in Switzerland. A European is living in Switzerland. She also has celiac disease. She has been put on a 780G pump. There is a gentleman living he's living in Himachal Pradesh. He has hypothyroidism and he has been put on insulin pump. And there is a South Indian Dravidian guy in Tamil Nadu with a big tummy. He has been put on insulin pump. In which patient the insulin pump will work better, 780G? Will it work better in the European patient? Will it work better in the Himachal patient with hypothyroidism, or will it work better in the South Indian? What do you think? Swiss guy? Anybody else? Which one it will work best? Best means best. Hypothyroidism and type 1 diabetes, both are there. Yeah. The answer is that only. Insulin pump 780G, because of artificial intelligence, does not distinguish between race, it does not distinguish between gender, it does not distinguish between comorbidity. It will work equally in everybody. Because of artificial intelligence, over a period of 15 to 20 days, it will work equally in American, Switzerland, North Indian, South Indian, anybody it will work equally. Only thing is paisa. So once the paisa part is settled, once it becomes more and more accessible, I think this is going to be the future for management of type 1 diabetes. Thank you.
Thank you, sir. Thank you for the wonderful presentation. Also covering a very complex topic in a very simple manner. Next upon, I would like to call upon Dr. Titu Umen or the onboarding of the review of the AID system, the initiation and the follow-up.
At the outset, I thank the ESICON team for inviting me. It's a great opportunity to be at this great venue and this great meeting. So my job has become quite easy now. So we all should watch out. Trump might add another tariff on us because of Dr. Sharvil, including him in making this slides. And most of you are hearing Dr. Santosh's talk, might be feeling that analyzing or putting on a pump might be a tough nut, so much of the artificial intelligence algorithm. But he has taken the role of Rahul Dravid, taken all the hard new ball stuff, and now it's easy for a chap like me to explain about how the pump actually works. So if I can do it, you can also do it. It's not like all intelligent people like Dr. Santosh alone can do it. So using this pump is very easy. So I'm just going to run through what is this artificial intelligence going to do in the real life scenario when we put the patient on a pump. So we'll just have a quick look at how the onboarding, how to put a patient on a pump, the initial CGM settings, and how these smart features come into play, and how do you optimize therapy. So you have to understand that even if you have a smart pump or the latest generation AHCL pump, you have to initially run the patient on a manual mode, because it takes at least 48 hours for the smart guard or the artificial intelligence algorithm to understand that patient's blood sugar variations and the PID. So PID proportion, you can forget that PID, the way, no need to know about that, because whatever be the basis of the artificial intelligence, that is, you don't have to understand the algorithm, because that is being done by the pump. There is no use of you understanding that. So that has to be in the background of your mind as well as the patient's and the caregiver's mind, because I worry about PID in a different way. I worry about the PID, the patient / parents interfering with the device, trying to incorporate their intelligence into the artificial intelligence. That's when the actually errors come in and a lot of the things that don't happen. So the minimal interference, you let the pump take care of it. So this is going to be very difficult for the patient, because they have been, or their caregiver has been entirely in control of their blood sugars, how to eat, what to eat, when to eat, how much insulin to give. And from that, you are going to go to something where there is very minimal input from them. But as said, initially, you have to set some settings in the initial part. That is, when you put on a patient who has been on multiple daily injections and you're putting onto the manual mode, First, you reduce the total insulin dose. Then, for the basal calculation, then you convert that into at least 50%. So if still the basal insulin dose is more than 4 units per 0.4 units per kg, you have different calculations. And then you can put it into 1 or 2 divisions. That is a 24-hour, you can have 1 24-hour dose or 2 base, maybe a little bit reduce it at night. But actually it doesn't matter. You select this, you put it, because within 2 weeks, the algorithm will decipher. So, you don't have to invest too much of your time and energy into thinking, did I use the 0.2 or the 0.3? And again, go for the most simple calculations for the bolus also. Insulin carb ratio is 450 by total daily dose. In India, in insulin sensitivity factor, we use 1,800 by total dose of insulin. Try to keep blood glucose target between 100 and 220. And the active insulin time, again, we have heard about what is active insulin. Keep it between 2 to 3 hours. Let these be similar numbers. I'll tell you with a study which points out that we may not have the artificial pancreas now, but we are very, very so close to that. If you keep your common sense and your environment to minimum level, actually the artificial intelligence will take care of most of the other things. For a patient who is switching over from a manual pump to an AHCL pump, only the bolus settings have to be kept like this. The basal settings you can go for what was there in the previous pump. When you onboard, you are putting the patient on the pump. The first thing that we usually do is make a WhatsApp group with the patient or the caregiver, our diabetes educator, the consultant, somebody from the technical team, to ensure that they have immediate answer to all the queries and adjustments. So these are the initial settings to be given. So in the CGM, in the sensor, you have to have default, the alert on low will be there, but try to put on the suspend before low. The low limit will be kept at 70. You generally keep the target, basal target at 100. Children, maybe you can keep it up to 110. Keep all the auto corrections on. So this is what I was saying. The effort from the clinician is for and the patient. The clinician telling the patient is only for one thing. Count your carb. Don't forget to give the bolus. Learn how to put the sensor and the attachments, prevent infections, all that. Your hands-on training will show you how to attach and all the quick set and everything. So those technical things are the only thing to be learned. From the pump aspect, only 2 things. See what you are eating, try to calculate the carb, enter that carb. The physician, the clinician, what will they do? Clinician has to enter the pre-specified insulin carb ratio. You have to enter an active insulin time. You have to select. These are not big things. You can actually, carb ratio, you can prefix even if you put a carb ratio as 10 gram, nothing will happen. You put an active insulin time as 3 hours, nothing will happen. Auto basal target 100, that's it. In 14 days, your pump will, the AID will find out how much are the fluctuations going on and it will adjust on. So how does this actually works in a pump? So Dr. Santosh told about this PID derivation and all. So in the first is that as soon as there is going to be a fluctuations, there will be auto corrections given every 5 minutes and the pump will. So this pink shades going down are the basal rates and the pump is trying to adjust for the basal rates. The blue bars are the auto correction. So after a point of time, the basal correction cannot adjust the blood sugar. The pump algorithm determines that and that gives an extra auto correction bolus. That is the blue bars. Again, the point is to keep the glucose variations back to normal. And this also can happen once in 5 minutes. And this is how an auto basal will work. So you can see here, the auto correction may help a missed meal. So Dr. Santosh spoke about how the missed meal, smart bolus. So you can hear the pump has determined that the patient has forgotten and he has forgotten to eat and the pump has given an extra bolus. So what are the basics in that? You don't have to enter the blood glucose levels in the modern pumps. If at all, occasionally when the algorithm doesn't work or the sensor was detached, the new guardian sensor doesn't need calibration, so you don't have to calibrate. But suppose after a prolonged hypoglycemia, take an oral glucose load or something, the hyperglycemia is so prolonged, sometimes the pump will ask you, check blood sugar, enter the blood sugar. Only at that point that you need to enter the blood glucose. Otherwise, you don't need to enter the blood glucose or calibrate. The only thing that you have to keep on reminding the patient is that enter the carbs. So when you enter the carbs, it will help the pump to prescribe or advise a bolus dose. That's the only thing that is to be needed. So this is an example this is exactly what Dr. Santosh spoke about, the safe meal bolus. That is, according to the carb counting, it was ICR is 12. The current glucose is 187. So you needed, actually, if you calculate and give the bolus, it should have been 7.5. But the pump has discovered that the rate of change of glucose at this moment is too fast. And if you give a bolus of 7.5, the patient will go in for hypoglycemia. So the pump will tell you 6. So if it was a manual pump, or if it was not a sensor augmented pump, you would have given 7.5 based on the sensor readings, an exact carb count, and the patient would have landed in hypoglycemia. But here, these calculations are happening. The patient doesn't have to remember anything. The patient just have to enter the carb value. This calculation is done by the pump and tells that your bolus instead, the bolus is given as 6 bolus. You have to enter the 6. So this is what generally the pump interface will look like. The smart shield, this shield tells you that the patient is on the AID pattern, the smart guard feature. It is what AID is being working. Lower corner, active insulin will tell you how much you have put, how much active insulin left behind. And the upper green circle there tells that the sensor is working. And then when you click that diamond star on the the pump, you will go to what is known as the screen, the sensor graph. So these are the things that are seen in the sensor graph. This is the actual sensor glucose value as of now. This is the graph showing that it is within the range. These blue bars are the auto correction. This is the basal. This was the meal given. This was a temporary target while the time of exercise. This is a previous generation, so that is why there was a blood glucose for calibration entered. And again, bolus insulin again given at that time before the meal or reduction. So this is happening to the patient over a period of time, and this is the accurate sensor reading given. So the different boluses, so there was a blue line going up, and the correction boluses made sure that the sugars were remaining in normal. So this is my patient's screen when we had onboarded the patient. You can see it's just learning. It's a video actually. You can slowly see that it is moving. It's going above 400. It's of an 80-year-old child. She eats her on wish and 780 G. In the initial 2 weeks, it's not great control, 340. It's how the AID is slowly learning to match that child's different times. The basal is on full blown. The pump's AID is being stretched to its limit, trying to put the sugars in balance. So this is the initial part. Then slowly after 2 to 3 weeks, this is the next part. So after 2 to 3 weeks, you can see how the AID has captured this child's patterns, frequent snacks, missed boluses, almost all missed boluses because, it's she was put on the pump when she was 7 years, so she will not listen, she will go and have her own food. But because of the pattern is there, the pump actually keeps track and always keeps after the 2 week run-in period, still, you can beat the algorithm too by extra snacking or ice creams or chocolates, but still, whatever said, and their life changed. The mother was also a type 1 diabetes lady, and her twin, one of her twin sibling child had type 1 diabetes, and the mother was not sleeping for months because she will go in for hypers at night. After putting on the 780G and once a smart guard was introduced, was a time when she could take care of her own health and have. This is what, see, it's a child. You can make out the graph that, that still the AID could manage a very, very good, decent enough job. So the initial part, the technical focus should be, teaching about pairing the sensor with the pump, making sure that they are counting the carbohydrate, making sure that they are giving correction boluses if at all needed, how to look at the pump interface, what is happening, and to check all these factors. And the sick days, other parameters, all we will be discussing in detail. And you have to remember to look at for the blue shield and the green circle, showing that the blue shield should be on maximum time. That is, the patient should be on smart card feature, and the green circle means the sensor is working. These two should be there. And even for clinicians, they have, Medtronic Minimed has a quick ready guide. You can get people who are using the pump should keep a printout in this so that you know what to happen. That is, within this one interface, you can have all at one go. That is, if you press the up button, you can suspend the insulin delivery. Diamond Star, I told you about the sensor data. If you right press, it will go to the time in range. So these are all the quick shortcut buttons where you will learn you have to know on person if the patient calls or your educator should know about these things. Now, how about optimizing therapy? That is, you have onboarded, the AID has worked, and now you have to interpret the sensor data. There is a detailed session on interpreting sensor data. But whenever you do any intervention, allow some time for the system to learn it. The only two things that you might have to change is the insulin carb ratio and the active insulin time. And again, I keep on reiterating the fact that encourage patients to count their carbs. This is what we hope for. When you see the graph, look at these 5 parameters. That is, we hope for HbA1c less than 7. We hope for time in range greater than 70% and smart guard greater than 85% with sensor usage greater than 85%. If this is not done by the patient, then they are not utilizing the HCl or the 780G pump to its maximum benefit. So if you look at this, these are the only 2 things you have to see. Sorry, it has not come out very clearly. So the auto mode is there on more than 90%, sensor is more than 90%, time in range is around 80%. So this shows that this pump is being utilized to its full extent. So what do you do when some of these things are met? Insulin carb ratio and time in range has the maximum effect of glycemia. So we will need to adjust it if at all some values are off. And active insulin time is useful when we are giving correction boluses. When you feel that post-automatic correction still hypoglycemia is occurring. So how do you adjust the pump setting when the time in range shows time above range is high? Now, look at the report to see if it is a preprandial glucose rise. Then it means basically that the patient is not bolusing earlier. It's too early rather than what kind of insulin they are using, whether it is a fast-acting aspart or aspart, the accurate bolus time should pre-meal bolusing is not correct. If the postprandial glucose is high, then ask them whether they are giving the actual bolus, and if at all, if they are doing the bolus, maybe you can consider reducing the ICR so that you will get more control. What if time below range is high? Time below range, again, look at the timing of bolus. They might be overestimating the carbs. You might have to increase the ICR, and then still nothing is work. You can consider increasing the auto basal target from 100 to 110. Maybe the pump's algorithm is. Then, if post-correction hypos are occurring, you can consider increasing the active insulin time. Hypos at night, consider snacks. And again, you can consider adjusting the smart guard target if nothing is working out. This will be covered in the later session. So if the sensor use is less than 80%, the patient is on a majority of time on manual mode. So if the patient is on majority of time on the manual mode, you will not get any of the values or time in range like that. So ultimately, as I said, the PID should be enforced from the pump's aspect. The PID from the patient's interference with the device should be kept to a minimum. They should have this CareLink account. Then only the clinician can see in their clinic and your educator can adjust. They should enter the appropriate carbs so that the bolus is entered. And the mobile app should be used to its maximum. Then only you will have automated uploads, and you should always look at the screen. To end the discussion, they had a study done which looked at flexed meal management versus fixed meal management. That is, precision carbohydrate counting was preferred. Both groups of patients were put on 780G pump. In the fixed meal means, they looked at last 7 days calorie carb counting, and they fixed that is somewhere in between. Big meals means 50 to 70, snack means 10 to 15 carbs. Fixed meal, patient just have to see whether it is a regular meal, large meal, or it is a snack. They don't have to count the carbohydrate or anything, just enter a predetermined carb value. At the end of the day, the flexible or the carb counting people had a better time in range, but still the fixed people with minimum involvement also had more than 70% time in range. And there was no statistical significance between the HbA1c achieved. Time below range was very low for both the groups. There was a continuation of these studies. People were followed up. This was for initial 3 months only. They were followed up for 1 year, which again proved the point that the time in range was much better in the more active people who were doing the carb counting. But even if you were fixed carb, you could choose, saying that, okay, if it's a large meal, put the carb as 70 gram. If it is a snack, put it as 15 grams or something like that. And then put the ICR and tell them. But even if you do that, fixed carbs with the 780G pump, the HbA1c and the time in range is better. And with that, I come to the end of my presentation with the Onam wishes from Kerala. Thank you for once again for this opportunity.
Thank you, sir. Thank you for the wonderful deliberation. Next upon, I'd like to call upon Dr. Uday Farke, sir, for the interpretation of the AID device reports. Yes, the point is here, right?
Thank you very much. So after all this, one might wonder what is the role of the doctor after the pump is fitted. In fact, there is a famous truism which was actually asked to some people using pumps or in the pump industry, will the doctor still remain relevant? And first the answer was, well, you really have nothing to do. So I'm just going to show a little bit about interpretation of CareLink reports that are generated while using the pump and tell you how the doctor still needs to be in the picture or in the loop when using the advanced hybrid closed loop systems. So essentially, when we are looking at pump users, the pump generates data and it produces what are called CareLink reports. All those graphs that you saw just now are actually called CareLink, and they're available online both to the patient as well as to the treating doctor. The first important thing in this setup, when you look at a CareLink report, is to look at whether the goals and the therapy targets are being met or not met. In fact, if they are being met, then practically you don't have much to do. Agree. But if they are not being met, then you need to look at the therapy that is going on. That means the pump settings, the types of boluses, the timings of the boluses, the behavior of the patient, etc. And it's time to change some of these settings. When you look at CareLink reports, these are broadly the things that you will see on the CareLink report. You will have an initial assessment and progress chart, which tells how well the patient is doing or not doing. Then there is a weekly review, which tells you about the glucose reading or the sensor readings and the trends over several days in a week. It also gives you how the patient is using the meal boluses, which have been repeatedly stressed upon by the previous speakers, because it's a very important part of management. The basal correction is being done by the pump, but the patient's role in announcing the meal, adjusting the bolus, putting in the carbs, still remains important. Once you have a top view of the week, you also have what is called daily review. So in a week's chart, if you find a particular day which is of concern, maybe it's a Sunday, maybe it's a festive day or a birthday party or something, you can go to that particular day and look at what is happening on that particular day and help the patient understand what went wrong on that particular day. And finally, you sit with the patient and make changes in the device setting. So this is how the flow goes. First, see whether everything is right. If everything is right, you and the patient both go home practically. If not, then this is the set that you need to go through. So this is actually the progress report, which comes up first on the CareLink sheet. And what it tells you really is, very importantly, it gives you all features. I cannot read them out. We have very little time here. But what it tells us is the patient wearing the sensor as expected? Is the patient changing the quick set as expected and the reservoir? Has the patient put in the correct active insulin time, which often is about 2 hours? Is the target set correctly to, say, 100 milligrams? Because that's a good target to use, unless we are dealing with elderly patients or very young patients or people with renal insufficiency or advanced cardiac disease, etc. And then you go to what's happening. Has the pump been shutting off? So there are patients who have a tendency to just shut off the pump and go, kind of missing for some time. You can see that on the pump setting as well. Then you look at the time in range. You know that in type 1 diabetes, it's almost impossible or impractical to keep time in range as 100%. You would create too many hypos. So an acceptable time in range is important. Also look at whether there are too many hypos or too many hypers going on. And this broadly tells you how the patient is doing. And these are the broad targets that you need to follow. A 70% target actually would indicate that the patient is doing well. What does this 70%, where does this come from? From all mathematical projections, it's shown that a 70% time in range seems to correlate with a HbA1c of about 7%, or what is called the glucose management index of about 7%, therefore 70. It's not that you should not aim for 75, but at least 70, and then of course you prevent lows and highs as well. So this is something which is very important. After this, if the patient is reaching the goal, well, you don't do anything, just check the pump settings and the patient is okay to go home. If, however, they are not reaching the goals, then your job starts. And then, of course, you move to what is called the review of therapy. And this is a broad 3-page summary of what you need to look at. Again, for paucity of time, it's very difficult for me to explain what each of this means. But in the first graph on the left, you're looking at the meal summaries. What it tells you is the patient telling the pump what meal he had, he or she, which means announcing carbs, telling us whether the bolus was given at the right time, which means about 10 or 15 minutes before the meal, or was it given late, or was it completely missed? All that will come in the meal summary report, and that gives us a lot of information, especially if the postprandial sugars are going high. So particularly for postprandial hyperglycemia, this is the page to see, that is the meal summary. Then you go to what is called the weekly review report. As you can see here, this is a summary of 3 particular days, showing you ups and downs. Now, if you look at them, again, what you can do really is first look at overnight levels, that means the basal levels, that means from midnight, say, to 6 a.m., and see how the basal function is happening. And most of the time, you will realize that unless the patient is really erratic, or the creatinine is high, or he has missed meals, or needs a snack at bedtime, you will often find that people on pumps will have a good overnight blood sugar level. That means the basals are doing well. However, many times, as you can see, these large peaks that you can see are typically meal related. Now, once you identify the day on which the maximum problems have occurred, you can actually go down to that particular day to assess what could have happened. Now, this is one such day that we have looked at. And if you can see here, from 12 midnight to 7 a.m., 8 a.m., till the patient had the first meal, everything seems to be absolutely flat, no problem at all. And here, at the time of breakfast, there is a jump. Now, if you see, what should have happened before the breakfast was, there should have been an announcement of carbohydrates, and there should have been a bolus. You can see here that there is no bolus at all. Bolus is represented by a line, a blue line there. The pump realized that there has been no bolus taken, and it made its own action by giving, as you can see, multiple small dots here, which are actually corrective boluses given every 5 minutes till the sugar came back to normal. Again, at approximately lunchtime, the patient has forgotten to give a bolus. Again, the pump kicked in and gave, as you can see, multiple corrections doses here. So the pump will work. It's not that the pump will not work if you forget to deliver a bolus, but it will do so only after the sugars have risen. And this particular spike here and the spike here doesn't augur well for a good HbA1c. It will create ups and downs. So the pump will kick in after the fact, but the best way is actually to do it before you hit a hyperglycemic peak. I'm going to skip some slides for paucity of time. But ultimately, what I need to show you is a case which highlights what I was talking about, that is the role of the physician. This is a patient. This is her pre-treatment graph. These are typical CGMs that you see in many patients of type 1 diabetes. And despite a lot of training, despite a lot of training, both to the child, she was a very intelligent child, as well as the parents, the CGM graph continued to remain grossly abnormal. And you will see that the time in range was somewhere around 10 to 15% at max. There were a lot of hypers, and there were some hypos as well, particularly in the night. And this was the best that we could do, despite wearing CGMs all the time, despite a good counseling about diet, etc. Now, these were obviously the challenges. A lot of fluctuations, a lot of adjustments, and yet HbA1c was still remaining around 9.5 to 10%. CGM did not show any, achievement of any target. And therefore, this pump, the automated insulin device, or the Medtronic 780G, was started in December 2022. Now just see, this is her first CareLink record, 14 days after we started the pump. And already from about 10 to 20%, her time in range had moved to 50%. Now you'll say 50% is not very good, and there are still a lot of hypers, 48% are high, 2% are low, but this is clearly better than what we are dealing with, that is about 10 to 20%. And in fact, the hypos had reduced now significantly to less than 2%. That itself was a big achievement, because the parents were in mortal fear of this child. One of them constantly used to sit at the bedside, looking at the patient, and they used to take alternate nights to sit beside the patient. Now, after a year of therapy, you will see that the time in range is now roughly about 60 to 65%. Again, not very ideal, There are still highs, but by this time, the patient had moved to a hostel. Overall, the satisfaction was there, but the patient had moved to a different town. She was now about 17. She had moved to a hostel. There were fixed timings in the mess. She also had some psychological issues, underlying stress, and we decided not to change the pump settings too much. She was also not very comfortable in doing this more aggressively. And so we had left it at about 65 to 70, 65% or thereabouts as her time in range. She came back a year later now, and you can see that the time in range has now dropped to 55% from about 65%. Her time above range is quite significantly high, and she's not at all well controlled. Her HbA1c is definitely abnormal. This is what her CareLink data shows again. And now if you see from the previous, this is, as I showed you, the weekly record, you will see here that there are multiple spikes occurring. At lunch, sometimes again after lunch, this is a peak after dinner, this is again after lunch, again after dinner. And we looked at her data, and you will see here that again, she has forgotten to bolus at breakfast. Here again, she took a bolus, but it got delivered late. So she started a meal and then realized that she had not bolused. Perhaps she is bolusing a little less. There are other things, of course, which can be seen here. I don't know how much time I have or how to explain it very well, but there is something called fake carb entries. What happens is, she realized that she had taken a bolus at lunch. She had taken it actually already when the blood glucose had started increasing, which means she took it somewhere in the middle of lunch, not before lunch. Then she realized that the blood glucose had gone up further. She took another bolus, say maybe after 15 or 20 minutes. She realized that the blood sugars are still high. So you see here, there are 3 or 4 more lines, blue lines, where she didn't eat really, but she just entered some carbs, kept on entering some carbs, and the pump kept on giving boluses according to a meal correction. Okay, she forgot the concept of auto-correction bolus. She announced carbohydrates. What happens therefore is that the pump becomes very aggressive. When it realizes that you're consuming so much carb, it automatically ups the basal bolusing. And therefore, these people are typically in a danger of getting a hypo, say 2 or 3 or 4 hours later, because the pump has upgraded itself because it feels that this patient is eating a lot of carbs. So actually what should have been done there is, once she realized that her sugars are high, probably because she did not bolus in time, she did not bolus adequately, was to have given a correction bolus, but not a meal-related bolus. So she didn't eat a meal, she faked the carb. So this is all a part of education. So the main thing that was told to her was, you probably need to increase the insulin carb ratio. That means not increase, minimize the insulin carb ratio. So suppose you're taking 1 unit for 10 grams, start taking 1 unit for 6 grams. That's what I mean. Take the bolus correctly 10 to 15 minutes before the meal. She was also showed what to do with the correction bolus, and she was told to trust the algorithm. The algorithm works if you give it enough time. It takes at least 48 hours again for settings to take place. And look what happened. 15 days later, no, this is in August now. All these corrections were done in June. And again, now she has reached 90% time in range from 58. So that's a huge improvement. And if you see the CareLink report now, it is practically a flat line. So just these behavioral changes, and this is the weekly report, you will see here now that the insulin carb ratio has changed. She is now bolusing correctly at breakfast. She is bolusing at lunch. She is bolusing at dinner. There are hardly any hyperglycemic peaks occurring. So just this change in pointing out where she went wrong is the role of the physician, and therefore the care link report becomes extremely important to, you need to really sit down and discuss with the patient what is going wrong. It's not easy to get this on day one, believe me. It is a very technical report, and you really need to sit down, understand what all these purple and blue and sort of shaded lines and black marks in between, and you probably cannot see this blue autobasal corrections and so on. But ultimately, if you get the hang of it, it comes right. So again, to reiterate, look at the targets, whether the targets are being met or not met. If they are being met, well, that's it. You don't have much to do. If they are not being met, go to three things. Look at how the patient is treating the meals and the meal-related boluses. That comes in the bolus results. Then look at the weekly report data to find out which day probably was the worst or the most representative of the problems that are occurring. Then go to a particular day in that weekly summary to understand what went wrong. As I showed you in this patient, the bolusing was not correct, the insulin-carb ratio was not correct, the boluses were being missed, they were being given late. She was announcing what we call fake carbs, not trusting the algorithm enough, and so on. And then ultimately you make these corrections. At the same time, never forget to see whether the patient is changing the reservoir and the quickset at the prescribed times, which is currently about 2 to 3 days. Also see whether the patient is discontinuing the pump for some reason, which could be social, at parties, she doesn't want to look bad or something. And this is a common thing about in adolescents, that they don't want to make setting changes while they are in a party, so they just forget about it. They don't announce carbs because they don't want to be seen doing so. All these things have to be discussed again and again and again with the patient. So pump therapy is extremely effective, but does not manage all aspects independently. There is a need for maintaining optimal pump settings. Continued patient education is an absolute must. So my personal feeling at the beginning of when I started using the pump was that, well, I now don't need to do anything at all. That has changed to I need to do something, sometimes at least, when things are not going correct. Thank you very much.
Thank you, sir, for your keen insights regarding the AID device reports. Next, I'd like to call upon Dr. Sachin Mittal for the meal management.
Good afternoon, everyone. At the outset, I would like to thank the organizers, the entire team of Ensicon 2025 for the kind invitation, for the wonderful warm hospitality, and also congratulate them for this hosting of Ensicon 2025. So what we're going to be talking today, that is meal management and insulin pump therapy. I have just digressed it a little bit and tried to make it more wider in terms of how important the meal management it is in day-to-day management of type 1 diabetes. And you heard speaker after speaker talking that how, what you need to do is to put in the carbs and then the algorithm will take care of that. What the pump does not know is how much the patient is eating, what kind of food the patient is eating, right? So the goal that we're going to have is that to make this thing as easy for you so that when you have a patient of type 1 diabetes in the midst of your busy OPD, you don't feel overwhelmed. You don't think कि इसको carbs counting सिखाना पड़ेगा, how much time I can devote, can my educator know about it or not, right? So meal management ideally should be done before you put the patient on insulin pump, not after putting the patient on insulin pump. Because meal management is something which you can do without insulin pump also, and a lot of advantage can be taken in terms of eventual outcomes when you do a meal management in a proper way. So that's the goal we have today. And we know that insulin delivers, the pump delivers the insulin in a very, the rapid acting insulin in both the basal as well as the bolus forms. And for giving a right bolus, the right meal management is actually the very integral part of it, and that actually determines a lot of outcomes. You heard Dr. Uday Phadke talking how a patient was, faking input of the fake meal entry and actually fake carb entry, and actually no meal was being taken at that point of time, and how it led to worsened outcomes. So important thing to realize is that meal management is less about restricting, more about working with the patient, how they can have better outcomes, what kind of food categories are there, and how in a simplified manner they can do the carbohydrate counting, right? So we know that carbs, they have the most important role when it comes to increasing blood glucose level, and estimating what is the type of carb and the amount of carb is actually paramount when you want to do a right bolus management, right bolus strategy for the patients. What is our goal? Our goal is, say you have a patient, right now it's 2 o'clock, you have a patient whose blood glucose level is so and so, patient is going to eat a certain amount of meal and you want to give the bolus dose, right? That's the goal, right? So what information you need to calculate the right bolus? What information you need? Anyone? What information you need? Carbs, right? That means what food the patient is going to eat. Patient machir bol jhol khane wala hai, ke dal roti khane wala hai, ke aloo paratha khane wala hai, whatever the information, right? And then what is the sugar level right now? Do you need that? Why do you need that? Because right now the sugar is not going to be dependent on the bolus, but why do you need that? For the correction bolus, right? Pumps have the figure out, the automatic pumps do have it figured out on its own, but that's a calculation. You can arrive at that calculation on your own itself. You can teach that patient without pump itself, right? And we'll talk about it. So basically, what you need is 2 sets of info. How much is the carbohydrate content of that food, number one. And second thing is, as speaker after speaker talked about something called as ICR, which is insulin carb ratio. What is insulin carb ratio? In one simple line, if you talk about what is simple carb ratio. Yes. So if you give 1 unit of a bolus insulin, how much carbohydrate it is covering, right? So it's very, very simplified thing. So if you have a higher ICR, what will be the dose of insulin? It will be high or it will be low? If you have an ICR which is high, you will require less dose or more dose? Less dose, right? If you have a low ICR, you will require a higher dose, right? So what is ICR? As we discussed, it is how much insulin you need to cover a specific amount of carbohydrates. As a starting point, you can think about this. 500 divided by total daily dose, that is your ICR. I said the word as a starting point because there are a lot of refinements you'll need to go into it, lot of changes you can do into it. So suppose the total daily dose is 50 units and the ICR becomes 10, right? And this means 1 unit of insulin is actually covering 10 grams of carbohydrate, right? Now, what next? This actually depends on number of factors. What factors? What is the individual insulin sensitivity? What is the time of the day? Usually you find the ICR to be lower at certain times, higher at certain times. Typically, patients tend to be more insulin resistant in the morning, and you find that ICR requirements may be higher, insulin requirements may be higher in the morning, right? Physical activity, obviously it depends on physical activity. A lot of patients do physical activity in the evening, so accordingly the ICR changes. Hormonal factors, right? Many times you find that situations in number of situations. So how do you calculate a bolus dose? So to calculate a bolus dose, now you have this phenomenon. That is, now you know the ICR. My ICR was 10, right? The patient, how many carbs the patient is going to eat, I divide that with the ICR and I get the bolus dose. Simple, easy. Now we want to know how much carbs, right? That is a tough time. I can tell you, when I was a DM resident, I found it so hard. Every time I used to open Google कि 2 chapati में कितना है, गोभी के पराठा में कितना है, आलू के पराठा में कितना है, that used to be a challenge. So that's what we want to simplify it, and that's what we have been using in our setup in my practice for some time. As earlier speakers also highlighted, pumps actually do that calculation on their own based on active insulin time, ki kitna insulin bacha hua hai. You can talk of the onboard insulin also. You know, earlier times when we were not using pumps, we used to call it insulin stacking also, right? That's how all our teachers have told us about it, right? And blood glucose corrections. What is blood glucose corrections? Blood glucose corrections is, if say my pre-meal sugar right now is 200, right? I need to correct for that, right? If say my target ideal is 120, but my pre-meal sugar is 200, I need to correct for that. So what is that correction factor? For 1 unit of that short-acting insulin, how much glucose is actually going down? That is the correction factor. People also call it something called as insulin sensitivity factor. Again, you can have a very starting point, raw starting point. People use 1500, people use 1600, people use 1800. I use 1700 because that is what I've seen in my practice that it works well as an initial starting point. 1700 divided by total daily dose. So if total daily dose is 40, you have 42.5, which basically means that 1 unit insulin 42.5 milligram kam karta hai, right? As simple as possible, right? So another way of calculating is this. If say my patient has eaten a meal at 1:30 or 2 o'clock in the afternoon, I check the sugar, not eaten anything afterwards, the short-acting bolus has been given, I check the sugar again at 6 o'clock, and if the sugar is say XYZ, say 200, let's take an example, I give 2 units of bolus insulin short-acting without giving any carbohydrates and see what happens, right? And after 2 hours, I recheck it again. Say if the sugar goes down by 80, I just divide that figure by 2, whatever I gave, and that gives me the ISF of that particular patient. Again, that's a raw calculation. That is a jugaad that we have been doing, but that actually works well for most of the patients, right? So you can actually, as I said, there is no hard fact science that this only will work. It's not like law of gravity. You know, you will need to adapt, you'll need to learn, you'll need to improvise, you'll need to refine. But these are the good starting points for you to start, right? Now, pumps actually have that figured out in terms of this is 780G. So you can see that it's start time, end time, what is the insulin sensitivity factor, you can figure out. So in this particular patient, it is 55 mg per dl, which is the insulin sensitivity factor, which is figured out over here, okay? So now, this is the list of common foods. Honestly, I never remembered it. I just kept a printout of that in my OPD. Whenever I wanted to tell it, I had to, you know, simultaneously read it in front of the patient. It was very hard to remember it and sometimes Google it. Right now, I found a simpler way and I'll go to that simpler way also down the line, right? So what is more important is to talk of this concept of what is high carb versus low carb, right? You generally want the family to get that idea that this is a category which is bad for the patient and this is a category which is good for the patient. So you want to give that broad bucketing, you want the family to create that bucketing in their mind, because once they have created that bucketing in their mind, they understand, okay, when they're eating out also, we have to order from this category, not from this category, right? So that bucketing really goes a long way in helping the patient make informed food choices, right? So for doctors, for us doctors, it is so easy. We know that high carb hota hai, low carb hota hai, and sometimes we take it for granted that patients also know it. But believe me, many of the patients do not know it. And when they hear it coming from your mouth, from the doctor's mouth, it gives it even more credibility. So please do not miss this step and take it for granted that patients know it. Many of the patients will know it, but anyway, no harm in repeating it, right? So low GI foods, high GI foods, important because, you know, sometimes the bolus timing change. So if somebody has a very high GI food, you can actually give the bolus a slightly earlier, 10-15 minutes, because the surge is going to happen very soon. So you give a bolus a little bit earlier so that the surge actually comes a bit earlier. So now I want all of you to take out your phones, open an AI app like ChatGPT. Please open your phone. Everybody, I hope everybody has ChatGPT or Perplexity or WhatsApp to hai hai, Meta AI in your phone, right? So just type how much carbohydrates as per ICMR ININ database. What have the prompt I've written on the slide on the top? Just copy that. Breakfast nahi likhna. Just copy that slide. How much carbohydrates as per NIN database? Uske baad I'm putting you the food. This is the food. So the first food you put is 2 aloo ka paratha, medium size with curd, 100 ml, with 200 ml of milk, right? Just type this, right? The calculation will come. The full calculation will come. What it shows? It shows medium size aloo ka paratha, this many grams of wheat, this many grams of potato, most likely this much amount of carbohydrate. It will give you a broad range, right? And the prompt is the key. So I always write, so this is what I've taught my staff. My staff actually does it for the patients, and they write as per ICMR NIN database. If you do not specify, it will pick up from all random sources, right? So you have given a clear-cut command that, okay, you want this food, this particular thing, this particular size, this much ml of curd, this much ml of milk. You can add with sugar 1 teaspoon, 2 teaspoons, whatever you want, you can do that, right? I've also tried using with pictures, but sometimes it kind of overestimates, sometimes it kind of underestimates. So I have not had a great experience with pictures, right? So I use it the text way. So the text way, I just put it this way. So 2 plain paratha, you can see the carbs. So the figure which you're seeing in the bracket is actual carb figure which is coming out, okay? So ले देके 10-12 मील ही होते हैं जो एक फैमिली लेती है, राइट? वो 10-12 मील का अगर आपने किसी पेशेंट के साथ निकाल दिया तो भला हो गया पेशेंट का, राइट? ये 10-12 मील का आप फिगर अपने स्टाफ के साथ निकाल के भी रख सकते हो. आप इसको 2 की जगह 1 पराठा का बना दो, इनटू कैलकुलेशन आपका स्टाफ कर देगा. So all of these things can make your patient's life easier, and this is, we do it not only for pump, we do it for non-pump users as well. राइट? उनको मोटा मोटा बता देते हैं कि ये खाओगे तो इतने लगाना, ये खाओगे तो इतने लगाना. इससे कार्ब आ गया, राइट? इससे डोज नहीं आई. डोज के लिए आपको ICR का कैलकुलेशन चाहिए, एंड दैट आई विल आल्सो शो यू इन एडवांस. सो सपोज नाउ यू हैव द सिचुएशन वेयर यू हैव द टोटल कार्बोहाइड्रेट्स, राइट? Now you have the situation of the total carbohydrates. So this is a sample breakfast: 2 chapati, half cup potato sabji, 1 cup milk, and total carbohydrates 62 gram. Patient's ICR 1:12, which means that 1 unit of insulin is covering for 12 grams of carbohydrates. So the bolus dose, as we discussed with the formula, amount of carbohydrates divided by ICR, that is it. You also need to take into consideration the things like, you know, fat ज़्यादा है meal में, protein ज़्यादा है, because we know that that leads to delayed postprandial rise. That needs to, in pump, that is why you can choose the bolus type. You can choose the bolus type कि simple bolus देना है, extended bolus देना है, dual wave bolus देना है, square wave bolus देना है. Because what happens with that? Simple bolus, simple तरीके से sugar जाएगा. Dual wave या extended bolus, you have 40-50% or 60% going up front, and then you have the remaining 40-50% going over a span of 2-3 hours, right? So that's basically trying to match the normal surge of the food the patient is eating at that point of time, right? Okay, so now, just on your phones itself, on ChatGPT, open, do another this prompt. Whatever this prompt I've written, just write this as it is. So my patient is going to eat, just write the same prompt which I write. My patient is going to eat 1 katori sabzi, 3 chapati medium whole wheat, 100 ml curd, small plate of salad. The pre-meal sugar is 220, the ICR is 12, and the insulin sensitivity factor is 50 mg per DL, right? So you see what I'm giving? I'm giving food, I'm giving ICR, I'm giving ISF, and I'm giving pre-meal sugar, because the pre-meal sugar I need for correction bolus, the ISF I need for correction bolus, the ICR I need to calculate the carb, how much insulin is needed to cover the carbs, and I want the bolus calculation, right? So if any one of you have done that, 8. Actually, absolutely right answer. This is what the prompt will come like. It will go you step by step. Step 1, this is the carbohydrate count, this much amount. And it is also saying, if your sabzi is peas or potato heavy, instead of this 8 gram, make it 10 gram, right? And step 2, meal bolus. It is calculating insulin dose is equal to carbs upon ICR. Then step 3, correction bolus. It is calculating correction is equal to current PG minus target PG upon ICF, right? And step 4, it is giving you total bolus. Easy? Easy? Anybody liked it? Right? So please raise your hands if you feel it can be done in an easy manner for your patients, right? It actually simplifies your life. Honestly, if you ask me ki एक आलू के पराठे में कितना होता है? मुझे पुरानी मेमोरी से याद है, हाँ यार 25, 28, 30, 35 ग्राम होता था. But now since last so many months I'm not doing it. I'm just using AI and inputting it in AI and using it how we can, advise our patients. And honestly, this is the same thing we are using in patients who are not on pump. Which means that a wider spectrum of patients you can actually help with simple calculations. Those who are very, very learned, you can actually teach them ISF, ICR, etc. Otherwise, just this last step you can keep on doing on your own. At least the carb counting and the calculation you can tell to the patients, right? So this point we have already discussed. Just explain to the patient simple कि ज़्यादा मीठा वाला खाने वाले हो तो 10-15 मिनट पहले लगा लेना बोलस. अगर ज़्यादा मीठा नहीं खाने वाले तो एक standard time पे डालें, right? So not all meals are same. We know that we've discussed that fats, proteins, they basically delay gastric emptying, so late postprandial. That is why you need a bolus where you have some portion of that going up front, and you have some portion of that extended over a period of time, basically trying to cover for the post-meal surge, right? So this already we have seen. So this is how the pump's prompt will look like. You can set up all of these factors. This has already been covered by previous factors. So sensitivity, carb ratio. So whatever calculation we did, these are actually inbuilt in a 780G, right? You basically, you just enter the carbs, everything is actually inbuilt. You can obviously modify it. You can modify the sensitivity factor, you can modify the ICR, you can modify all of these things, but the algorithm actually does it on your own. But at the back end, as doctors, we need to know that this is how it is done, and this is what we can do to help our patients in a better manner, right? So CGM is important because, once you know the glucose trends, you can actually improvise in a much better manner. So you can see that Dr. Santosh and other speakers also talked about the autocorrection. This is a patient of 780G actually on getting an autocorrection bolus. You see that as the graph is rising up, the autocorrection boluses are getting active. And after some time, you see that once the curve is actually going down, it is actually becoming flat. This was actually an autocorrection bolus which happened. So that is one of the advantages of automation and algorithm, that over a period of time, you can do that. Food labels, most of our patients actually do not go with food labels, right? But if somebody is having that food with food label, then it is important for them to explain ki serving size kitna hai, how much serving size, how much carbohydrate there in per serving size. If there is a dietary fiber, you subtract that from the total carbohydrate, right? If there is a dietary fiber, you subtract that from total carbohydrate. If there is a sugars written, you do not add it because the sugars, carbohydrate is already added into it, right? If somebody wants to go with that label part, you can go with that label part as well, right? So we know that our meals are complex. Hidden carbohydrates are important. Sauces, chutneys, amki chutneys, all these chutneys, they do have sugar, they do have carbohydrate. So important for us to remember that. And when eating out, always tell patient to estimate slightly generously. What I have seen is that patients tend to underestimate कि मैं इतना खाने वाली हूँ या इतना खाने वाला हूँ, right? And always, since there is always a multi-component meal when the person is eating out, so probably an extended bolus or a dual bolus works better in eating out settings as per my experience in most of the patients. So exercise, obviously we need to be slightly careful, and pumps actually do make the correction boluses easy because you just have to press a button for that. Food portion and food size, very, very important, right? Because, food portion, if the portion size is high, obviously carb content will be high. So food order again, we know that certain foods do not have so much of an increase in terms of blood sugar levels. So start with non-starchy vegetables like then protein, then carbohydrate. Will better manage your blood glucose levels. So points to remember, any snack with at least 1 unit of insulin required should actually be covered, right? Pre to post meal up to 40 to 60 mg per dl rise is okay. Beyond that, you need to look at it. One important point to remember is that unnatural weight gain, if it is there, lastly, unnatural weight gain if it is there, this means that patient probably is overeating and the pump is being overused to put in more insulin. If it is an automated pump, then the whole setting will actually go according to that, and when that patient starts having an under-eating kind of a situation, difficulties will happen. Most of females, especially adolescents, I find a lot of challenges in the premenstrual phase. Most of the females have seen that once the menses come, the challenges actually subside, and sometimes there are food cravings also which are more at that point of time. So you just need to be slightly careful with these few days that how it is to be important. ICR is more usually in the evening because the physical activity is more, so dose usually required is less. Physical activity is less in the morning, so the dose required is more. Hormonal surges again have a same concept in terms of ICR. So identifying most common foods and then just working with the patient. Whatever we talk, nothing is, as I discussed, the law of gravity. It's just, you know, you learn, you adapt, you do something, you just figure out what didn't work right, what did work wrong, right? So I'll just like to end with acknowledgements to two of my friends with whom we have been discussing about type 1 diabetes here, Dr. Rajiv Singla from Delhi, Dr. Amaya Joshi from Mumbai. And this is my numbers, the contact number as well as the WhatsApp number. If anybody wants the presentation, I'll be happy to share the presentation with them. Thank you. Thank you so much for your kind attention.
Thank you, sir. Thank you for the key insights and tips and tricks regarding the meal management. For the next session, actually, Dr. Mayur Agarwal was supposed to present it, but due to his absence, I will be presenting on his behalf. So we will be dealing with exercise and sick days and how to use the insulin pump. So our life does not stop if a patient is having a type 1 diabetes. He has his good days, his bad days. He also has his sick days also. And he wants to be, he or she wants to be involved in physical activities, in contact sports. So we should be able to give the patient the opportunity of how to handle this situation. So according to the type 1 diabetes guidelines, ADA guidelines, regardless of the type of diabetes, regular physical activity is very important for overall health and wellness. In order to also important to balance your insulin doses with your food and also with the activity. So we'll just go through the few terminologies. What is physical activity? Physical activity is the bodily movement which involves the muscle contraction to produce energy expenditure above the basal level. What is exercise? Exercise is something very different. It involves a structured, planned, repetitive with the objective of improving or maintaining one's physical fitness. So here comes physical fitness. So physical fitness is actually the circulatory, respiratory system ability to supply oxygen during sustained exercise, and it is measured as VO2 max. So we have different classification of exercises. We have the aerobic and the anaerobic activities. The aerobic activities are again the walking, cycling, and jogging. They are involving the large muscle groups with a repetitive continuous movement of more than 10 minutes. On the anaerobic part, there's a short burst of activity with the energy dependent on glycolysis. Resistance training forms the anaerobic exercise, which working on the muscles against resistance load and improves the muscle endurance and the strength. It increases the lean mass and the metabolic rate. For the flexibility and the balance exercises, we have the yoga, which is mainly used by the older adults with the diabetes, and stretching improves the range of movements, motions, and the balance exercises also helps to reduce the incidence of falls. So the exercise classification can be done according to the parameters of the training heart rate. We can be done with the metabolic equivalent and the rating of the percent exertion based on the Borg scale. So we have the classification of light, moderate, and vigorous along with the near maximal intensity, depending on these parameters. What are the advantages of exercise in type 1 diabetes? They may help in the early stage, especially in the young patients, a preservation of the beta cell mass and better hypoglycemia management in the younger patients. Also, it improves in the overall cardiovascular fitness. There is some dubious topic that whether it provides glycemic benefit or not, because there are some conflicting reports regarding that. Prevention of development of complications and also the improvement of the general well-being. Preservation of beta cell mass, there is some studies which have shown that significant beta cell function may remain for years, and there is some possible mechanism for that. Among the improvement in the cardiovascular fitness, young adults with type 1 diabetes are less fit and they match with the individuals with diabetes. Alteration of the cardiac metabolism, use of non-esterified fatty acids. Also, supervised physical activity increases fitness in type 1 diabetes, and it can affect the ultimate mortality and the cardiovascular disease also. Among the glycemic control, there were 3 meta-analyses in which one of the meta-analyses showed no glycemic benefit. The other two has shown that exercise had statistically significant decrease in HbA1c, but this conflicting reports could be the consumption of energy during the exercise with a decrease in the insulin dosage probably could have nullified the glycemic lowering effects. Also, the diabetes-related complication, there is a definite good effect on the lipid profile. There is a reduction in the blood pressure, improved vascular function, reversal of endothelial dysfunction, the microvascular complications. Also, what are the challenges of exercise in type 1 diabetes patients? So, in the patients with type 1 diabetes, there could be probably a hyperglycemia, also a hypoglycemia. First of all, the moderate intensity exercises, there is increased glucose utilization and the rapid fall of glucose, and this rapid fall of glucose results in hyperglycemia. The first defense for hyperglycemia is the decrease in the insulin, which is obviously absent in the type 1 diabetes patients. Hyperglycemia may occur during the exercise or delayed by several hours. In the hyperglycemia part, we have the high intensity exercise, which can also result in the triggering the counter-regulatory hormones, the adrenaline, cortisol, and the growth hormone, and this might result in a risk of hyperglycemia, and there might be actually a rise in the blood glucose regarding, not the fall. So one important point to note is that there is a certain insulin pharmacokinetic factors which are very important. The subcutaneous insulin delivery is still artificial. It is not delivering directly to the portal vein. So it can be unpredictable compared to the natural insulin secretion. There is a delay in the offset of the insulin action. Regardless, we are having this ultra rapid insulins, but the data is not showing much offset in this matter. There's also during exercise the increased blood flow, the increased activity, and this accelerates the absorption of injection from the injection site, paradoxically increasing the insulin activity during the exercise. Also, matching the insulin to the carbohydrate needs. So patient may not plan for the exercise from beforehand. So that is a factor. We should always advise the patient to plan the exercise in advance. There is a difficulty in the balancing the meals, and eating within a bolus dose, also taking a bolus dose of insulin 1 to 3 hours before exercise would not be recommended. Unplanned exercises also requires reactive carb intake, and extended exercise more than 40 minutes requires 30 to 90 gram carbs per hour. There are some technology limitations. We are using the CGM data. So the CGM is the interstitial blood glucose which lags behind the blood glucose, and this rapid change of blood glucose in the exercise period might not be reflected appropriately by the CGM data. Also, accuracy issues in the CGM would occur due to the motion, sweating, and the hydration changes. In some cases, the automated insulin delivery system helps, but they cannot reverse the insulin already delivered. We can do a temporary target reduction risk, but this must be set at least 1 to 2 hours before for the best effort. Disconnection might be required for the AID devices, especially in playing in the contact sports department. Also, water might also disrupt the connection between the sensor and the device. So there are some delayed post-exercise effects. There's increased insulin sensitivity, and this persists for up to 24 hours after exercise, particularly after prolonged or intense activity. This may lead to the risk of late hyperglycemia, especially overnight. Evening exercises poses higher risk compared to the morning exercise, and meal bolus after exercise may need to be reduced up to 25% to prevent lows. Also, the recognition of hyperglycemia, the symptoms of hyperglycemia like sweating, tremors, tachycardia often overlap with that of the normal exercise sensations. And this impaired hyperglycemia awareness could be a risk factor. Also, there are some psychological and behavioral barriers, and the fear of hyperglycemia discourages many from exercising regularly. There's some anxiety about the unpredictable glucose response, lower participation compared to peers. There's a practical burden regarding the planning of the carbs, adjusting insulin, carrying supplies, and monitoring of the CGM alerts. So what are the strategies we can have in place to exercise with the insulin pump? So first of all, we'd like to reduce the insulin on board. So we'd like to avoid the large meal boluses 1 to 3 hours before the activity. And if we are if you're eating before the activity, we should at least gap it for 1 to 3 hours, and also decrease the pre-exercise bolus. though I should mention that this decrease in the pre-exercise bolus, it all depends on the person who is exercising, his weight, his or her weight, what exercise type they were trying to do. So there are multiple factors based on which we can decide the exact dose. There is some temporary basal reduction. Set the temporary basal, this is for the manual pump users. They can reduce the temporary basal reduction 60 to 90 minutes before the exercise. In the automated insulin delivery device, there is a temporary target setting. So we can actually, this will disable the automatic correction during the exercise period. So what we can do is we can set the temporary target up to 150 at least 1 to 2 hours before the exercise to reduce the hyperglycemia risk. So how do you manage the carbohydrates? If there is a glucose level less than 126, before the exercise, we'd like to consume 15 grams of carbohydrate without the pump bolus. So we'd not like to inform that they are taking the carbohydrate. So we'll not have to inform the pump, and without informing, we'll take the bolus. During the exercise also, if it is prolonged, more than 40 minutes, 30 to 90 gram carbs per hour, tailored to intensity, fitness, and sex and the insulin levels. After exercise, definitely the next meal we are taking, the bolus may need to be reduced by 25% to account for increased sensitivity and the glycogen depletion. From the monitoring standpoint, we should be careful about the alarms for low threshold during activity, watch for any rapid trends. Also, we can corroborate our data if we are suspecting that the CGM is lagging, so we should do a CBG with the glucometer. For the overnight protection, extra monitoring after the late day exercise. If it is a late day exercise, evening exercise, definitely we should watch out for the nocturnal hypoglycemia. From the pump management during specific activities in the contact and water sports, the pump may need to be disconnected. If that is the case, suspend the insulin delivery when disconnecting to ensure the algorithm accuracy. If we are disconnecting the pump for more than 2 hours, give supplemental insulin, example 50% of the missed basal or the correction dose. Also, we should consider regarding the infusion site consideration, inside from sites away from the areas of high movement stretching to avoid the dislodgement. In the post-exercise adjustment, again, we have to reduce the bolus insulin for the first meal post-exercise up to 25%. For the overnight hypoglycemia prevention, lower the evening bolus if exercise was late, and some pump users may set the temporary basal reduction overnight. We need to use the pump reports and individualize the treatment. Also, the patient needs to be taught that there are some planning needs to go to for the patient before they are trying to go for the exercise. So definitely it should be personalized, and also there might be some overlap with the sick day and exercise. So in that period of time, the hydration, ketone monitoring also takes precedent. Also, psychological support to the patient to prevent the fear of hypoglycemia and improving the adherence to exercise. So what are the strategies we have in place? For the AID, we are discussing 780G. For that, we have, let's say for a common 45-minute exercise, aerobic exercise, using the Smart Cut feature, we'll start the temporary target, let's say we'll take temporary target of 150. We'll start that 1 to 2 hours prior to exercise. And if required, we'll give a 10 gram of carbohydrate if the CBG if the blood sugar before starting is less than 126. We'll go through the exercise. This is for a moderate intensity, not for the high intensity training. So again, we'll stop the temporary target after the exercise. And some key categories, we should note that we should not exercise if there's a ongoing hypoglycemia less than 70 or a very high hyperglycemia more than 270. Also, carbohydrates may need to be continued over time if there is more than 40 minutes exercise. For anaerobic activity may not require insulin adjustment. Autocorrection may actually help mitigate highs that may occur as a result. So the exercise strategies, what are the do's and don'ts? So we will like to discuss the exercise strategy with the patient. Start with the target 1 to 2 hours before the exercise. We would start exercise actually in a target range if needed. If needed, consider replacement carbs before, no more than 10 minutes before. And during exercise, not enter this in the Smart Gut bolus. If disconnecting the pump for exercise, suspend insulin delivery to ensure correct total daily dose. Turn off the temporary target at the end of the exercise, ideally 15 minutes after the exercise. Post-exercise meal, consider bolus modification, slight decrease. Trust the system and let the algorithm do the work. On the don'ts, we have the exercise with high insulin on the board. We should not do that. Begin exercise with rapidly rising trends, overtreat hyperglycemia, enter replacement carbs. Also, we should keep a track of the smart gut bolus screen and the carb load pre-exercise. So we have a case over here. We have a 38-year-old lady who has a long-standing history of type 1 diabetes on insulin pump therapy. She has impaired awareness of hypoglycemia, otherwise having an active lifestyle. She is keen on exercise for stress management. So if you can go to the event timeline, at 8 a.m. in the morning, she had a full breakfast. She had taken a full meal bolus insulin, and at the 8:30, 30 minutes after that, she had begun this moderate intensity exercise of cycling. And she had set the pump's temporary target 150 milligram per day just right before starting instead of earlier. The insulin on board remained high because of the recent meal bolus. So what is the end result? So in the end, actually, she had, during the exercise, she had the hypoglycemia. It went up to 67, and she was immediately actually given, treated with 15 grams of glucose tablets. Her glucose level remained low for 50 minutes, even later up 56. An additional 15-gram glucose was consumed, followed by a rise in the sensor glucose 30 minutes post-termination. The temporary elevated glucose target was left active until 1 hour following exercise commencement. So auto-corrections were administered by the device to address the rebound rise in the glucose level, and lunch was taken at 12 p.m. when the plasma glucose was 185, and she took insulin bolus for 64-gram carbohydrates. So there is an overall haywire going on after that simple exercise. So this was a poorly planned exercise. The complications during exercise was a rapid drop in the glucose during the first 30 minutes, developed hypoglycemia due to mismatch between insulin activity and the increased glucose uptake. CGM alerts were delayed, requiring unplanned carbohydrate intake to recover. In the post-exercise issue, she had hyperglycemia, her glycemic status became unstable, rebound highs after treating hypos, followed by another drop. Evening meals were complicated by increased insulin sensitivity, overnight risk of hyperglycemia, heightened glycogen depletion, plus impaired awareness. The clinical lesson is that the late temporary target activation was ineffective, must be set at least 1 to 2 hours before the exercise. Exercising too soon after a large meal bolus left excess insulin on board, a major driver for hypoglycemia. Patient with hypoglycemia unawareness need stricter planning, CGM alerts, and possibly lower glucose threshold, and demonstrates proactive planning. We have a case too in which this patient is having a 40-year-old female. She has a long-standing type 1 diabetes on insulin pump therapy, also has impaired hyperglycemia, but her schedule is a bit different. She has followed all the protocols. She has skipped breakfast before the exercise, avoided larging meals. She had set the temporary target 150 milligram per DL before 1 hour before the exercise, and allowed the algorithm to reduce the basal insulin gradually. No excess insulin on board, and the exercise session was moderate activity, cycling, walking for 60 minutes, maintained stable glucose profile without needing excess carb intake. And this was the end result, and her chart was much, much better. So for the lack of time, I'd like to go fast for the approach to sick days. So what is a sick day? So a sick day is any day where illness or infection or health stress disrupts the glucose control, and even any mild sickness like cold, flu, stomach upset can destabilize the glucose management. There are some unpredictable hormonal responses, increase in cortisol, adrenaline, and growth hormone, and there's an increase in insulin resistance. Glucose rises despite the usual insulin doses, and if the food index is reduced, there's a risk of starvation ketones formation. And also we should look specifically for pump failure during illness, and any amount of or lack of insulin during any illness will cause rapid decay. So when to activate a sick day plan? any feeling of unwellness and the patient is having persistently more than high blood sugar, more than 250 for more than 2 to 4 hours. Also blood ketones high, even in the urine ketones, if there is small level, there is a persistent vomiting, diarrhea, any unexplained pump, alarms, infusion set issues, or rising glucose. So the preparation for this matters because illness actually increases the insulin needs, and without adjustment, the risk of decay can occur in hours. So frank decay and the patient will end up in the hospital. Also the vomiting and diarrhea increases the dehydration risk, and the preparation ensures rapid action before the complications worsen. So what one must have in the sick day kit, they should have a diabetes supplies of spare infusion sets, pump cartridges, insulin pens, syringes, a printed copy of the pump settings, monitoring tools. So backup monitoring tools, the glucose meters, the strips, the blood ketone meter, also a logbook. There's a quick carbs, we should have access to that, the easy carbohydrate, the rehydration fluids, sweetened drinks, and also some basic medications like pain relief, anti-nausea. And they should have always been in contact with the diabetes educators, the endocrinologists, or they even go to the local hospital if there are some complications. So they should be monitoring the blood glucose every 2 to 4 hours, ketones every 2 to 4 hours, and confirm CGM values with finger sticks. They should never stop the basal insulin. So the basal insulin must not be stopped, and continued carb boluses should be taken. Correction boluses every 2 hours if the glucose is elevated. If ketones are present, extra insulin dose 5 to 20% of the total daily dose via pen if pump is unreliable. If the pump is unreliable, we can give it via the other method. Always replace the infusion set plus cartridge with unexpected highs. And we should have a lookout for the fluid intake, 125 to 250 ml per hour. If no solid food, aim for 15 gram of carbs per hour from fluids. So we'll just go for the special scenario, hyperglycemia plus sick day. We should also treat with 8 to 10 gram of carbohydrate, repeat it every 15 minutes until it is more than 100. And we should go for, if there is a hyperglycemia plus ketones, change the infusion set, increase basal level by 30 to 50% temporarily. Hyperglycemia plus ketones, turn off the smart guard, switch to manual, correction doses by pen can be given. So I'll just go when to go for the medical help. I think everybody knows that. For the Minimed 780G specifically, we should note that they are having all these considerations and the observations, and the technology should be able to handle just some mild illness. Okay. We also have a case over here that in which the patient had undergone COVID-19 and the patient was well controlled with that. So to conclude, safe exercise and illness management in type 1 diabetes requires proactive planning and continuous monitoring. For exercise, minimize the insulin on board, use the temporary targets, basal adjustment, and combine with tailored carbohydrate strategies. For sick days, maintain basal insulin at all times, monitor glucose ketones frequently, and act promptly with insulin correction, hydration, and infusion set checks. Early recognition of red flags and timely escalation of medical care prevents the serious complications, and with structured protocols, pump users can safely remain active and resilient through illness. Thank you. Next, I'd like to call upon Dr. Beatrice Ann, ma'am, for the type 2 diabetes and pregnancy indications for insulin pump.
A very good evening to all. It's a pleasure to be back in Kolkata because I'm a proud alumnus of IPGMR. So let me talk about the other indications or the other situations where we can use an insulin pump. So I'm going to be talking about specifically type 2 diabetes, pregnancy. What do the guidelines say? So you've heard from all the speakers so far that AID system should be the preferred insulin delivery method in type 1 diabetes. That is grade A recommendation by almost all the guidelines. When do you start it? So you want to start it early, including at diagnosis. That becomes grade C recommendation because it depends on the patient's or the person's or the caregiver's needs and preferences. And one of the countries which has been the forerunner of type 1 diabetes management is UK. And UK, the NHS has in fact decided that they will be rolling out about 3 lakh pumps for patients with type 1 diabetes, and they have got us as far as 80,000. And even the ISPAD clinical guidelines do state the same, that AID systems, especially the closed loop ones, should be strongly recommended for youth with diabetes, type 1 diabetes. So is AID only for type 1 diabetes? AID can also be used for other people, for type 2 diabetes, pregnancy, and I'll also be talking about type 3C diabetes. So type 2 diabetes, as you all know, in people living with type 2 diabetes, this is European data, but I'm sure this is going to be even higher in India. So about 8.5% of the population are living with type 2 diabetes, and 18.9% of these patients who are living with type 2 diabetes, insulin is required. And of these, about 30% are on multiple daily dose insulin. So the question is AID safe and effective for use in adults with type 2 diabetes who are being treated with insulin? And unlike type 1 diabetes, we have type 2 diabetes which is also being treated by other medications. We have the GLP-1 RAs, we have the SGLT2 inhibitors. So is it safe in that setting? So we have a couple of studies, large trials, in fact, to answer these questions. So one is a non-randomized clinical trial where they picked up type 2 diabetes patients, uncontrolled sugars, with at least a basal insulin, some form of insulin, and patients are also on background medications, and they have been started on the AID, and they have been observed for a change in HbA1c. This is a 13-week study, and a change in the HbA1c was seen. What was interesting in the study was the baseline HbA1c, in fact, decided how good the pump is going to work in these patients. So there was almost a 2% decrease in the HbA1c in those patients who had a baseline of more than 9%. And even with the race and ethnicity, there was a change because some of the racial groups, they used a lower target. So in this particular pump, the lower target that can be set is 110, 120, 130, 140, and 150. So those patients who had used a target of 110 had a better HbA1c reduction. The adverse events were not many. There were no severe hypoglycemia or diabetic ketoacidosis or HHS. So from this study, we do get the message that in adults with type 2 diabetes, glycemia can be improved in spite of the background medications of GLP-1 RA and SGLT2 inhibitors. So this, another study which was published in the NEJM just in this March, again on type 2 diabetes. Here they have used, this is a randomized controlled trial, so they have used two groups, and both these groups initially were on multiple doses of insulin. So they were at least on one rapid-acting insulin and either a premixed or a basal bolus regimen. And in these patients, they started on AID. One group was started on AID, and they looked at the CGM values of these patients. The HbA1c, again, this was a 13-week study, which showed that the HbA1c reduction was much better in those patients who were on AID. And the TIR, the time in target, was again much better in those patients who are on AID. So in this study, there was about 3 hours better time and range in those patients who were on AID. And the other interesting part of this study in type 2 diabetes was, unlike in type 1 diabetes, where we have to show them the carbohydrate counting and teach them carbohydrate counting, in this particular study, they have just given a fixed meal bolus. So it was not very strict carbohydrate counting. So despite that, there was a better time and range. So this is the IMPACT-2 study, which is done by Medtronic for their own pump, the MiniMed 780G, in which again patients with type 2 diabetes, uncontrolled diabetes, they were again assessed with the 780G MiniMed pump, and they were followed up for 3 months, and the HbA1c reduction was studied. So this was about 95 participants, and they found at the end of the study, there was an improvement in the time and range from about 72% to 79.8%. And the other interesting part of the study was this. If you see here, the blocks here, so this is the basal insulin, this is at baseline. So basal insulin, and this is the boluses. So here we see another pink graph here. So here the basal insulin, and this is in fact the automated bolus. So the light blue bar is the user-initiated bolus. We see here that the user-initiated bolus at the end of the study is lesser than what it was at the beginning. So this in fact reduced the diabetes burden. It reduced the diabetes distress and also the fear of hypoglycemia in these patients. And in these patients, some of them are also on GLP-1 RA. And again, this was studied whether there was any difference after adding an AID to somebody who was already on a GLP-1 RA. again, there was a difference of about 76% to 80% increase in the time and range. So this is about the data for type 2 diabetes, which is still evolving. And now we look at pregnancy. Pregnancy again is a very special situation. Where do we stand when it comes to AID in pregnant women with type 1 diabetes? So there are two devices which are approved. One is the CAM APS and the other one is the Minimed 780G system, which are approved for type 1 diabetes in pregnancy as well. But what is the catch here? The problem with or the issue with pregnancy is our time and range. The pregnancy specific time and range is different. It is different from type 2 diabetes, it is different from type 1 diabetes. So if you look at in pregnancy, we use a range of 63 to 140 milligram per deciliter. Whereas if you look at the pump settings, the smart card can go up to a lower value of 100. So we cannot bring it down further. So that way we will not be able to achieve the time and range for pregnancy in the usual pumps that we are using. In the CAM APS system, there is an option of bringing down the lower value even lesser. But it is not so with the other pumps. So what do we do about it? So there are certain techniques to make sure that the sugars are still in the lower range. So one thing is you can sort of give fake boluses. So this is one condition where generally we tell the patients not to fiddle with the pumps and not to confuse the system and don't give fake meal announcements. But in this case, when you want the sugars to be lower, then you give a fake meal announcement so that the pump keeps giving the boluses. So this is one way of doing it. And as the pregnancy advances, we see that the rate of absorption of insulin also comes down. So we'll have to tell the patient to take the insulin bolus about 30 to 45 minutes earlier, not 5 to 10 minutes as usual, like how they take it usually. We'll have to ask them to take it much earlier. The active insulin time can be reduced. The insulin carbohydrate ratio should be reduced. So all these have to be done when the pregnancy progresses. And it is going to be different with each trimester, the first, the second and third. So it involves a lot of monitoring and fine tuning. But the advantages are also there because it is a less burdensome to manage when you have a pump, especially when it comes to hypoglycemia. So the fear of hypoglycemia is lesser. The diabetes distress is lesser. Of course, we do not have much data on what happens to the pregnancy outcomes if you give an AID. So that kind of data we do not have, but hoping that there is a potential for improved pregnancy outcomes, we need to look at this option as well. So this is again another AI-DACT trial. So this is again published in NEJM, automated insulin delivery in women with pregnancy complicated by type 1 diabetes. Again, they have enrolled patients before 14 weeks of gestation who are already type 1 diabetes. They have enrolled them into this AID system. And they found that there was better glycemic control. There was better time and range in the closed loop group. There was about 68% better time in range. The adverse events were almost similar. We do have case reports as well of Minimed 780G being used in pregnancy. But again, something else here which is very interesting from this study. If you look at this, so this is the first 1 or 2 weeks. This is about the time and ranges here from the CGM data. So the first 2 weeks, then comes the first trimester, second trimester, and third trimester. If you see here, the N stands for nocturnal. So that is the bedtime. D stands for the daytime. So we see the difference in the time and ranges here. So the nocturnal is usually okay. So it's about 70 to 80%. It is still okay. But if you look at the daytime, so that is where the problem lies. So you see here, it is only about 47%, 59%, 61%. So throughout all the trimesters. So what does this tell us? That we need to be a little more careful in monitoring the day and night separately, the day and night time and range. And reducing the insulin carbohydrate ratio in pregnancy may be beneficial. And we may need to be a little more aggressive. We may need to give fake announcements of meals, and we may need to give extra boluses and small frequent meals. So this is very important when we manage diabetes, type 1 diabetes in pregnancy with AID. And last, another set of patients who behave very close to type 1 diabetes, that is a type 3C diabetes, who are very sensitive to insulin, and they do have wide glycemic fluctuations. So this is just a case report, but still an eye-opener for us for the potential for use of AID in pancreatic diabetes as well. So we see here this particular patient, total pancreatectomy done for a pancreatic neoplasm with wide fluctuations in the blood sugars, and the fear was more for hypoglycemia. So this patient would not take insulin or would overdose insulin based on the blood sugars, and we see the wide fluctuations, and this is a good candidate for starting AID because we see the improvement of the time and range here to up to 70% after starting the AID. So from this case report, we do understand that total pancreatectomy, type 3C pancreatitis, where they do behave like type 1 diabetes with wide fluctuations in blood sugar, they are also good candidates for AID. Of course, we do not have very large studies on these, but potentially, yes, they could be used in these as well. But here, the concern is more about preventing hypoglycemia rather than treating the hyperglycemia. This is especially for pancreatic diabetes because it improves the quality of life for them. So from all this data, my take-home messages for today is AIDs are safe and they are adaptable for use in diverse populations, not only in type 1 diabetes, and there is growing use in type 2 diabetes, pregnancy, and type 3C diabetes as well. And we do have real world and trial data which indicate that these technologies can help us manage unstable glycemic patterns when there are variable insulin needs. And it can reduce, the most important advantage of AID is they are going to reduce the hypoglycemic risk, especially the nocturnal. And research is of course needed for early adoption in high need diabetes groups. And especially when it comes to pregnancy, we need to study the maternal, the fetal outcomes when we use AID. So we need to have RCTs on those planned. And of course, we are in the early stages when it comes to AID use in pregnancy and in pancreatic diabetes. And long-term data are still awaited. So thank you, one and all.
Thank you, ma'am, for actually saving us some time. I'd like to call upon Dr. Mahesh, DM, for the hands-on insulin pump therapy. Also, I'd like to request everybody to come to the first 2 rows, and we're having actually 8 pumps, and Vinay and the Medtronic team will actually coordinate, and they'll supply the pumps to each and every in the first 2 rows, okay?
Can we have 3 people on stage who have seen the pump? Any 3 volunteers who have already seen the pump? $780G, how many have seen, used $780G?
Any three final year PGs here? Final year PGs or just finished DM? Three people who want to stand. Okay, any three people who are interested in standing, can you please come? One from this side, one from the center, and one from the last. So nobody wants to start the pump, huh? Please. Yeah. You have, you can start. Hello, you can start. Hello, am I audible? Yeah. So somebody who is holding the pump on this side, they can see here. You can turn that side. Yeah. Can you see the pump? There is nothing visible, but you can see the pump. Okay. So the picture will be here, so you can try to see. So some of you don't have the sheet, but you have something which is having very small font. So this is just a bigger font so that they can read. So we have learned everything about insulin pump. How many of you are exhausted, have learned too much today? What do I do? So it is too much of learning, AID, automation. The automation is so much that our brain has become automatic now. You can't listen now. Everybody is feeling thirsty, want to drink a cup of tea or probably a cup of coffee. Some want to run away, saha kappa insulin pump shuru madate. Kya pump shuru karna hai, dimag kharab ho gaya. So what we will learn in the next 3 or 4 minutes is what you must know. If you don't know this, forget about pump, you cannot start anything. So we all know we are calling automation, and now the word used is it's a hybrid closed loop pump. Okay, now show the pump, whatever they have, okay. Is what they are having hybrid closed loop? Yes, no? Is what they are having hybrid closed loop pump? Yes, no? You can say yes, no. The answer is either yes or no. Yes, no. It is only a pump. It needs to be having a loop, and that loop is closed with the help of a CGM. That too, the CGM has to be guardian for CGM. Most of the time what happens is, when we are telling no, we don't use the word CGM. Patient will be thinking, I had one type 1 diabetes patient who was a doctor's daughter. Patient was using CGM for a very long time. So I told them CGM, you have to use it with CGM. I did not tell Medtronic CGM. So they said, sir, I connected the pump. She was already on a previous pump. She told, okay, I took the new pump. Array, sir, there is no difference between the old pump and the new pump. The only difference is that it looks different. Otherwise, there is no difference at all. It is not able to sense from the existing CGM. So this pump is closed hybrid loop only with the CGM. That too, Medtronic Guardian CGM. Otherwise, it's as good as a normal insulin pump, which will only have little bit of modernity to it. It's like wearing a new dress, but there is no difference between the purpose of that dress. It's not an automated dress. So what we need to do is you must have that sheet in that. So I will go through the steps initially next 2 minutes. The first step is you have to know, must know. This is must know. If you don't know this, you cannot work with the pump. So the first step is you should know the total daily dose of the patient who is taking insulin. So the first question I will ask is, can you start insulin on day 2 of admission, newly diagnosed type 1 diabetes? Answer is no. You need at least ideally 15 days, after which you can consider starting the patient on the pump. So you have to know the total daily dose. So whoever has a sheet, you write whatever, approximately write a number, maybe 40, 45, 50. Write a number if you have that sheet with you. Okay, write any number that you want, your choice. Total daily dose that the patient is taking for the last 2 weeks. Average dose, maybe 40, maybe 30, maybe 50, whatever it is, write that. After you write that, next you have to reduce. We all learned that we have to reduce the dose because the basal rate or the basal delivery of insulin is very good on an insulin pump. So you have to reduce on an average by 15 to 25%. So reduce by 20%. We'll keep simple numbers. So if you write odd numbers, then you will find it difficult to calculate. So usually use even numbers so that you calculate fast. Okay. So 20% reduction from the dose that you have decided for your patient, you reduce the 25%. Now, we have taken 2 steps. First step is you have the average dose for the patient for the last 15 days. Now you have reduced it by 20%. From that 20%, whatever reduction, total now is the 80% of the dose that the patient was taking. You have to calculate how much basal we should give. By thumb rule, it is half. That is 50% of the value that you have calculated. So there is a different for body weight, for kids, for adults, elderly, you can always have some variation. We'll keep everything simple because we must do. First step is very important. So now it may be half the dose, maybe 20 for some, maybe 15 for some, maybe 35 for some, whatever it is. You now have the half the dose, that is the basal rate. When you start the pump, you have to fix the basal rate. Okay. So we have taken the basal rate here setting. Okay. So now very easy to do is set a single basal rate. How will you do that? Whatever you have got, divide by 24. You have to do that. Whoever is writing have to do little bit calculation. AI will not teach you this. Okay, AI role will come after you do this. Once you do this, then AI will take care of rest of the things. So ideally, you will need 2 rates minimum. Okay, because in the night you will have no meal and the cortisol levels are very low. And the cortisol level increase by 4 o'clock onwards, but usually 6 to 8 o'clock it is at a higher level. So usually when I start the pump, I keep the basal rate higher from 6 a.m. onwards till, depending on the patient, either 8 p.m. or 10 p.m. So between 6 a.m. to 8 p.m. or 10 p.m. fix one basal rate, and after that reduce it by 30%. Okay. So now you got 20 units per day you have to give. For example, you have to give 20 units per day. So from 6 a.m. to 8 p.m. it has to be at certain rate, and the night should be 30% less than that. So you calculate the lesser rate first and then you add. You decide how much you want to give. So you have fixed the rate. Okay, now you started the pump for the patient. This is a normal simple pump where you are starting 20 units, more during the daytime and less during the night time, in order to prevent hypoglycemia, which we all know is very common during the night so nocturnal hypoglycemia. By doing this, patient comes the next day, you have put CGM also. Is it a hybrid closed loop pump? Day 2. Yes, no, everything is there. CGM is there. Yes, no? No. Answer is no. Because the pump has to learn. It cannot learn in one day. It doesn't know what has happened in the last 15 days. We all listened to all our previous speakers, my dear friends. They all said it takes around 2 to 3 weeks for complete learning. But does it start learning on day 1? Kids start speaking some words, some sentences. So it learns on day 3. Onwards, it learns something. On D3 onwards, the first thing it learns is how to calculate the basal rate on its own. As long as the CGM is working, day 3 after 72 hours, the pump will start calculating the basal rate on its own. So you don't have to do anything for the next few days because the pump is learning and it will try to do the automation on its own and the basal rate will be fixed. At the end of 2 weeks, you will get a good basal rate with a good sort of, you'll have a decent fasting glucose level if the pump is automated. So we'll go through the next 2 and 1 minute of slides to just go there. So the total CGM works only when this system works very well, when the system is well connected like this. There is a Guardian 4 transmitter with the sensor pump connected to the phone. It is connected to the computer where the CareLink server, all the data can be uploaded and up to 5 people can see. Patients, relatives, their father, mother and the doctor can see when this loop is completed. There is one loop that is of the pump working, but the second loop is learning. The learning happens only when we get all the data into the system. If the data stays only in the pump, then we will never be able to learn how to enhance the value. Like you saw, very good data where the patient came with 2 or 3 years of data. First year, the time in range improved from 20 to 50%, then it increased to 65%, then it came down to 50%, then it reached 80-90%. That happens only because when you get it connected to the server, you can see all the data and understand how to take the next steps. So this is how we all know about this. It's connected. Also, this glucometer is given with the pump. So whenever you check this pump, it gets into the system and the value is recorded. But that is not automation. It is just sort of data that is recorded. So what is the minimum dose we can give? As of today, in a pump, you can give minimum is 6 units per day. It is written 8, but the minimum is 6 units per day. Maximum is around 250 units per day you can give with the pump. So now whoever has the pump can see these buttons because we will go through a set of what they mean, okay? So there are 4 important buttons, one on the right, up, down and left side. Then there is a back button, then there is a graph and the sleep mode. The pump is usually in the sleep mode. If you press it, it will on, okay? Once it is on, if you press it again for 2 minutes, it will go back to the sleep mode. Either it will show the graph mode or it will show the sleep mode. Now what are the buttons up, down, left, right? What do they help us for? So the next step is these buttons. So the first step, when you have this, when the screen is on, you can see this time here. This is the insulin that is there and the battery is operating. So this is very important. If the battery is very low, then you must charge it. Otherwise, after some time, the pump may not work. So the first thing you have to see is whether the battery is good or not. Second thing is the reservoir is having insulin or not. These 2 are very important. So this is what indicates that it is full. Then what is the time, what is the blood glucose, and what is the active insulin. Active insulin will come a little later. So these are the things that you see first step on the screen. Next is when you press the button which has 4 If you press this diamond, 4 diamonds, then you will get this home screen. Here in the home screen, you can see the glucose value here. You can see the trend of the arrow. So the trend arrow shows in its direct vertical, it is flat, it is inclined. If it is direct vertical up or down, it means the rate of glucose falling or increasing is very fast. If it is stagnant, that means the rate of glucose is stable. If it is declining in a slant way or going up in a slant way, it means that there is slow increase in the glucose level, because that will help you to understand how fast the glucose is increasing. Because if the glucose value, what it was earlier, if it is from 80, it is going up to 160, or is it coming down from 200 to 160, you will know when you look at the arrow. As soon as you see the arrow, the patient glucose is 165, but you see the arrow is going down. Here, you have to be cautious when you give the correctional dose. Okay, we'll come to it later, but we calculate correction dose. How do our patient is about to eat, but the glucose is going down. We don't know what the patient did earlier. Patient probably had, went up and down, running into the corridor, came back, and the glucose is coming down after sitting for 15-20 minutes. So you can see here the glucose is coming down, and this is showing that there is suspend icon is on, means that whenever it will go too low, it will suspend. The system is activated. And here you can see it is connected, this active connection is there through the Guardian Connect, and there is also this which shows that all the parameters are, it's an automation that is working, and there is active insulin in the patient around 0.5 units. So we now will go to the next step in this. So there is something known as smart guard settings in the chart that you have, okay? Can you see only when the patient is connected to the CGM can these work, otherwise this will not work. So in that there are 7 settings. One is suspend before low. If you see, it is on the side of the graph. Can you see in that? Suspend before low, not in the sheet. Okay, there in the settings, this will come, you can see here, suspend hard, and there is a smart guard checklist. So in the smart guard checklist, these are the 7 things that will be there. Suspend before low, low limit threshold. Suspend before low means you have to press yes. If you say no and it is still automation, it will not work. So you have to switch it on. That means it will suspend as soon as it is going low. What is the low limit threshold at which it will stop? This is in the sheet. In the sheet. Yeah. Correct. And the low limit threshold is 70. In patients who have got hypoglycemia unawareness, you can set it at 80 also. You don't have to keep it at 17, probably pregnant women, you may set it at around 65 to some height. Then alert before low, alert on low, alert on high, auto correction on, then active insulin time. Usually for universally easy purpose, we keep it at 2 hours. We can go up and down, but for most patients, we will keep the active insulin time as 2 hours. When do you change them? Whenever you get lows, you usually increase the active insulin time. Whenever you get highs, you usually reduce the active insulin time. Then you can adjust the other things like ICR and everything else. So we'll go to these slides. So before basal is very clear, we have got the basal because the pump takes care of the basal most of it. Most of the things, and initially you said after 3 days it starts, by the end of 2 weeks. Pump is doing very good job with the basal rates, and the basal insulin, it is doing an excellent job. The only thing you have to be cautious is like when we spoke about exercise, you need to suspend or set the temporary rate at least 1 to 2 hours earlier and not just before exercise. If you do it just before exercise, you will end up in hypoglycemia after some time. So at least 2 hours before you have to set the rate, or if you want to suspend temporarily also, you have to do that earlier so that you don't get into hypoglycemia. If you do that, the basal works excellent. It's a very good, almost you can say 90 to 100% accurate in terms of its basal delivery, adjustment and dosing. Now coming to the bolus. So before bolus, we need to understand two important terms. We all have learnt about it. So what is insulin carb ratio and what is ISF, insulin sensitivity factor. Insulin carb ratio is, you can take any number from 400 to 500 and you divide by whatever dose you calculated. So if you have kept as, use 500, you can use 500 also, or you can use 400 or 450, whichever you are comfortable. If the patient is predominantly taking carbohydrates, you usually keep it at a higher level, because when you have a predominantly carbohydrate intake, the insulin sensitivity also, the rate at which the insulin work also, everything will be fast. So you take insulin carb ratio as 450 or 500, divide by the total dose, which can also vary according to the patient, but fix some number, take that. You will get a number, usually on an average, most of the time it is between 10 to 15. So like Dr. Sachin said earlier, you can adjust this on a rough basis also. If you don't know anything, patient is not ready to calculate, you don't have time, fix it at 10. After 2 days, you can always see the changes in the sugar levels and easily either reduce or increase it. If you want more dose, you will reduce the ICR. If you want higher dose, you will reduce the ICR. Like we saw in that patient, slight reduction in the ICR value will increase the insulin dose that is delivered. So you can start with 10 grams for 1 unit and go up or down depending on the response that you see when the patient, you give insulin, see for 2 hours what happens, and then you make the adjustment for the same meal that the patient is taking. Next is insulin sensitivity factor. Again, you can use 1800 divided by the total dose. You will get a number. And based on that, you can give the patient the dose. So how do you calculate? What do you do for giving the bolus? So if the patient is on the automated mode, then the bolus wizard will come into the picture. Okay, when the patient, last page, you can see the bolus wizard comes into the picture. Here what happens, the patient, you will calculate the food bolus that is required. That is the total carbohydrate intake divided by the ICR. So patient is taking say 60 grams and the ICR you got is 10. The amount of insulin you will give is 6 units for the food. Now there is a correctional bolus. What is the current glucose value? The current glucose value is say 150, you can see there, and the goal is 100. So 150 minus 100 is 50. 50 divided by the ISF. ISF again, if it is 1800 divided by 40, 45, you will get a number which is around 40 milligram. So you can say 100 is the target, 110 also is okay. So you just give 1 unit extra. So you got 6 units from the food bolus and 1 unit from the correction. But what we need to see is here, if you see up, the active insulin is how much? 0. Can you see here active insulin? When the active insulin is 0, there is no need for correction that the bolus wizard will do. You give automatically whatever is the dose, 7 units, you will give, 7 units will be delivered. But when there is active insulin in the body, like here 1 or here 0.5, that will be subtracted on its own when you are using the bolus wizard calculator. So even if you press give 7 units, it will deliver only 6.5 units or 6 units to the patient. So these are the other things that you can see here. Suspend all delivery if the patient is going for some, swimming or something. You want to suspend all and then move on. That is here. There is a smart card checklist. You can see the pump, what is the battery, what is the insulin here, sensor, whether it's working or not, how many days. You can see 7 days the sensor has been there, and the battery of the sensor and it's working or not. So that sensor logo is here. Can you see here? Top is round. This is the sensor logo that the sensor is connected. So again, if you press the right side button, you will get the time in range. This is the shortcut for this, which will show you everything. Time in range, 78% graph, and also the value. This is for the right side button. If you click, you will get that. So this is Just to show again, when you press the bottom button, when you press the down button, you will get this. To get the bolus wizard screen and pressing the bolus. Down is bolus, right up. When you press the top button, you will get this smart guard checklist, suspend all delivery, pump sensor. When you press the top button, so down you will get the bolus, top you will get the smart guard checklist, pump sensor and suspend bracket, and then when you press the right side, you will get the time in range. When you press the down again, little more for a short period of time, then it will upload the entire thing to the care link. If they don't do that, it will not get uploaded to the care link, then you will not be able to deliver. So at least once in a week, the patient should upload entire thing to the system, and the code number is there here, so everything gets down there. Next is when you press the center button, you get these things, the smart guard, sound, vibration, glucose settings, pairing of devices, insulin status, reservoir, history and graph. I'll go into the next slide to see what they are. So smart guard is the smart guard checklist, temporary target, and the smart guard settings, whether they are on or off. If the patient is not on the CGM, it is as good as it is off. Okay, even if you press it on, it will not work. Then you'll get the history, graph, glucose levels, time in range, everything. Then you'll get the new cannula filling. So all these things are there, and looking at the settings, alert settings, device settings, and delivery settings, all of these can be done through this. When you press the center main button, you will get the menu button, you will get all of this, and you can navigate and set them accordingly. So all of you have, I think Dr. Sharvil showed a wonderful video of inserting this that we have already seen. We will just revise them. There are 3 types. One is the 90-degree cannula one. You can see here 90-degree soft tubing, which is commonly used. Second is the 30 to 45 degree, which is for lean patients. Some people are very lean, 2-year-old, 3-year-old kids come. They've lost a lot of weight in the initial part, first year. After 1 year, they become chubby and they're doing very well. Then you can go back to the 90 degree. But initially, all teenagers, you can see newly diagnosed type 1 diabetes, lost 15, 20 kgs. For them, this is probably ideal one to start with. Lean, very active lifestyle, and they're 30 to 45 degrees. You should change them once in usually 3 days. And there is one more, which is steel needle with extra adhesive pad for more secure connection. Those who are very physically active, doing a lot of things. So for them, they have to change very frequently. Some people develop induration as soon as you start. So for them also, you have to change very frequently. These are the areas where you can use them. We will finish with this YouTube video. If it gets on. There is no internet. I think we have seen Dr. Sharvil's video is much better than this. I think that is enough. So what addition to the newer setting is that there are 8 patterns that you can set. Okay, so you can set basal 1 to 5. You can set a work day basal rate. You can set a day of basal rate. You can set a sick day basal rate, which is preset. So the day you are sick, you can just press that sick day button. Everything will be slightly on the higher side. It will work well. And the day off, where you are sitting at home watching TV, doing nothing, no walking, no exercise, you can set it little high and leave it at there. And the work day or the workout day is when you are working out really hard, you want to have a different rate. You can set that previously based on what your experience and leave it like that. And whenever you want, you can go and set that. You will have this basal pattern. You go to the home screen, delivery settings. You will get basal 1 like that. You can add new basal 1, 2, 3, 4, 5, work day, sick day, and a day off, and set it and leave it like that. Whenever you want, you can switch that. You will get the basal rate that you want for your system, which will work at that time. This works especially when you are on a manual setting. When you are on a CGM linked, which is automated, you don't have to worry much. It will usually take care of itself. Again, the same thing, when you want to set, you can set at different time periods and use it. And again, when you want to give the bolus insulin, you go to the center button, press this, you will get the bolus. When you press the bolus, you will get this. So here there are 2 things. One is in a manual, and when it is automated. Automated, most of it is calculated on its own. It will give. In manual, you have to look at the active insulin that is there. Look at the blood glucose, then the bolus will come. depending on the blood glucose level. This is where when you check with the glucometer also, it will come to the insulin pump itself. When you use AccuCheck guide glucometer, only that glucometer it can read. No other glucometer can be read by this pump. So when you are using AccuCheck glucometer and you want to give bolus, you check, it will come there, then you can calculate, and you can, the bolus delivery comes as the number of carbs that you are taking, and it will deliver. When it is in a manual mode, you have to press the number of carbs it will give, then you will get the, you press the number of carbs required, active insulin will be subtracted, and the total bolus will be there, and you press the deliver bolus. The bolus will be delivered depending on the current glucose, total carb intake, active insulin in the body. Looking at all these three, and sometimes if you need any adjustment also, it can be done based on the active insulin for the particular patient. AccuCheck Roche meter, that is guide, is what gets into the, it's connected to the insulin pump, and that will be able to give you the value, and you can calculate and you can give the bonuses. With this, I thank you all for a patient listening, and you can. Just to finish, I will revise what you must know. You must know the total daily dose. Second, you must know that you should reduce it by 15 to 20%. Then you have to calculate the basal dose. You have to calculate the basal rate. Day and night you fix. If it is on automated mode, then it will take care of itself. Nothing to worry. The basal, you forget about it. If it is manual, you have 8 different settings that you can calculate. At the end of 1 or 2 weeks, you can fix those 8 settings temporarily and leave it whenever you want. You can adjust. This is for basal chapter close. If you are having smart guard and connected to CGM, you need to activate this smart guard setting, which includes suspend, active, all those things, and then use the bolus wizard, give the bolus, and then you will see that the patient is happy. You are also happy. Thank you.
Thank you, sir, for the wonderfully interactive session. Actually, due to paucity of time, we won't be able to take any question answers, but Medtronic team is already there, so they will be taking care of any questions if you have. Okay, next up, we'll have the Meet the Professor session.
Before coming to the Meet the Professor session, all the participants who have participated and registered in the insulin pump workshop, please collect their certificate from the backstage. Now coming to the Meet the Professor session, for this session I would like to call upon stage Professor Dr. Sanjay Kumar Vadada sir. Along with sir, I would like to call Dr. Jayaditya Ghosh for the case of hypercalcemia. So, Dr. Jayaditya Ghosh, he is a consultant endocrinologist in the Yashoda Hospital. Have achieved first prize in paper presentation in ESICON 2023, and also in first runner-up in oral presentation in RDCC 2024. Have 19 publications in international and national journals, and 1 chapter in RCCD Atlas of Diabetes, Food on Charcot's Food. So, Dr. Sanjay Kumar Vadada sir needs no introduction. Still, sir has been an immediate past president of ESI, has received teacher oration, and also received Golden Jubilee of RSSDA Award from the Research Society of Study of Diabetes in India in 2022, and also received Professor R.G. Das oration from Odisha Endocrine Society 2022.
So, good evening, ladies and gentlemen. So, in this post-lunch session after diabetes, now we are moving to the metabolic bone disorders. And next 1 hour, what we are going to do is that we are going to discuss the hypercalcemia, approach to hypercalcemia. And during this 1 hour, this will be a case-based approach that how to approach a patient of hypercalcemia. So these are the learning points for this, or the learning objective of this 1 hour session. How to approach a case of hypercalcemia, proper diagnosis in PTH dependent hypercalcemia, and problems with the imaging in the primary hyperparathyroidism, then treatment of patient with hypercalcemia. So in spite of the best effort and available facilities, the significant number of cases where the final diagnosis of hypercalcemia is not made. So seen by this one of the study which is published, that is in the most common cause of hypercalcemia in hospital setting is malignancy, followed by primary hyperparathyroidism, and then vitamin D intoxication, and finally is the unknown causes. So this vitamin intoxicity is upcoming cause. It is multifactorial, that because number of preparations are available of the vitamin D, many times patients are taking more than one preparation, and thanks to our orthopedic colleagues, they are prescribing injectable vitamins. That is also another way, and fortification is coming another way for the cause of hypercalcemia. So we have few cases, and as time goes on, we'll do these 4 or 5 cases. So for this now I invite Dr. Jayaditya Ghosh. So Dr. Jayaditya will present the case, and after each case we'll engage the audience to give their thoughts and what they are going to do. So that is the plan. So over to Dr. Jay.
Thank you, sir. Thank you for giving me the opportunity. So as we all know, when we are dealing with a case of hypercalcemia, the next step we generally do is do a IPTH. So if the IPTH levels are high, we generally suspect either it is a PTH dependent, that is primary hyperpara, and FHH can be a possibility. The other possibilities like lithium dependent, and in patients having tertiary or other causes that can be in PTH dependent. So when we are dealing with PHPT or FHH, it can be, we can differentiate it with urine calcium creatine ratio. So if the urine calcium creatine ratio is more than 0.02, we can think of primary hyperpara, and if it is less than 0.01, we suspect it to be FHH, and we can go forward with a genetic test. So if the PTH comes to be low, then we can go forward with the PTH RP and a vitamin D levels. So elevated PTH RP leads to, can lead to suspicion of malignancy, whereas elevated 125 vitamin D can lead to suspect of lymphoma, sarcoid, and granulomatous diseases. So elevated vitamin D in the background of low PTH and hypercalcemia generally suspect of vitamin D intoxication. If both those are normal, then we can suspect myeloma or other rare causes. So we'll come to the PTH dependent hypercalcemia cases. So the first case is a 34-year-old female patient who presented with history of recurrent renal stone disease, operated actually 8 times for renal stones in the bilateral kidneys, no history of any fracture, pancreatitis or gallstone. Father had a history of renal stones. So she was referred to us for the workup of recurrent renal stone disease. On evaluation, the patient was having a calcium of 10.9, where the upper cutoff limit was 10.2. Phosphate was normal, albumin was 4.1, PTH was 52. So if we take calcium high and in the background of 52, so it is a PTH dependent hypercalcemia if we are suspecting that, and vitamin D was adequate. So we went forward with a urine calcium creatine ratio which was 0.016. So it is in the borderline zone. So we have a case of recurrent renal stone disease with hypercalcemia, with increased PTH, and a urine calcium creatine ratio of 0.016. So I would ask sir to take over this part and discuss what can be the diagnosis regarding this.
So with this brief history and the biochemical investigation, what should be the diagnosis and how will you proceed, or you want any other investigation in addition to this? Maybe DM residents can take the lead. Primary hyperparathyroidism, okay, that is definitely there. That is one close differential diagnosis. But the calcium is, corrected calcium is 10.9. And there is a family history of renal stone disease. So of course in primary hyperparathyroidism, the family history can be there, but usually in India we see the sporadic primary hyperpara is most common. Any other differential diagnosis? Yeah, so FHS, can we consider FHS? Yeah, so that's, you are correct. The ratio is 0.016. So that is, it is in the gray zone. 0.01 to 0.02 is actually a gray zone. If it is less than 0.01, then it's fine. Or if it is more than 0.02, still it is fine. So it is a gray zone. Any other differential diagnosis? So one is primary hyperpara, second is FHS. Would you consider normocalcemic hyperpara? So that's fine, that is not normocalcemic, okay? Any other? FHH? Not FHS. So in FHS, calcium level can be up to 11 is fine. So are you feeling that FHH is not a possibility because of renal stone disease? No, so FHS can have renal stone disease, even in pancreatitis also. So that is not a exclusion for the FHH. Dr. Jai, next.
So we are going forward with this. So the differential diagnosis that was discussed, familial hypocalciuric hypercalcemia can be a possibility, PHPT, and normocalcemic hyperpara with conversion to PHPT, that the history was over a period of 8 years. So there is cases where there is conversion of normocalcemic hyperpara to primary hyperpara. So that can be a possibility. So if we discuss the familial hypocalciuric hypercalcemia, so there are actually 3 types. So if we want to differentiate between the types, we generally depend upon the calcium creatine ratio. So when we want to differentiate between the types of FHH, like the type 1 is because of CSR mutation, type 2 is because of the AP2S1 mutation, and type 3 is because of the GNA11 mutation. So then we have to do forward the calcium magnesium clearance ratio. So in that case, if the calcium magnesium creatine ratio, if more than 5, then it suggests FHH. If it is less than 5, then it is more towards FHH type 1 and type 2. Because in patients of FHH3, there is relative hypomagnesemia. So that leads to the increase in the ratio. So by this, we can differentiate between the types of FHH if we are suspecting that. And this is one of our study that was done from our institute, where the presentation was defined in patients of PHPT, where 50% of the patients had either bone disease and 1/3 had renal impairment. Compared to the Western population, in our population, the presentation was more symptomatic as compared to the Western population, where it is still asymptomatic, as it is said. In the normocalcemic hyperpara, there is increase in PTH level in the setting of a normal albumin corrected calcium. So after ruling out all the secondary causes of PTH elevation. So it should be confirmed as per the definition on 2 occasions over a period of 3 to 6 months to make a diagnosis of normocalcemic hyperpara. So actually this is a spectrum of disease from normocalcemic hyperpara to PHPT. There are actually 4 phenotypes. Type 1 is the PTH is elevated, but it is in range. In the phenotype 2, there is increase in the PTH with normal calcium. So phenotype 3, there is asymptomatic PHPT where the calcium is high and the PTH is also high, and phenotype 4 is actually the PHPT. So there is the rate of conversion I was talking about. It is around 9% as estimated by a study over a period of 4 years, but rates can vary from 1.6 to 22% depending upon the population that we have included in the study. So coming back to our case, so the genetic evaluation was done for our case and the CSR pathogenic mutation was found. So patient was having a FHH. So coming to the data from our center, when we compared the patients of PHPTA and FHH, we found that even in FHH, 10% of the patients had renal stone disease, and it was though statistically less as compared to the PHPT patient. So we were having a diagnostic dilemma that we should be very aware while dealing with patients of hypercalcemia with a raised PTH levels. So coming to the learning points, that diagnosis is vital as the treatment is totally different. We generally do not go for surgery with FHH, whereas in PHPT, surgery is the primary treatment modality that is advised. And careful evaluation of biochemical test needs to be done and genetic test may be needed in some cases. So coming to the case 2.
Yeah. So I think in this particular case, the message is very clear that we should not go for imaging immediately. That is very, very important. And the diagnosis of primary hyperpara is mainly based on the biochemistry, not on the imaging. So we suppose do the imaging and suppose ultrasound is done by, because they will look the report, okay, that may be likely possibility, they will write something that some looking hypoechoic area, then you go for the maybe, then maybe some confusion, everything will be in confusion, and sometime patient is operated for that, that is futile exercise. So it is sure that you should make sure that patient is clearly having hypercalcemia, then and then the patient should be subjected for the imaging itself. I am not talking about surgery, I am talking about the imaging itself. Otherwise you do imaging, then you in the further trap. So the rule is following the biochemical diagnosis should be considered in any endocrine disorders holds true in this particular patient. Thank you, Jai.
Thank you, sir. Coming to the next case, a 44-year-old male patient actually presented with history of generalized body ache. So for the last 2 years, he had history of recurrent renal stones as well, operated thrice. No history of any pancreatitis or fracture, no family history or any renal stone disease, no history of any headache or visual impairment. The patient was operated in 2004 for the first time for renal stone disease. So in 2021, the patient was actually evaluated routine checkup and was found to have hypercalcemia. The calcium was 12.9, PTH was elevated, vitamin D was 28, and a CECT neck was done. Left inferior parathyroid adenoma was localized in the CECT neck. So patient underwent removal of the left inferior parathyroid adenoma. HP showed no parathyroid tissue and patient was not in remission. Calcium was still elevated and PTH did not decrease after the surgery. So after 6 months, the patient again underwent a MEB scan this time. So LIPA was localized this time as well, underwent again a surgery for resurgery for the LIPA excision. HP showed a colloid goiter, no parathyroid adenoma this time as well. The corrected calcium and the PTH was still elevated. Going with time, in May 2023, patient was repeated a MEB scan. Because earlier 2 times, because of the surgery failed, the surgeon went for a left hemithyroidectomy. And this time also, no intrathyroidal parathyroid tissue was located in the surgery tissue. And calcium and PTH was still elevated. So we are dealing with 3 surgeries down the line, still not in remission.
So this patient actually happened what we have seen the previous patient, that in spite of the multiple surgeries, patient is not in remission. So what do you think, what is your next plan if you see such patient, you are in the referral center? Ectopic, okay. One possibility is ectopic, fine. Imaging is the same center they did the imaging, yeah. Parathyroidmatosis can be there, that may be another differential, of course, that is there. So one is that ectopic is a strong possibility, and God is given multiple parathyroid glands, and unfortunately they are distributed all over the area, and that is a really nightmare for an endocrinologist if there is ectopic parathyroid gland is there. That is one. Second is parathyroidmatosis. Fortunately, parathyroidmatosis is very, very rare. In our patients of Indian PHP registry, 1,000 patients are there, more than 1,000, we have only 1 or 2 patients of parathyroidmatosis. So these 2 possibilities. What is the third possibility? Anaplastic. Hyperplastic, okay. Maybe a possibility, you can consider that may be a possibility. Yeah, so every time they are showing that is tumor in the LIPA, that is the LIPA was there. So I think I'll put my money on the ectopic. It might be ectopic. Let's what Jai is showing in the next slides.
So in 2024, patient was referred to our center after 3 surgeries. The calcium was elevated, phosphate was low, PTH was elevated, a choline PET scan was done this time. Apart from earlier, the patient had undergone a CECT neck and a MEB scan. The choline showed a highest mediastinal location at the level of D1, D2 to the left of IJV. Likely ectopic was the report that was given there. And SESTA-MEB on repeat SESTA-MEB scan there, they also showed that it was in the similar localization that was done. Patient underwent surgery and HP had showed parathyroid edema, calcium level, PTH level dropped and calcium also normalized. So coming to the problems in localization, the localization that we use are USG, MEB and choline generally. And localization allows actually, why localization is important, it actually allows performing a guided parathyroidectomy, minimal exploration, hospital stay is become shortened, helpful in to suspect FHH, increased localized parathyroidectomy can be done in patients having under cervical block as well. So reduces the chance of failed surgery. Likely reasons for non-localization are usually location of unusual locations of adenoma, parathyroid hyperplasia as was discussed, less experience of the interpreter in case of USG, and ectopically located adenoma. So these are generally the sites of ectopically located parathyroid gland, like under the mandible, retropharyngeal space, level of the thyroid cartilage, retrolaryngeal space inside the carotid sheath. Intrathyroid can be there, retroesophageal within the thymic ligament, and intrathoracic can be there. So the other modality is also 4D CT, which can be done for use of localization of parathyroid tissue as well. So coming to the publication that was done here, which showed that the sensitivity and the positive predictive value of USG was around 69.3 and 87.1% in USG. MIB was around 80.7 and 97.6, and choline has a sensitivity of 100% with a positive predictive value of around 96.3%. This is another review article which was done, which showed that combined imaging modality gives a better result, like combining with choline PET scan has a better outcome as compared to the combining the other two.
So that's why this imaging is also an issue, like for ultrasonography or ultrasound, you need a experienced radiologist. That is the important one. For MIB also, there is 3-4 important precautions are required. One is patient should not be on the calcium channel blocker, should not be in the calcium mimetic agent like cinacalcet, as well as the active vitamin D. These will hamper the imaging with the MIB. So there is some of the precaution while you are getting the imaging. And in our clinical practice, what we do is that we always take at least 2 modalities should be concordant before subjecting the patient for surgery. Not if there is one is showing something different, other is different, then better not to subject the patient for the surgery. And very happy that the choline PET is actually having very good sensitivity and specificity, even for the ectopic location also. What exactly happened in this patient is that patient had even hemithyroidectomy was not cured because that was not the correct location of this adenoma, and that was in the upper mediastinum. So that is required. Many times experienced surgeon, when they operate for parathyroid gland, they'll put their finger in the upper mediastinum and remove the thymus irrespective of that, because the adult patient thymus is not used, and many times ectopic lesion is there. So that can be another good idea to operate at that time, and the imaging, you can utilize the imaging properly. So if it is, and you need expert parathyroid surgeon, that is also very, very important, because the ectopic location is very common. The surgeon is able to differentiate, and many times our patient is going one after another surgery in the same sitting, or maybe third day they are re-operating. The patient is not normalized calcium and PTH in next 2 to 3 days. So sometimes they require the multiple surgeries. So that is also there we should keep in mind. So this is the diagnostic dilemma, and depends on what facility you have. So that is there. Thank you. Yes, Jay, please.
So the learning points, choline PET has a highest accuracy and sensitivity, and combined imaging modality should be utilized in patients dealing with such difficulty in localization. So coming to the third case, a 35-year-old female known case of diabetes on oral medication presented with history of patient presented with a biochemical diagnosis of hypercalcemia, history of gallstone disease, had a history of pancreatitis 2.5 years ago, which was managed conservatively. Patient had no history of any renal stone disease. There was no history of any headache or visual impairment. The calcium level was found to be 11.12. Phosphate was low. PTH was elevated, 150 picogram per ml. Vitamin D was adequate. Imaging localization was done for this patient in view of PTH-dependent hypercalcemia. USG neck showed a query lymph node. Cesta MIB was done, which showed intrathyroid adenoma. That was mediated focal areas of subtle hypodense lesion in the left lobe of the thyroid. Choline PET scan was done this time, but it was of no use. It did not show any localization. 4D CT was done as well, so it was not showing any obvious lesion. So opinion for this patient.
So what do you think in this patient? What should be the next step?
Sir, needle to PTH.
Pardon?
Sir, needle tip PTH. Sir, needle tip PTH. Needle tip. I will put the needle in the adenoma and check the PTH.
You are doing FNAC?
Sort of FNAC, sir. I will just wash out the fluid and check the PTH level in the fluid. So if it is more than 30,000, it's
okay. Fine.
It was more than 0.02. It was more than 0.02, sir. Normal.
0.2, so that is suggestive of primary hyperpara. Any more suggestion what you can do? Any imaging, any treatment plan? Because like in primary hyperpara management, one important thing is dharya rakhna chahiye. Matlab, we should not be in hurry because you have a lot of other things to do rather than after the patient to immediately subject for the surgery or something like that. And if you are doing imaging and the imaging is done at baseline, then need not to do subject imaging time and again maybe 3 months is too short a period. Maybe end of 1 year or maximum after 6 months only you should do re-imaging. Before that you have some treatment plans, what we have with us so that we can utilize that. So what we did in this particular patient, Jai will share you with.
So the treatment options that we have is giving a management for hypercalcemia and waiting for 3 to 6 months as sir suggested, or the intrathyroidal adenoma, that excision of that part can be done, that was localized in maybe. So any opinion regarding the treatment options that we discussed from the house?
Okay, that is a possibility. But meanwhile, how to overcome this hypercalcemia, what you can suggest, what we can do? Cinacalcet, okay. Okay. And this one is good hydration, that is important. For the DM residents, what do you understand by good hydration? Anyone? For the DM resident, what do you understand by good hydration? How will you explain the patient that you should be well hydrated? So good hydration meaning by that, if the urine color is like water, that is a good hydration. It's a very simple way of explaining that what is the criteria to say the good hydration. So of course, we have anti-resorptive agents, very powerful, very effective, and at least they can persist their effect for a few weeks to months, so that can be tried. Then you can do reimaging. Yes, Dr. Jai. Yeah.
So coming back to our case, patient was explained regarding what options we have, like waiting for 3 to 6 months after giving a management of hypercalcemia, but the patient chose to go forward with surgery as we gave options of 4-gland exploration, and we removed 3 glands, kept 1 gland, but patient had hypercalcemia in spite of that. So patient was put on Cinacalcet as was having mild hypercalcemia after the surgery. So as this patient had gallstone disease, this is one reference that we have, that gallstone disease prevalence is more in PHPT patients as well. So this was a therapeutic dilemma that we had for this patient, what treatment to be given. So the learning points is that treatment options should be individualized. If localization of the adenoma is doubtful, we can manage the hypercalcemia and repeat the imaging after 6 months, as going forward with surgery may not be fruitful as we saw in our case. So it was not very fruitful in management of hypercalcemia here. Next. Coming to the next case, a 34-year-old female patient with history of recurrent episodes of nausea, vomiting, excessive heartburn, easy fatigability and loose stools, no history of any headache or visual impairment, no history of galactorrhea, menstrual irregularity. She was evaluated outside and was found to have hypercalcemia. Calcium was elevated with a PTH elevated, ultrasound neck was done, and it showed a left inferior parathyroid adenoma. Went for excision outside, persistence of high PTH and calcium, as the patient was only localized with a USG. Referred to PGI, a sestamib scan was done, showed again REPA and LEPA localization, and underwent bilateral neck exploration. Calcium and PTH normalized, and calcium also normalized later. HP showed parathyroid hyperplasia in the bilateral specimen that was sent. In view of persistent dyspepsia and reflux history, Syndromic association was thought of, gastrin was sent, which was elevated, prolactin was normal, CCT abdomen was done, which showed an enhancing lesion in the tail and body of the pancreas of 2 into 1.8 centimeter. And in the left adrenal as well, there was a mass that was 2 centimeters. The biochemical analysis for the left adrenal functionality was done, which was negative. And dotted PET scan was done, which was showing a SSTR expressing lesion in the pancreas that was suggestive of neuroendocrine tumor. And left adrenal mass was non-enhancing in the SSTR, dotted PET scan. So the patient underwent an endoscopic ultrasound, which showed a mass in the body, which was underwent surgery and as well as left adrenalectomy in view of suspect of syndromic association. A genetic analysis was done, which was positive for MEN1. Underwent PRRT for the neuroendocrine tumor. Son was also evaluated because of the MEN1 positive diagnosis, and patient was found to have hypercalcemia with a PTH elevated. Localization was showing to be have LIPA and MEB scan, and patient underwent 3 gland removal with a thymectomy. So how to screen these patients?
So now obviously the diagnosis is multiple endocrine neoplasia 1 and in our clinical setting. So one is that always take a detailed history as any clinical science is there. His son is symptomatic and evaluated and found to have multiple endocrine neoplasia. So here these 2 questions are there. One is that how extensively we have to evaluate for this multiple endocrine neoplasia, and patient is having more than one tumor, like he's having or she's had parathyroid gland hyperplasia or adenoma, she had a pancreatic lesion, then she had a gastrinoma also, then she had a pituitary lesion also. So how to proceed, how to manage? So this is the question in your clinical practice. So anyone from the house? Just to keep you everyone engaged, we are asking this question. It is just, and you must be seeing similar type of patients in your clinical practice. So what do you feel about that? So obviously for screening, these are the all 3P we have to screen for that. And out of these 3P, the mortality is associated with the pancreatic lesion. If the pancreatic lesion is more than 2 centimeter, there is indication for the surgery. If the size is less than 2 centimeter, it is good to wait and watch. Sometimes they are not going to cause anything, does not increase in the size also. Now the second question is, if you have all 3 problems, what is your plan? How to plan? So, especially patient is having hypoglycemia, suppose. Then patient is hypoglycemia and hypercalcemia. So what should be the first target? Hypoglycemia. Anyone else? So, of course, hypoglycemia, if it is severe, that is important. But if it is not really severe, in that case, you can operate hyperpara first, made the patient eucalcemic or eupara, and we know that calcium is an important molecule to increase the insulin secretion. And some of the patient, what we found is, patient having the symptom of hypoglycemia, we operated their primary hyperpara, they are eucalcemic, and patient's hypoglycemic symptom improved. So the first is low-hanging fruit, use that. And if it is responding to that very well, if not, then you can go for the subsequent surgeries. So that is the plan of surgeries.
So coming to the screening, so individuals who were tested for MEN1, patient who have patients less than 35 years with hyperpara, patients who have 2 or more endocrine organ tumors, first-degree relatives with MEN1 should be screened. And the age of onset of screening should, in parathyroid, 8 years, gastrinoma 20 years, insulinoma 5 years, and other neuroendocrine tumors, that is less than 10 years. For anterior pituitary screening, it is around 5 years, adrenal less than 10 years, and thymic and bronchial carcinoid, it is around 15 years. So this is the screening protocol that we follow. And as sir has already said regarding the sequence of surgery, so if there is hypoglycemia, is the symptom with hyperpara, so we can go forward with the parathyroid surgery, and then we can go forward with the pancreatic surgery. So this is the syndromic association that we see with patients with hypercalcemia. So the learning points, all symptoms should be given due weightage, as the patient was having dyspepsia, as well as after diagnosis of calcium, we should look for other causes as well if it is not improving. Syndromic association should be kept in mind and evaluated properly, like in this patient, and family members of proven genetic mutation should be adequately evaluated. Like the son in this case was also evaluated and found to have primary hyperpara, as the patient was having a MEN1 genetic mutation positive. So coming to the next case, a 65-year-old female presented with history of low back pain for the last 5 months, gradual onset, dull in nature, and increase on movements including bending. Patient was having easy fatigability and lethargy for the past 2 months. There was no history of any other comorbidities apart from having hypertension. This was the biochemical parameters that was there. Patient was having anemia. We did the urea creatine. The creatine was elevated, 5.2. And the patient was having hypercalcemia. 15.1 was the calcium level when the patient presented. In view of management of the hypercalcemia, we had given denosumab, and acute management of we managed with calcitonin as well. So calcium normalized. Phosphate was slightly on a higher side, 5.7. In the background of CKD, it can be there. ALP was normal. Vitamin D was normal. PTH was elevated. So we went forward with a ultrasound abdomen. There was cholelithiasis there. USG neck showed a PTH adenoma there in the left inferior region. So a sestamibi PET scan was done, and it showed a faintly MEV-avid, ill-defined 0.3 into 0.6 centimeters lesion in the left inferior parathyroid adenoma. So obvious diagnosis, right?
So we have discussed the sporadic primary hyperpara, we discussed the FHH, we discussed the hypercalcemic hyperpara, and we discussed the familial hyperpara. So now here is the case. Those who listen carefully, what do you think, what is the possible diagnosis? Phosphate was 5.1. Tertiary hyperparathyroidism, okay. Creatinine is there, but kidney size was normal actually. So it was less likely, the CKD is less likely. Yes, sir? Pardon? Yeah, so there may be a possibility of combo rather than just thinking about the primary hyperpara or something like that. There is 2 clues, and in our clinical practice, hemoglobin is a very, very important parameter, and this patient has a low hemoglobin. That is one. So if the low hemoglobin and high phosphate, pardon? Multiple myeloma. How many agree with multiple myeloma? Please raise your hands. So less than 20% people are ready to accept the multiple myeloma. And primary hyperpara? Coincidence combined. Very less few people are ready to accept the, if I'll say both, then how many people are ready to accept the combination diagnosis? Okay. So majority people are feeling it is just multiple myeloma only. Okay. Let's tell the Jay what he says.
So we went forward with the radiology. There was punched out lesions, as well as there was vertebral fractures noted. So when we look into the biochemical picture, high phosphate, normal ALP, AG, reversal ratio, renal dysfunction, anemia, as well as weight loss with chronic back pain with hypercalcemia. That is PTH dependent. PTH was elevated. So we did forward with the peripheral blood smell. It showed a circulating plasma cells of 3% and M spike present. Bone marrow diagnosis was done, which was consistent with multiple myeloma, and a diagnosis of severe hypercalcemia, acute on chronic CKD, as well as multiple myeloma plus primary hyperpara was done. So there are certain clinical features which are actually combined in PHPT and multiple myeloma that can be there. So anemia, bone pain, renal dysfunction, hypercalcemia, all of them can coincide in both these cases. So we have also been seen that we have case reports where in patients with anemia presenting in PHPT as well. And the mechanism of development of anemia in PHPT is actually fibrosis in the marrow. So after, this is one case report that was published from our center where pre-surgery and post-surgery there was actually improvement in the marrow because that anemia also improved. So there's a varied spectrum of presentation of PHPT. This is another review article that we published regarding the phosphate being given an underrated importance in PHPT, where phosphate should also be looked into in patients of primary hyperpara. As 58% of the patients with PHPT have hypophosphatemia that has been described in the literature. So the bone turnover in PHPT and multiple myeloma, it's a bit different. Like in PHPT, there is actually coupling. There is increased bone osteoblastic as well as osteoclastic activity. There is increase in beta CTX as well as ALP and P1NP. Whereas in multiple myeloma, there is localized osteolysis because of cytokines, and there is uncoupling that happens with the osteoblastic activity. So there is not increase in ALP and P1NP. That is, in our patient as well, the ALP was normal. So we have a combined presentation of PHPT and multiple myeloma, though a very rare presentation, but still we should be cautious regarding such kind of presentation in patients. The learning points in this patient was the biochemical test should be interpreted cautiously, as they may lead to clues which have to an underlying diagnosis apart from the most obvious one. There may be cases where the initial workup may not lead to the final diagnosis. Like in here, we were thinking of PHPT only, but there were other clues which were leading to the diagnosis of combined. So coming to PTH-independent hypercalcemia.
So calcium is already a poor cousin of sodium actually. So people are very worried about the hyponatremia or hypernatremia, hardly look for the calcium. And I think phosphate is the poorest cousin of these all, so nobody looks at the phosphate, what is there. And this particular patient, the message is very clear, the phosphate is 5.1, so that is something is different. And also for the young people, that there is, you should look for each and every parameter, not only just one parameter and leave it. Another important thing is always should get the calcium into 3, because that is a standard one. The one calcium report never do anything. Ask for the 3 calcium on different days. And if still high, then you should plan for any investigation, otherwise not. So now we move on to this next one.
So a PTH independent hypercalcemia case, earlier all cases were either PTH dependent or a mixed kind of a thing. So here a family of 5 person, 4% presented with history of dyspepsia. Out of 2 patients had history of associated oliguria. So the biochemical analysis that was done was showing calcium elevated in all of the patients. That was more than 14 in all of this patient. Phosphate was normal, slightly on the higher normal range maybe. The PTH was low and vitamin D was significantly elevated. So it was PTH independent. We are dealing with a case of vitamin D dependent hypercalcemia. That is obvious in this case. So what was the connection between all of these patients?
So now it was a real tough one, because you have PTH independent hypercalcemia. PTH dependent hypercalcemia is pretty easy, and of course the medical management is also effective, so you can buy a time of few years at least. But here you don't have time to buy few years actually. So maybe we can have some differential diagnosis, because that is the day-to-day cases that you see. So age of the patient? Yeah, so age of the patient is youngest was 22 years, another was 30 years, and then the 50 and 55 years, something like that. So these are the all adult patient. All are taking vitamin D, okay. So, but they says there is no history of taking vitamin D in form of oral or in form of injection. There is no history. Activating mutation. So yes, that is a good suggestion, but the presentation is very different. One is 22 years, another is 25 years, another is 50 years, another is 55 years. And of course it is a family, so there's not genetically all are same. At least father, mother are different, definitely. And such severe hypercalcemia is less likely. Pardon? Source of vitamin D. Okay, let's discuss what can be the source of vitamin D in your clinical practice this patient can have. It was really a nightmare for us actually. It was very difficult to reach to this conclusion. I will just reveal. So we can have more suggestions from the house. Our 3 residents are there smiling. That was very easy, but at that time it was really very difficult to reach to the somewhere from someone vitamin D is there. Of course, no doubt about the pardon? Tape water also. So I remember there is that is khodeka juice or khodeka soup. Khoda means, I think this is called in goat. Goat is called, and there is hoof of the goat. They are used for to improve the bone health actually. So it was very common in Srinagar. And I remember one of the ISBMR, Dr. Bashir and his team presented few cases. The person started using for weakness that khode ka soup and they developed the vitamin D toxicity. But these all are vegetarian. These are our family, so that is not in the picture. And they were not receiving treatment from any orthopedic surgeon. So that is also out that received the, sorry if there is someone's better half is orthopedic surgeon, please don't mind. This is our interaction between orthopedic surgeon and endocrinologist keep going and we are enjoying actually. They are always ready, okay, Dr. Badada, you are often pulling us, but still we are providing you a lot of patients. Mega, thank you very much. So that is there. Anyone? And this vitamin D is 800 nanogram per ml. To reach this vitamin D is really very, very difficult actually. And fortunately what happened is that these are the 4 family members, but the few more members are there from that locality to develop this kind of problem. Any suggestion? They are vegetarian people, not taking any this one. Pardon, sir? Hamburgers, thyrotox, but they are vegetarian. Yes, differential diagnosis is good, yes, yes. Ergosterol. So it is not available in India. Na? We don't have vitamin D2 preparations. We have vitamin D3. That is another problem because many people are not taking vitamin D3 because their label is to put red label or the green label because it is the animal source. So there is already debate is going on of the ISBMR that what to do and how to solve this problem. Okay, I think we have some more time, so let me buy some time, ask few more questions to that because this is the, Jay, it is last case?
Yes, sir.
Okay, that's good, no problem. So that we have to know how to spend the time also. Any sunlight exposure can cause if they are going for a, on the, what you call vacation, family is on vacation, on taking the sun bath? No? Pardon? Then it will not synthesize the vitamin D that will.
Sir, this is maybe laboratory this may be the laboratory
laboratory error of vitamin D.
Because 8,000 is a vitamin acute toxicity, hypervitamin D.
So we can, sir, we did in multiple labs and we did in multiple times in dilution. So it was correct actually. So for residents, can vitamin D toxicity develop the sunlight exposure?
No.
Why? Why? So it is not possible, but in one condition it is possible. So vitamin D 25 to 125, 125 to 2425. So that is a metabolite which is not active. But if there is a mutation of that, in that case they can develop, then the sunlight exposure is there. After vacation they can develop. Though Indians are not very fond, at least our females are not fond of to go and lie on the beach like the Americans, classical. So that is less likely. So that is also out. Anything else? No clue? Okay, it was difficult for us also. But now Jay, you show some more slide, then we can have one by one slowly. We have a few more minutes to take care.
So this was the clue to that. It was having added vitamin D as well. So when we tasted this oil from a laboratory, it was showing 1 ml of this oil was containing more than 1,000 nanogram of vitamin D. So the whole family was using this oil, and this was actually locally made from a company, and whole of that locality was having this outbreak after using this oil actually. So this was very novel that we found out from this.
Yeah, so now the question here is that I was just wondering that if I calculate, because this fellow is selling this oil at rupees of 100 per liter, right? If this 1 ml contains 1,000 nanogram more than that, If even he is putting vitamin D, is he losing in business? Right? That is important. If he is putting that much of vitamin D in 1 liter, then he has to put pocket from his pocket to that business. I'm sure Indians are that smart. Even they are taking care of the Trump also, so it is not possible to lose the money in business. Right? So, I don't have answer to this question that how he managed to get this much of vitamin D in this oil. So we propose few hypotheses possibly. One is that he got some expired vitamin D where people is about to throw, because obviously they cannot use the human use properly. But they purchased or at throwaway price from that particular chemist or the manufacturer, and they put his oil. And that person was selling this oil with the name, आप ये oil खाए आपका हड्डी पूरा मजबूत हो जाएगा. So something like that he was giving this information. And people, those are taking, and interestingly in this family what happened is that youngest patient affected maximum. The reason was that he was using oil more in diet as well as applying on the chapati also. So that we are planning this, if you apply on the skin and measure the vitamin D, if it is increasing, then good idea to use the vitamin D. Those are not ready to take or apply the oil, like your testosterone therapy can be another one. And these few anecdotal case reports are there. Vitamin D applications improves the hair growth. So people, those are lacking hair, they can apply this vitamin D hair for the scalp also. So that can be another possibility. So this was the story of vitamin D toxicity. So community, sir.
In May and June this year, in an area of Spain, there is an island there, and they got at least 15 cases of hospitalizations because of hypercalcemia, which was on account of vitamin D toxicity. And this they attributed to some, online supplements which the patients had bought. So now the government there has banned these online supplements which contain unaccounted amount of.
Yeah, so nutraceuticals, that sometimes neem hakim khatre jaan. So ऐसा होने का possibility हो सकता है. So in this particular family it happens, and unfortunately few people lost the life, especially the elderly people. When we searched this, we went to this village actually and informed the authorities that what is going on, and 2 people are died because of the vomiting, because they could not understand what is going on. But the 70 plus people, 2 people are died after 70 years and above. These 4 patients were hospitalized, and it is good opportunity to do some research that when the vitamin D level is more than 1000 nanogram per ml, what happens to your peripheral blood counts, what happens to the flow cytometry, what will happen to the high resolution peripheral QCT data. So we are working on that. Jay, you can go. Yes. Yeah. So that's why. Yeah, we did that, and already it was stopped, and even one patient of hypoparathyroidism developed the hypercalcemia because of use of this oil. Right? So that is the problem, and hypopara patient getting the hypercalcemia because of this oil use. Well, we screened some family, those are taking this oil, not each and every one, because those are using this oil, we screened them, and their level is 200, 300, something like that, 20, 25 patients. So he ran away. After that, he reached this information, something is screening is going on then. So that is a, yes, Jay, please.
So that was the last slide. So conclusion, management of acute hypercalcemia is actually universally similar and should be initiated immediately. Etiology of hypercalcemia should be evaluated very carefully, as they may not be that obvious. And the biochemical test should be carefully interpreted so that not to miss any underlying diagnosis.
So I think from our side, this much only. So from this August gathering if they have any question, suggestion, comment on primary hyperparathyroidism, PTH independent hypercalcemia, or combination of hypercalcemia, where that we have few more patients where the combination is sarcoidosis and primary hyperpara. So there's interesting discussion then what to do first. Like in that patient where the combination of multiple myeloma and primary hyperpara was there, we thought to operate first primary hyperpara because that is low-hanging fruit, that take care of that hypercalcemia, then you can manage the remaining one. And it might be interesting that one is supporting other in causing this causation. There is some association is there, multiple myeloma and primary hyperpara association is there, but the sarcoidosis can be other one, and if they are taking kind of vitamin D toxicity, that may be sometime this combination. So that is there. So now we can have questions from the house and suggestion from the house. Yes, sir, please. Yeah, so actually that may be false, basically technique, and they are reporting like that. That's why you need a good clear-cut image as well as the person, because otherwise sometimes it is difficult. So that is always important, sir. Yes, please. Yeah, it's a very good question. So we did it through the LCMS. And that was done in one of the center in the Mohali. They are using for the community purpose all these type of, they are taking the samples that's done on the LCMS, not on the our ICLIA or this one. Good, very good.
Sir.
Yes, sir, please. Yes, Kaushik.
Sir, first of all, thank you for the fascinating cases. So my question is simple. What is the cutoff of PTH that you use to differentiate between PTH dependent and independent hypercalcemia?
Yeah, so that is 20 picogram per ml. That is the standard one. Above 20 is considered the PTH dependent. Below 20 is considered PTH independent. Okay. Yeah. And so because in the Western population, the PTH is 55, 60, something like that for majority of the patients with asymptomatic hyperpara. Yeah.
And the second one is, sir, you had shown in denosumab 60 milligram was used in hypercalcemia one. So do you use 60 or 120 for managing normally?
Very interesting question. And so because 120 is used for the malignancy, not for the primary hyperpara, because the hypercalcemia is not that severe and not that one. And I want to share very good paper which is coming in very soon in Osteoporosis International, where what we did is instead of using 60 milligram of denosumab 6 monthly, we used 9 monthly. And that was effective, and almost 50% of patients, 9.5 months, it was equally working as in 6 months. So because our body weight is much less as compared to the Western population, and unfortunately this all dosage is fixed. Because I was keep thinking always that in medicine, we remember people are carrying a book in the, at least in NHS, they have the per kg body weight, lot of doses are there. And we are using 60 milligram for each and every patient who is having 100 kg or who is having 40 kg. So that our particular paper showed that if your BMI is less and this baseline CTX is low, then you require the lower doses. So the 60 milligram is good for Indian population rather than going for 120 milligram. And the 60 is good for, at least for primary hyperpara, I'm sure there is no problem. That will take care nicely. And another problem with the denosumab is if you use high doses, they develop severe hypocalcemia, especially the patient with renal dysfunction. So always very, very careful, because we had one patient of hyperpara with CKD, and now she's required hospitalization for a long period of time. We have to delay her surgery because she was developed hypocalcemia because of denosumab. So even with the 60 milligram. So 120 is not required for Indian population. I think that's good. And I am thinking now Romosuju maybe 105 is good for us rather than using the 210, which is cost will also increase, and for our body weight that will also be good one.
Okay.
Yeah.
Thank you, sir. Thank you.
Yes, please.
Sir, in vitamin D toxicity, in the last case, what you showed that you gave denosumab and all those things. So, but we all know that in vitamin D toxicity, steroids are given, oral steroid therapy.
Steroid as given, yes.
So how long will you give, sir? How do you decide?
Well, because in these 4 or 5 patients, they presented with acute renal dysfunction actually, and the severe diarrhea and vomiting. So we just vomiting and constipation actually. So we treated this patient good hydration, and 1 or 2 patients required the dialysis actually. This calcium was very high. And we are not actually given the steroid to any one of them. And they improved slowly over the period of time with the hydration and the sinic acid we use in these patients.
But generally we say that we have to give.
Yeah, it will take some more time. Definitely, people do use steroid, that is known, but we have not used steroid in these patients.
But anything that just I wonder what duration or what dose, anything as such, because I
of steroid.
Yeah.
That is 1 milligram per kg of isolone for few weeks actually. Maybe you have to keep monitoring and plan accordingly.
Because that's in my case, I gave denosumab and I waited. Then after 15 days, again the hypercalcemia came back.
Yeah,
Then
so continue, and on that itself you can measure the calcium, how they are behaving.
After that I gave steroids.
Yeah, because using steroid is another problem, because already even vitamin D toxicity per se do the lot of bone resorption actually. And on the top of you give the steroid, that will also cause a problem. So we just not given the this steroid to these patients, and they are good. We are following closely all these patients from the community. Yeah.
Thank you, sir.
Dr. Badada, at PGI, are you routinely doing intra-op PTH? At our center, we are doing intra-op PTH in all patients. And probably this could prevent those complications which were there in your patients, failure of surgery.
Well, so first that patient was operated 3 times, not in our clinic. It was the outside hospital. That is one. The second is that if you have the facility of intraoperative PTH, it is good one. You can follow that. But we don't practice this in each and every patient. Where we have some doubt is there, because the surgeons sending the parathyroid tissue for the frozen section. If they are finding it is not, then they wait for that. If that is there, the tissue is there, they don't send the PTH. So not in routine, but as and when required, we do the intraoperative PTH, and sometimes we do the intraoperative imaging also. Patient is given the dye, and they bring the gamma camera itself in the OT, and they does that also. So
these days, there is another device, I don't remember the name, fluorescent, it localizes the PTH during surgery.
Yeah.
Parathyroid glands are localized and visualized.
Yeah, because that facility is used for the metastasis patient. A lot of breast malignancy patients are there. They do use to remove as much as possible. So they are using some, actually I don't recall that, but they are using, in primary hypertension, sometimes we do. Yeah. Yes, Dr. Deep. Yeah.
With regards to, we have had several cases of presenting with severe hypercalcemia, malignancy first time detected, probably even sources sometimes not identified. But with regards to PTH, RP related, because previously it was done sometimes, but now we don't get to do PTH, RP anywhere in the labs. So very difficult to establish the diagnosis in those patients.
Yeah,
any comments?
Because PTH, RP is routinely not done, and it is, I think, outside is very costly. So it is difficult. We are also not doing. And so in that case, you can treat hypercalcemia. That's try to find out the etiology and treat accordingly.
Sir, any level of PTH that rules out FHH? In other words, what is the highest level of PTH you have seen in patients of FHH?
Less than 200, if you say it is less, usually 80 to 100, 120, something like that. But if it's combined with the vitamin D deficiency initially, it may be up to 200, but not more than that. Sir.
How specific is rise in ACE in sarcoidosis, and have you come across rise of ACE in lymphomas as well?
Yeah, so ACE is not very reliable, so it is not very good. It is really not very good to diagnose the sarcoidosis. If it is positive, it's fine, but on that basis, we generally don't take any decision that ACE is
How, you come across rise in ACE in lymphomas? Why I'm asking is, recently I had a patient in whom this ACE was done. It was high. The differential diagnosis clinically was sarcoidosis versus lymphoma, NHL. And it was difficult to assess for biopsy.
So I had to check the lymphoma S level is increased or not. But yes, sarcoidosis is increased, but generally is not very supportive for the diagnosis or the treatment. Yeah.
Thank you.
Yeah, thank you, sir.
Sir,
Sir,
at
last
what?
question.
Sir, at
Sir,
what?
you have raised the You have raised the issue of romosozumab. Just I have a small question. Sir, as because it has got a high possibility of cardiovascular disease, how you visualize or you take it in the backdrop of diabetes mellitus?
Yeah, so that initial trial, there was a increased cardiovascular mortality with romosozumab, but then the lot of phase 4 trials are there, and there is no increased cardiovascular mortality. And in our clinical practice, what we do is that we take little more precaution before prescribing romosozumab. We get their carotid artery Doppler, each and every patient, and their 2D echo. At least baseline should not be any problem related to that. So we are taking this some extra precaution, but we don't know what is going to happen. But maybe extra dose may be harmful. At least that may be one of the possibility. Yes, sir. Maybe last we have for.
Sir, at what creatinine cutoffs would you judge calcium creatinine ratio? In CKD patients, at that time it is very tough to understand the...
So ideally, if GEGFR is more than 60, it's fine, you can do the calcium creatinine ratio. If it is less than that, then sometimes it is difficult to interpret.
That's what I...
Yeah.
In the presence of renal stones, the urine calcium excretion ratio, should it be reliable, or how? A person presenting with acute pain to us...
I think in renal stone disease should not be a problem until a patient is having the elevated creatinine. In presence of renal stone disease, it should not be a problem, because that is the why the patient is having renal stone is because of maybe hypercalciuria. Yeah. So thank you very much everyone for this active participation. Thank you very much. Thank you, Jay. Wonderful presentation. Thank you.
Thank you.
Thank you, sir, for this wonderful session. Next, we'll be having our next Meet the Professor session. For that, I would like to call upon stage Professor Dr. Tushar Vangas, sir. Along with him, Dr. Divya Ragate. We will be discussing a case of tumor-induced osteomalacia.
So thank you very much. And at the outset, I would like to thank the Endocrine Society 2025 ESICON team for this opportunity to speak on a topic which is quite close to our heart, tumor-induced osteomalacia. So it's based on the experience of managing patients at St. GS Medical College and KEM Hospital that we are trying to showcase our experience of managing these cases. So what we have tried to do is to put together 3 cases with some learning message at the end of the day to see how do you diagnose them, how do you manage them, and how do you differentiate between those FGF23 dependent causes and independent causes. So to do that, we have a case to start with, and then we'll have some relevant literature around that case, which we would be showing to you. So Divya, who is an assistant professor, I would ask her to start it.
Good evening, everyone. Thank you so much, sir, for this opportunity. So I'll be discussing 3 case capsules pertinent to the topic of tumor-induced osteomalacia, and the discussion will follow. So starting off with the first case capsule, here we have a 34-year-old lady who is symptomatic since 4 years with complaints of pain in the right hip joint. She had multiple doctor consultations, treated with analgesics, vitamin D, however, the pain persisted. There was progressive difficulty in ambulation. There was pain in the left hip joint, which then progressed to generalized body aches and weakness, for which she was completely bedridden for the last 2 years. There was no history of fracture or renal calculi in the past, and the family history was non-contributory. So with this complaint, she was admitted in the orthopedics ward at our hospital in KEM, Mumbai. X-ray was done, which was suggestive of some hypodensities in the head of the femur with a preserved joint space, and the contour of the head was maintained. An MRI pelvis was done, which was suggestive of bilateral hip AVN. So she was posted for bilateral hip replacement. Pre-anesthesia workup noted there was some deranged calcium profile. So this is when the endocrine consult was sought. So here in the investigations, we can see that the patient was having persistent hypophosphatemia, lowest phosphorus being 0.6 mg per deciliter, despite multiple courses of vitamin D. Calcium levels were normal, ALP was elevated. Initially, PTH was elevated to the tune of 284 picogram per ml, which decreased to 58 after replenishment of the vitamin D. 25 hydroxyvitamin D levels were 38 nanogram per ml. TMP upon GFR was low for her age. There was no evidence of metabolic acidosis. Spot urinary calcium creatinine ratio was 0.1. On the X-rays here we can see there's evidence of osteomalacia in the form of pseudofractures in the pubic rami, in the ischium, in the humerus and in the ulna. A C-terminal FGF23 assay was ordered, which came out as 8,898 relative units per ml. The upper limit of normal is less than 150. So with this, this was suggestive of an FGF23 dependent hypophosphatemia. On a thorough head-to-toe examination of the patient, we did notice a gum swelling in the just above her incisors. So a gallium Dotonox scan was ordered in this patient, which revealed a 1.5 to 2 centimeter lesion in the right maxilla with an SUV max of 12.4, and there was an anatomical correlate on the CT-PNS. So the diagnosis was modified as tumor-induced osteomalacia due to right maxillary tumor. So the patient underwent right maxillectomy with split thickness skin graft, and the histopath was consistent with phosphaturic mesenchymal tumor, non-ossifying fibroma type. And post-operatively, 6 months, the patient was ambulatory and the serum phosphorus had normalized to 4 milligram per deciliter. So the learning points from this case, tumor-induced osteomalacia is a rare cause of FGF23-dependent acquired hypophosphatemia. Due to misdiagnosis or lack of awareness, there's a long latency period prior to the diagnosis, as was in our case. It is most commonly caused by small benign tumors, PMTs, phosphaturic mesenchymal tumors. The most common site of these tumors is lower limb extremities, followed by head and neck region. Wide surgical excision is the definitive treatment for these tumors. If there's any question pertinent to the case?
Any questions or any suggestion in any other management or any other thing, if it is there, or I can go ahead with the theory discussion part of it.
What about that AVN?
What was the
AVN, bilateral AVN.
I didn't get the question.
In the MRI, it was written as bilateral AVN.
Yeah. So it's a part of osteomalacia which was being seen as that, and after that you can see the patient is walking with a bit of deformed walking, but she's doing quite well. So over a period of years, she's really good and she's improving quite well now.
Also, the transient osteoporosis hip has a very much radiological presentation similar to that of AVN, transient osteoporosis of hip. So as a component of osteomalacia, it was TOH.
Fine. So when we talk of TIO, so we've seen this case. It's an adult who has come with chronic hypophosphatemia, and it's due to FGF23 excess, which is coming due to a benign tumor which was localized, and after surgery, patient has become completely all right. So we've seen an FGF23 excess which is doing that, but when you look at phosphate homeostasis, there are multiple players in it. One is PTH and one is vitamin D, and they act together in concert with each other, and how it improves or maintains the phosphorus level is what we have to discuss. So to know that, we should know what is the normal physiology as well as pathophysiology when we are looking at the phosphorus axis or regulation of phosphate homeostasis in our body. So it's basically a complex interplay of intestinal system, the bone system, and the kidney network which works on that. And here when you look at phosphorus, so we know about the inorganic phosphate, though the majority of the work or the maximum work is in bone mineralization, maintaining the skeletal system, but we know that it is required for basic cell processes, cell membrane composition, the cell-to-cell signaling, as well as energy metabolism, ATP formation, and so on and so forth, acid and base balance. And this is required so they are manifested with acute hypophosphatemias. With chronic hypophosphatemias, these things are compensated, and you will look only at mineralization or musculoskeletal health is a message which goes there. So phosphate is maximally concentrated around 85% in bone. In intracellularly, it is around 15%, and extracellularly is only less than 1%, which is 2.5 to 4.5 milligram per deciliter is what level is maintained. Because of this complex interplay of vitamin D, PTH, and FGF23 as an axis. So the absorption which comes through is through GIT, which is NaPi2b receptors, which occurs passively in 70% of the absorption, and this through NaPi2b, which is acted on by vitamin D, is 30% of active absorption, which occurs through GIT. But the major regulation is through kidneys, through NaPi2a and NaPi2c receptors, which is managed by PTH and FGF23, which downregulates this axis, and that's how it maintains. But if you look at the renal reabsorption, the filtration reabsorption, based on the serum phosphorus, kidney can adjust to the renal reabsorption from 0% to 100%. And that's the reason why kidney is the most important place where phosphorus management or phosphorus levels are maintained, and it's the most important center there. With increased PTH and FGF23, there will be downregulation of these receptors, and that's how you get hypophosphatemia. And when you talk about vitamin D deficiency, you will have less absorption, but it works indirectly, causing secondary hyperparathyroidism, and ultimately it works through the kidneys. So the most important part, the practical aspects when you look at these things, is that we need to replace vitamin D deficiency earlier as a first step, so as to cover whenever you are trying to evaluate any patients with chronic hypophosphatemia, because it's going to interfere with your assessment whether it's coming through a kidney or somewhere else. So that goes as a dictum, replace. By the time patient comes to us to endocrinologists, they would have received so many injections of vitamin D, but still you have to make sure that vitamin D is replaced, and then you evaluate for hypophosphatemia. So when you look at these complex hormonal interactions, you see the PTH activates both vitamin D3 and FG23. FG23 will inhibit both PTH and 125. So 125 has a dual role where it inhibits PTH, but it activates FG23. So knowing this complex interplay is really important, not only to diagnose various disorders, but also when you're trying to treat the patients, to look at the safety and efficacy of this management. So when you treat or when you diagnose patients with hypophosphatemia, they can present across the lifespan and has varied etiologies, right from genetic to a neoplastic disorder. So mind you, if you, simple way to look at it, if you come at a younger age, family history, then it's a genetic cause, but as you go older, it's going to be an acquired cause, but these things may not be true. All these patients which have been depicted here have a genetic form of rickets. So you have to know your physiology, pathology, and genetic diagnosis also to not miss cases with hypophosphatemia is a message which goes there. So essentially, for a practicing endocrinologist, there are only two ways to look at it. It's either FGF23 dependent or FGF23 independent causes of hypophosphatemia which you're looking at. So the third major player of vitamin D and parathyroid will have a calcium component which is affected there. So in vitamin D deficiency, you have secondary hyperparathyroidism where calcium will be low. In primary hyperparathyroidism, calcium will be high. So that disorder can be easily managed by an endocrinologist. But apart from that, when you look at only chronic hypophosphatemia, it's either FGF23 dependent or FGF23 independent is what we have to make out. And so once you are very clear with it, then you can go and discuss it or dissect it further to look at how do we pick patients with FGF23 dependent ones versus that of independent ones. How do you clinically look at, how do you biochemically look at, and how do you investigate it further? So which FGF23 disorders, dependent ones, they're either genetics or there could be acquired causes of tumor-induced osteomalacia. Rarely you can have iron infusions which can cause increased FGF23, and there are other somatic genetic mutations which we need to know about. So we first concentrate on FGF23 since we are talking about TIO. How do you evaluate or involvement of family members or drugs which can cause like iron deficiency, iron replacement, or drugs which causes nephrotoxicity and all. But by the time when the patient reaches to us, you may not be able to differentiate and you will have to take one step ahead. So you can do a clinical examination in FGF23 dependent rickets where you have to examine from head to the toe to not miss any of these lesions. I've shown you some of the lesions which are picked up by clinical examination, like that of the soft tissue in the upper alveolus, in the foot, third or fourth toe, you can see there is a soft tissue lesion. In the thigh, there is one lesion, right upper maxilla, there is a lesion, which suggests that this could be that sole single tumor which is producing FGF23. In the other cartoon, you can see this lady who has got a cafe au lait on his face, and there is irregularity of the face, which is suggestive that it's macunal, right? So these are skin lesions with a dysplastic bone which secretes FGF23. So looking at a clinical picture, you will pick up a FGF23 dependent rickets like that, then the management is different. Patient with neurofibromatosis will have similar clinical examination features. And there is a epidermal nevus syndrome which is seen there at the extreme right corner, where there's a nevus which is going from the base of the scrotum to the middle part of the thigh. There is a nevus in the girl's face. So they have, along with skin, they have some dysplastic bone which secretes FGF23. So looking at this clinical evaluation, which will help you to pick up patients with FGF23 dependent hypophosphatemia. Biochemistry, we all know of phosphorus levels are age dependent. As your age increases, till it keeps on going down. In adult age group is 2.5 to 4.5, and our TIO patients are mostly coming in adulthood range, but there are some mix and matches and surprises which we'll show you when we are showing there. So the fasting morning sample has to be collected for phosphorus, and if you divide hypophosphatemia into mild, moderate, and severe, TIOs are the patients who will have moderate to severe hypophosphatemia, and hence they will come with muscle weakness and they will be crippled and bedridden. But if you look at XLH, they will have a milder hypophosphatemia. They don't come with muscle weakness. They come with deformities and they are able to walk around. So this clinical picture you need to be aware about when you're looking at any hypophosphatemia cases. Definitely renal phosphate loss has to be looked for by looking at the percentage tubular reabsorption of phosphate. And from there you can get a DMP upon GFR by either an omogram or through an online calculator to confirm the renal phosphate loss. The important point here is when you decide to look for FGF23, and mind you, this is a very important slide where I would want your attention, that if dividing patient into FGF23 dependent versus independence, you have an assay for FGF23. But it may not be available to everyone, and it takes around 7 to 8 days to come. It's quite costly. You can do some tests which are available in a routine endocrine department or a routine lab, which tells you whether it's FGF23 dependent or not, and that's what we usually use it. So you have to go back and look at the mechanism of FGF23. It inhibits 125 hydroxylase, and that's why 125 is low. That's why PTH goes up, and there is less calcium in the urine. As against FGF23 independent ones, there is no repression of 1-alpha hydroxylase, and 125 is high, which suppresses PTH and causes hypercalciuria. So if you use only two indices of having PTH and spot urine calcium by creatinine, in FGF23 independent ones, PTH will be suppressed and there will be hypercalciuria, and you have made a diagnosis of FGF23 independent rickets, and you don't need any fancy assays or anything else, and you can very clearly rule out or rule in tumor-induced osteomalacia, as against TIO, where there is mild suppression, so PTH will be slightly high and the calcium in the urine will not be there. And that's the bedside test which you can do to pick these patients, and maybe you can start instituting your scans and other things when you're looking at these patients. But nevertheless, we at Mumbai, we have had fortune of getting C-terminal FGF23 for last 15 years or so. We have been using it, and lately now for last 1 year, we are using intact FGF23. There have been issues with C-terminal FGF23 where they have not given a cutoff to differentiate between FGF23 dependence versus independence, and there is a gray overlap region there. But there is a study which shows that if you keep a cutoff of 90, then you are able to differentiate FGF23 independent versus that of TIO. But so this was a fallacy of that, which you have to take with a pinch of salt. But with intact, you can clearly differentiate between FGF23 dependence versus independence with a cutoff of 27 and 30, which is the importance of looking at intact FGF23. So we have seen the fallacies of C-terminal FGF23 in FGF23 independent rickets of Fanconi-Bickel and HHRH. We have shown that C-terminal can be grossly abnormally high, which is falsely positive in these cases. It could be because of chronic liver disease, which is glycogen storage disease with Fanconi-Bickel syndrome, or there was associated fibrosis, liver involvement in this HHRH syndrome. Iron deficiency anemia can also falsely increase your C-terminal peptide. So we've looked at clinical evaluation, we looked at biochemistry. So once we confirm that it's FGF23 dependence is there, you have to image the patient, and that's where we use FDG PET and dotatate scan, which is the #1 scan to look at. And these are the functional scan findings of these patients where we have shown the clinical pictures. You can see the uptake in that particular region when you do dotatate PET CT to pick up these patients with TIO. We have clearly shown as a comparison between FDG PET and gallium dotatate PET CT, where we've shown FDG, we used to use it till from 2007 to 2012. That time DOTA was not available. After 2012, we've got DOTA, which is available. So 50% of the patient we used to pick up with FDG PET, but with SRS scan, we started picking up patients in most of them. So earlier we had SPECT CT, then we had PET CT. So the PET CT would have a better resolution, and that's what I will try to show you one or two cases. How do you differentiate between these two? So this patient who had FDG PET, which is negative, you can see the SPECT is showing very faint lesion, but gallium dotatate shows a very clear uptake there, showing that if you use this gallium dotatate PET CT, the spatial resolution and the image is so good that you will never be able to miss it. Second case, FDG PET is not showing any lesion. SPECT CT is showing a bit of faint lesion, but you're not sure whether it's there or not. But if you see a dotatate, you can see it's very clearly visible. So dotatate is quite another one in the foot, which has been missed by the two modalities, and you can see that it is very clearly seen. But all is not good with gallium dotatate. It is a function of the size of the tumor that this functional imagings will pick up the tumors. If it's less than 1 centimeters, none of the functional scan will pick it up. It has to be going above a particular lesion. So this was a patient who was 50-year-old male who had osteomalacia symptoms with 3 years with typical biochemistry and radiology. You can see we did a dotatate in 2013, but it was not localized at all. So we treated the patient with medical therapy, then we came back again after 2 years, we evaluated again. There was no such lesion. There was a small lesion in the spleen, but in front of spleen, we thought it could be spleninculi. And again, the patient was put on medical therapy, came back 3 years later, and you could see that the lesion increased to 2 centimeters. And then now it is picking up the uptake, suggesting that when you do a functional scan, it is a size-dependent phenomenon. You may have to image for 3 or 4 or 5 years to pick up the tumor, and once you pick that tumor up, you subject the patient to surgery and patient goes into remission. So you have to be patient with this patient, this conditions, and treat the patient medically to reach to a diagnosis. TIO localization, whole body dotatate PET CT, there are some issues which as clinicians which we should know, that the scan should be performed extending from head to toe, including the hands and feet, to avoid missing small tumors in the distal extremities. As was missed in this patient, it was false negative SRS because we did not include distal extremities in that. And then we asked for a repeat scan. You could see that the lesion was there in the 4th proximal interphalangeal joint of the right foot. So picking in your hands and your feet, you should have a complete DEXA scan. Other important part of dotatate is to, as a theranostic potential, because some tumors can be recurrent, they can be persistent. You can't surgically remove them completely, and they may have to be treated with PRRT or other therapies, or in metastatic TIO, you can use this. The treatment modality is only definitive curative tumor treatment is complete surgical resection of tumor with wide margins. Now these tumors are not encapsulated, and they may infiltrate it into the soft tissues and along bony trabecula, making the wide excision imperative. And that's how we need to be aware that we need to have a wide excision of these tumors to be cured. Post-op, intact FG23 levels will come down within, the half-life is around 1 hour, but phosphate takes around 4 to 5 days for it to normalize, and patient takes around a few weeks to a month to improve clinically. So we have experience of managing 33 such patients of TIO, of which 24 have undergone surgery, and we have a follow-up of 4 to 10 years. And here, though they improve within a few weeks to a month, but few of the patients who have big tumors have required phosphorus supplementation for 3 to 4 months to improve, and so you have to be patient and not give up the treatment when you're treating such patients. Patients with head and neck TIO are the one who can persist, and this is what we've shown because of the anatomical location. You can't do a complete evacuation or removal of the tumor, and they are the patients who require prolonged therapy or medical therapy in these cases. So we put together a data of head and neck TIO because of this special kind of consideration, where it has very clearly shown in 163 patients worldwide literature that they have maximum tumor in location in paranasal sinuses. Along with hypophosphatemic symptoms, they come with local mass effect, come with epic success, nasal obstruction, and epistaxis which is there, and when you remove the tumors, 30 to 40% of the patients can be persistent or recurrent in this. So one of the patients which we tried to treat in such area where one surgery was not enough and second surgery, even after doing second surgery, the uptake was there. So the patient was treated with PRRT based on the uptake on dotatate and confirming that such tumors is difficult to remove and we need to keep on doing multimodality therapy in this case. So this was in short about TIO and head and face neck TIO, which we have tried to showcase as a case of TIO. Let's go to the next case. Any questions? Fine.
Going ahead with the second case capsule. So here we have a 33-year-old male accountant. He complained of lower backache, bilateral lower limb bony pains for the last 1 to 1.5 years. He consulted multiple orthopedic surgeons. MRI hip was suggestive of bilateral hip arthritis, bilateral sacroiliitis, and enthesitis. Also, there was a pseudo-fracture in the left neck of femur. HLA B27 was ordered, which came out negative. There was temporary and partial relief with analgesics. So the patient was suspected to have ankylosing spondylitis, and he was referred to a rheumatologist. He consulted 4 different rheumatologists for ankylosing spondylitis. He received multiple disease-modifying biologicals varying from adalimumab, infliximab, etanercept, and secukinumab, unfortunately with no response. So the pain worsened such that he was not able to walk on his own and he required a walker. He again consulted another orthopedic surgeon. X-ray lumbar spine was suggestive of a facetal arthropathy at L5-S1 with minimal retrolisthesis at L4-L5. He was then advised a bone scan. So bone scan suggested of increased tracer uptake in bilateral feet, hip joints, knee joints, and bilateral sacroiliac joint, suggestive of an inflammatory etiology. So this is when he consulted another rheumatologist. He was put on methotrexate and prednisolone. However, he didn't have any response yet again. So then he was referred to an endocrinologist, and that is when a calcium profile was done. And this revealed a hypophosphatemia. Phosphorus was 0.7 milligram per deciliter. PTH was 146 with an elevated ALP. There were renal function test was normal. Vitamin D stores were adequate. There was renal loss of phosphate documented with this TMP-GFR. There was hypocalciuria. The 24-hour urinary calcium was just 75 milligram in 24-hour sample. The patient did have history of a renal calculi, so he underwent a technetium 99 system EB scan. This was reported as 5 into 6 into 1.5 mm soft tissue lesion in the left tracheoesophageal groove, suggestive of LSPA. With this background of renal calculi in the past, he was suspected to have primary hyperparathyroidism. Mind you, the calcium was 9.6 mg per deciliter. So this patient underwent left superior parathyroid adenoma excision at another center. HPR came out as parathyroid tissue. The weight of the tissue was as meager as 50 mg. Post-operatively, the patient had persistent symptoms, and this is when he was referred to our institute. So when the calcium profile was repeated, calcium was normal. Phosphate was persistently low to the tune of 1.2 milligram per deciliter. PTH was elevated, 360 picogram per ml with normal serum creatinine. So given the persistent low serum phosphate with normocalcemia, so we thought whether it could be tumor-induced osteomalacia, and the patient was affording for intact levels of FGF23 levels, and which came out as 1041 picogram per ml. So a dotatate PET CT was ordered, which was suggestive of an uptake in the left greater trochanter region with an SUV max of 18.72, and there was an anatomical correlate on the MRI pelvis. So the diagnosis was modified as tumor-induced osteomalacia due to greater trochanteric lesion. So we discussed this case with the orthopedics team at KEM. Since the lesion was in close proximity to the joint space, wide excision would not have been possible, so the patient was subjected to non-surgical ablation of the lesion. Prior to the ablation, the biopsy was done, which was consistent with spindle cell tumor with resemblance to phosphaturic mesenchymal tumor. This patient underwent cryoablation. So here we can see post-procedure, 7 days post-procedure, the intact levels of FGF23 fell from 1000 to 15 picogram per ml, and phosphorus levels normalized over time, and by 30 days, the patient had completely normal serum phosphate. His symptoms were completely resolved, and we repeated a dotatate scan, which did not show any avidity. So from this case, we learned that TIO is caused by small tumors in the bone or soft tissue. Tumor location is an important factor in deciding the treatment modality. So when the tumor is present in unfavorable surgical sites, like in this case, non-invasive modalities like radiofrequency ablation or cryotherapy can be done. And long-term follow-up results with these non-surgical ablative procedures, they look promising.
Any questions again on this case or any suggestions?
So just one question, that why despite a PTH of 300, the 24-hour urinary calcium was just 75 milligram?
You're too fast. Can you be a bit louder?
So despite a PTH of 300 plus,
yes,
why the 24-hour urinary calcium was 75 milligram?
So there could be a component of vitamin D deficiency because there's a time duration difference between the first evaluation and the follow-up. Because the patient was not from Mumbai, he was from Pune and used to come once in a month and was being treated. We think there was associated vitamin D deficiency over there, though the earlier vitamin D level was quite normal.
And another thing is, sir, in the bone scan that was done, I mean, the images were not there, but the descriptive report shows that the uptake was predominantly peri-articular.
Peri-articular,
around the hips, around the knee, and how then this is, but in a given case of osteomalacia, we expect the uptake to be more diffuse, both the upper limbs as well as the lower limbs, sometimes the ribs as well.
Yeah.
The second thing is that on MRI, how do we go about explaining the sacroiliitis that was reported along with enthesitis?
Sure. So I think, so we don't have any clear-cut answer for that, but it could be secondary changes to osteomalacia, prolonged immobilization, because he was a young fellow. Over years, he has taken 50, 60 consultations from different doctors, being treated by rheumatologists on 3 different levels. So we think it could be secondary to all the myopathies and osteomalacia-related component, and post-surgical removal or post-ablation with normalization of VJ23, she was completely all right. And he's able to mobilize and he's completely mobile now. So
okay, thank you.
Sure.
In our experience, what have you seen that those patients comes with bone scan, typically rachitic rosary and tie sign, so-called, that is increased uptake in these areas are much more common, unlike the sacroiliac joint and others. So it's around sternum and along the costochondral junction. That is the most common feature that we have seen. That's number one.
Okay.
And number two, regarding the this PTH, is it due to low calcitriol only? So it's a balance between...
regarding what?
The IPTH was so high.
IPTH.
So despite normal vitamin D. So was it due to low calcitriol only or something else? Is
So
also
that's what I tried to showcase earlier, is that with FJ23 suppressing 1-alpha hydroxylase enzyme and reducing the conversion of formation of activated vitamin D3, we've seen PTH more than 65 to 100 approximately, and around 150. But you could have some aberration, maybe one out of the league. Definitely it's not less. It's high. So maybe added vitamin D deficiency or something else could be adding on to that picture.
Right. Thank you.
So,
excuse me. Hello.
Yeah.
So, one point, one comment maybe. During evaluation of TIO, when we are searching for a lesion, sometimes there are pseudo fracture too. So during bone scan, maybe not bone scan, but DOTA PET scan, sometimes uptake could be seen in the pseudo fracture region.
Yes.
And whenever we are asking for a second opinion from orthopedician for surgery, orthopedicians are actually not convinced that whether we should go for surgery or not.
That's right.
And then in that case, they, as per their statement, you can give some treatment, at least phosphate, for a few months, then you can check again. So we got a patient where the patient is absolutely complaining of proximal muscle weakness or severe hypophosphatemia, and we found a, up to DOTA PET scan, there is a tibial uptake. But simultaneously, the X-ray showed that in that location there was a pseudo fracture. So surgeons are not convinced. So we wait for 6 months. Again, we go for repeat DOTA PET scan, and we saw that they are in similar in the similar zone there is uptake. So at that time they are convinced that probably if it is due to the fracture, it should not have been there.
Yes.
Because patient is taking phosphate and the phosphate level is fine, patient is clinically fit.
Yeah.
So this is one point that sometimes it may be, we can misdiagnose the location because pseudo-fracture and the lesion may coincide.
That's right.
Second point is the TIO, sacroiliitis is actually described in case of TIO. Usually there is no erosion. In case of ankylosing spondylitis, usually you will see erosion in the sacroiliac joint.
Okay.
But in case of TIO, usually you do not see any kind of erosion in that place. But TIO with sacroiliitis is an entity and it is commonly misdiagnosed as case of ankylosing spondylitis.
Sure. So to answer your first comment, which is perfectly right, and I think whenever you have any lesion which is positive on a functional scan, before doing any surgical or ablative therapy, we need to be sure to confirm it by an anatomical scan.
Yeah.
If it's a soft tissue, we have to do an MRI. If it's in the bone, we have to do a CT scan. And so every functional scan has been confirmed by an anatomical scan, without which the surgeons don't operate or do any surgery. So other point is that if you get a fracture at a site of that particular lesion, which one of the patient I will try to show there, so you may have a uptake as well as soft tissue lesion because of the fracture there, and that has to be picked up by an MRI, which gives you that soft tissue component very easily. Second point is very well taken. That was a good suggestion.
Thank you.
Sir, suppose, so this is a patient where enthesopathy may be there. So we know that enthesopathy may be common in X-linked hypophosphatemia rickets as well. So what are the clinical pointers apart from family history that will guide us that to look for TIO in this patient instead of going for genetic screening for this patient?
So I think short of genetics, nobody can really pinpoint and say at a given point of time. If you have a long-term follow-up, if you have a family history, you get other clinical features of XLH, which are, I'm sure everybody knows about that, then this may be corroborative to it. And I've shown you a TIO patient where 5 years you're searching for the tumor, you didn't get a tumor. You can call that as autosomal dominant of hypophosphatemia rickets or osteomalacia, which comes at an elderly age group. So short of genetics, nobody can give you an answer. It's a long-term follow-up which you can say that the patient belongs to this particular entity or not. So here, this case taught us about using a non-surgical ablative measure because that's the best way to manage any tumors or which are TIOs, because medical therapy is not going to be a curative part and it's going to be a lifelong affair and it will have its own complications. So people have used various non-surgical ablative therapies like cryoablations and radiofrequency ablation. Radiofrequency ablation works on the principle of heat, but there is an issue that when you are burning the tumor with the heat can get dissipated around and that it might be a bit dysregulated. And that's where our vascular intervention radiologist is erring towards cryoablation now, because he feels that you can get an ice crystal formation when you're using it, especially in some bone-related lesions. They use that cryoablation, and hence the last case has been through cryoablation, but we've had major experience with RFA where we have shown when we have used it. So it's performed under GA, and we do a biopsy prior doing RFA because that's the only chance to get the tissue, after which, after ablation, you don't get a histopathological diagnosis. Size of the lesion is an important determinant of cure in RFAs. So we were working on that since 2014. We published our data first experience of radiofrequency ablation in the 3 patients, which every patient had some learning or curve or message which I would try to showcase to you. Ours was the first way to corroborate that. Along with biochemistry and clinical evaluation, we've shown imaging findings to show that the ablation was curative in these cases. So this was the first patient where you can see that there was a lesion in the right femur. We could pick up the uptake on the DOTA scan, and when a needle was inserted and we have burnt it out, the uptake has completely resolved, corroborating with the clinical and biochemical findings. And this was done in a single RFA setting, which takes around half an hour or so. Second patient in the thigh, in the bone, you cannot ablate, you cannot have a 1 centimeter margin, which is, so surgically you cannot treat this patient, and hence we treated with RFA. You can see that the uptake is completely gone. Some patients require multiple sittings, as was seen in this case, where after one sitting, you can see that There was some improvement clinically, some improvement biochemically, but the uptake was present. And hence we had to do a second sitting, and after which the ablation, the patient was completely cured. But there are other learnings from one of the patients which was very difficult to treat. He has a history of TIO for almost 20 years. 1995, he was having these complaints. He came to us at 2004 when I was doing my residency. And he had a fracture in the lower end of femur. You can see that X-ray, it's not that good quality, but you can see that there's a fracture in that lower end of femur, which there are bone grafts sitting inside it. Because we picked up the soft tissue lesion, the FGF23 was very high, and we discussed with orthopedician, and they said that if you want to have an excision of the tumor, then patient would have to undergo above knee amputation, which is very difficult at 25 years of age when he came. So we did a curettage of tumor and bone grafting, post which patient was on medical therapy for 15-20 years. And then we went into secondary hyperparas, tertiary hyperpara. He went into CKD with medical therapy. In 2014, when DOTA scan was available to us, we did a DOTA scan which showed an uptake in the lower end of the femur. We tried to treat him with PRRT, but because of CKD, it was denied. And then we thought we use radiofrequency ablation for this patient. Now, if you see this anatomy here, you can see that lesion with multiple bony spicules, multiple compartment in that soft tissue. And if you have to ablate it, then you have to go to each and every section of it. You can see the uptake there. We did almost 4 sittings of RFA, but when you put a needle inside, it will burn the tumor, but the tumor would go into the crevices because it's got no capsule there, and hence you could not completely ablate the tumor, and you get partial or temporary response in patients where you can RFA was used. So knowing the nuances of RFA is also very important. We've had the highest number of patients who have undergone RFA from a single center, 9 patients where we have follow-up of 5 to 10 years. The data is only for 2 to 3 years where we published it. And out of 9 patients, 7 patients have been completely cured, and 2 patients were persistent. One was that man which I showed you with a bone graft, and the other one was who had a 3.6 centimeter acetabular tumor. She underwent 1 RFA surgery, 2nd RFA, but was not cured. The other patient that was learning, as I was talking about, using different modalities of cryotherapy versus RFA. This was a lady who had a lesion in 1st and 2nd premolar, and we subjected her to single RFA. There was complete clinical and biochemical recovery. There is no SSTR avidity, no contrast enhancement of MRI after 3 months, but there was a local site ulcer, which you can see here at the place of the lesion. It was because of the heat dissipation has burned the tumor, the normal bone around, and she had to undergo surgery for that and ultimately had to have teeth implantation. Suggesting that in head and neck TIO, this also becomes an issue where you're using RFA, and that's why we are things that we can shift over to cryoablation in the patients who have lesions in the bones. So I think with that, this was a learning from the RFA which we have had. If you have any questions, otherwise I go to the next case.
How feasible is RFA for spine lesions, mesenchymal tumors located in and around spines?
Yes, so I think the same issue would crop around as we had in the 3rd patient, because you have such a narrow place and there is so much soft tissue as well as nerves around there, then going and burning it off would be a difficult part. And it is known that these are the patients who they remain persistent as well as they recur if it's at the tumor is at the spinal sites.
Okay, going on with the 3rd case capsule. It's a bit complicated case. The patient was symptomatic since 5 years of age, and this is when he presented to us in 2017 when he was 19-year-old. So he was initially suspected to have X-linked hypophosphatemic rickets. The patient was on oral phosphate and calcitriol supplementation for the past 10 years. The patient was compliant to the medications, and he was treated with the doses of phosphate varying from 50 to 100 mg per kg per day and calcitriol of 0.5 to 1.5 microgram per day. Despite this, the patient had worsening deformities, and he also underwent epiphysiodesis surgery for his bilateral genu valgum. there was no response, such that at 19 years of age, the patient was bedbound and he was not able to bear weight. In the initial biochemistry here, we can see that there was hypophosphatemia with normal calcium and elevated alkaline phosphatase. PTH levels were elevated. In the initial few months of treatment, there was a response as evident by the decline in the alkaline phosphatase levels. However, over the span of 10 years, with this high doses of phosphate and calcitriol, the patient, when he first presented to us, was in frank tertiary hyperpara with elevated calcium, persistent low phosphorus, elevated ALP, and elevated PTH levels. So at this point, here the calcium was 10.8 with phosphorus of 1, elevated PTH. There was hypercalciuria, and ultrasound was suggestive of nephrocalcinosis. So the diagnosis was hypophosphatemic rickets with tertiary hyperparathyroidism. We did a 4D CT. This was suggestive of bilateral parathyroid adenomas. The patient underwent total parathyroidectomy and histopath of which the left superior, and right inferior parathyroids were removed. The histopath was suggestive of hyperplasia. So in the further course, here we can see that post-parathyroidectomy, the PTH levels decreased, alkaline phosphatase levels also decreased, calcium levels normalized, however, phosphorus remained persistently low. The patient was put on oral phosphate supplementation at the rate of 20 mg per kg per day and calcitriol at 0.5 microgram per day. Over the time, the hypophosphatemia was persistent. Alkaline phosphatase was still elevated. To tackle the elevating PTH, he was also given cinacalcet. So after this, the patient had a clinical improvement in the form of decrease in the bone pain and some improvement in the lower limb strength. And there was some radiological healing of the rickets. So on his anatomical scan, this mass was noticed in the thoracic cavity. Initially, it was considered to be an OFC, which was arising from the left rib or the thoracic vertebra. So post-parathyroidectomy, it was decided to have a surveillance for the reduction in the size of this OFC. However, the patient developed dyspnea on exertion and had massive left-sidal pleural effusion. Pleural tap was exudative in nature with negative TB workup. This mass at the posterior end of the 10th rib was suspected as the etiology. A biopsy was done, which was consistent with spindle cell tumor, which was focally positive for SMA. There were no osteoclastic giant cells. This was compatible with phosphaturic mesenchymal tumor. C-terminal FGF23 levels were sky high, reaching 97,739 relative units per ml. So this patient underwent pre-operative angioembolization of this lesion, and this 15 into 15 centimeter chest wall mass was resected. It was arising from the 10th rib posteriorly. HPR was consistent with phosphaturic mesenchymal tumor. Post-operatively, we can see that the C-terminal FGF23 levels fell from 1 lakh to around 810 relative units per ml in the first 1 week. Phosphorus levels remained low even at 5 months of follow-up, with improving trend in the alkaline phosphatase. C-terminal FGF23 further decreased to 535 after 5 months of follow-up. 3 months later, there was significant improvement in the lower limb and low back pain, and the patient was able to bear weight completely on his lower limbs. A dotatate scan was done at this point, and there was an uptake noted at the site of attachment of the 10th rib to the transverse process with an SUV max of 3.4, with an MRI correlate of 2 into 2 centimeter soft tissue residue. So the further plan was RFA for this residue, orthopedic correction for the lower limb deformities in occupational therapy. Unfortunately, the patient succumbed to COVID infection. So the learning points from this case is childhood TIO is very rare, with few case reports reported in the literature. Clinical exome analysis using next generation sequencing should have been done in this case to rule out XLH, keeping in mind the sensitivity of 80 to 90% of NGS for this. It might miss out the deep intronic variant or large deletions, duplications. Conventional medical therapy can be used as a bridge prior to tumor localization. Suspect TIO if it is not improving with adequate medical therapy. Complications of secondary but tertiary hyperparathyroidism and nephrocalcinosis can be avoided by using low doses of phosphate and active vitamin D supplementation with gradual uptitration and close monitoring with serum PTH, spot urinary calcium creatinine ratio, and ultrasound KUB annually.
Any questions on this, or any suggestions or comments? What is the? we use AdFos sachets, which we use now. Yeah. Yeah, so we used to do that till almost 7-8 years back. So we typically used to use that 6.1 gram of disodium phosphate and 1.6 grams of sodium dihydrogen phosphate. You combine that, put 100 ml of water, and 60 ml is equivalent to one gram or something elemental phosphorus. Used to do that as a student. I used to do that. So, but the people used to not, and you used to prepare a solution and keep it, and it's very sour. If you taste it, you will not like to have it. So now the AdFos sachets are very good. They're palatable. Yeah. Yeah. Yes. Yeah. So, but that's not actually approved. It's more of a. It comes in a chemical kind of composition. So AdFos is a one which we are using quite regularly, and people are comfortable with it now. Yeah. Okay. Sure. So here, this was a TIO in a younger age group, and so it's a shock to see that the tumor-induced osteomalacia can come at such a young age of 3 years of age, where we put up our data together. So there are only 28 cases have been reported in the world literature till now, with the youngest child being 0.9 years. So they come with hypophosphatemia with a tumor which is visible, and that's how it used to be picked up. Otherwise, we don't know how many patients may have been missed earlier with this. And the median age of diagnosis is around 11 years, with diagnostic lag time of around 2 years. The most common tumor locations are in extremities, followed by pelvis. And ours is the first case to report a thoracic site. Rest all the diagnostic and management strategies are similar to that of the adults. So what we need to harp upon TIO with conventional medical therapy is that these are few cases or indications where medical therapy can be useful or may have to be used, especially we use it prior to surgical removal of the tumor or ablation with RFA in recurrent persistent TIOs, in inoperable, unlocalized and multifocal TIOs. We would use medical therapy in conjecture with that. So it's similar principles on the basis on X-linked hypophosphatemia, where we have to look for efficacy as well as for the safety. Safety is based on using lowest possible dose of phosphorus so that you don't get into secondary and tertiary hyperpara. Use at least 20 to 30 nanogram per kg per day of activated vitamin D3 to make phosphorus absorb from the GIT and prevent secondary hyperparathyroidism. But we need to be aware that it causes hypercalciuria, nephrolithiasis, and renal stones. And efficacy is based on alkaline phosphatase. Don't try to normalize the phosphorus. You can, if you want to look at phosphorus level, keep it at a lower range of normal. With secondary hyperparathyroidism, you can use cinacalcid. Cinacalcid use has been advocated with PHPT therapy as a medical therapy, but we can use the similar principles so as to suppress the PTH. It acts on by also reducing the FGF23 based action on hypophosphatemia through renal loss, and some amount of phosphorus can be saved with that. And it has its own issues of side effects of GI side effects, and hypocalcemia has to be looked for. The neotherapies, we don't have any experience with this FGF23 receptor antibody levels, but we should know a few words about it. That it's a fully human monoclonal antibodies against FGF23, and it interferes with this action and thus reverses the actions of 125. It is subcutaneous injection to be given once in 4 weeks. It is approved for XLH. It is approved for TIO by US FDA, EMEA, and in Japan. So what has been shown that when you compare data of XLH versus that of TIO, the TIO, the FGF23 levels are not that high, and the severity of hypophosphatemia is not that much. So you will get results within 6 months of therapy, where within 1 month, phosphorus would go up, TMP upon GFR would also go up, and there would be healing of rickets in around 30% of the patients in 6 months' time. But even TIO, the FGF23 is very high. It takes time for the phosphorus to go up. It takes around 3 to 4 months for the phosphorus to go up, and even after 2 years and 3 years of therapy, only 30 to 40% of the fractures and pseudo fractures heal, because you're looking at a mass of FGF23 which is created, which you're trying to block it. We don't know about long-term effect, about it is self-potentiating the tumor growth and all that. People are postulating about this particular aspect of burosumab. New kid on the block is infigratinib, which works on as a oral FGFR 1 to 3 pan FGFR tyrosine kinase inhibitors, which have been used in very few patients, 5 or 6 patients. This NHGM publication, they have used it intermittently for 1.5 to 2 years, where they have shown that FGF23 normalizes within few days. Phosphorus goes up completely. The lesions, metastatic TIO completely normalizes till the time you use it. But once you stop it, it comes back again. You have to stop it, you have to give it intermittently because it causes irreversible side effects of corneal scarring and keratitis, liver dysfunction and neutropenia and so on and so forth. So they are trying to look for a more specific FGFR1 based inhibitors or tyrosine kinase inhibitors, but at present, at best you can use it for a metastatic TIO where life expectancy is not that much, or you can use it intermittently. In this case, it has been used for around 2 to 3 years intermittently where patient has done well. So with this, I would like to conclude about this TIO that it's rare, but it's an important cause. If you pick up the tumor, it's really gratifying for the patient as well as for the doctors. Clinical evaluation, biochemistry can be suggestive. Functional scans followed by anatomical scan to pick up the tumor, and surgical excision or RFA is a treatment of choice. Head and neck TIO requires specialized consideration because of the anatomical location of it. They require special additional treatment modalities. Childhood TIO is challenging. We need to have genetics also on board. So if anybody who is not treated adequately or not responding adequately, then we need to be looking at that. And newer therapies are exciting and need to be vigilant about it. So with this, I would like to thank you and thank you for your patient hearing.
Thank you, sir and madam, for these wonderful insights into these tricky cases. Now we will having our last session, that is quiz prelims. For that, I would like to call upon the quiz master for this session. Anish.
Good evening, everyone. After those excellent Meet the Professor sessions with our professors, we are now going into the next exciting segment for our PDTs, and that would be the EndoPG quiz. It will be hosted by our very own Nagesh sir and yours truly as well. My quizmaster, co-quizmaster is here as well. So PDTs, please gather up in front. Those who have already registered for the quiz, and the details are with me. Apart from that, if you are going to submit your names right now, you can come up to me and submit it as well. And we will be handing out answer sheets to each such team. Please mention your institution name and the members of your team in that answer sheet clearly and legibly, so that we can, there's no confusion once they are tallied for marks. I hand it over to Nagesh sir for the rest of the quiz workflow.
First, can we have the team? Can all the students come here, please?
Hello, check. Hello, check. Kindly mention your names. You are not registered, right? Please spell first name, surname, please. A-A-N-I and right. J. Your institute? Sorry. MMC. Which year? एक टीम को of 3 members each team will receive one such paper. Got it? Yes, please mention your registration number.
Anish, leave the registrations. I'll tell them.
Could someone be
Let them form a team among themselves.
Okay, later we'll then do that.
I'll tell you how to do it.
Hello. Asking all our postdoctoral trainees to please come up front. I think you've already formed teams of 3 amongst yourselves. Inter-institutional teams are allowed, so no issues there. But when you're writing down your names and institutions, please write them clearly in the paper given to you. Have you not found a third member?
Come here. The ones there, come here.
Just wait.
Piyash ko bolo. Piyash ko bolo.
Piyas, are you here? No, tell all our PDTs to come up front.
So all those ardent quizzers who are sitting at the back, if you don't want to get disqualified, please sit in the front. Else, you are in the zone of disqualification. Thank you.
You can all come to the first row. No issues. It's not that the first row is the hot seat anyways. This row is completely vacant. Yes, so we have allowed 2-member teams. You can please make teams of 2 amongst yourselves. If you have 3, then that's fine. You haven't submitted it previously, na? You write it down, your name and institution clearly in that paper which will be submitted. Okay. Fine. That's fine. One of the chairs is vacant, please, both in this row and in that other row. Teams composed of 2 to 3 members may not be of the same institute. So when you're writing down your names and institutes in each sheet, please write them clearly in capital letters.
If you're not from the same institute, write both the institute names.
Yes.
Or all the 3 institute names.
You just sit down, organize yourselves into a team. We will collate the team names later. Who's distributing the answer sheets?
Who has the answer sheets?
Excuse me, RX, please distribute the answer sheets to the other teams here. If you don't have a sheet, teams of 2 or 3, please raise your hands. Excuse me? 6. No. Stragglers there. Stragglers there, sir. Maybe if they could come up front. Just leave one seat beside. Yeah, if there are any teams with 2 members, you require a 3rd member. We are running matchmaking services here for teams now.
23, 24, 25, 26. How many members are there? 2. 1 member? Are you a single member team? There's one person who doesn't have a team there. You can join them if you want to. No, this row, 26, 27. How many people in the team? 2, 28, 29. Here, 30, 31. We already counted you, right? 32, 33. I think we've got 36 teams or 37 teams. So I'll briefly explain the rules to you. You got your answer sheet. Just write down your name, your team name, and 1 WhatsApp number, 1 or 2 WhatsApp numbers by which we can contact you.
अच्छा, okay, वहाँ पे 1 minute का.
You will be getting 40 questions. The questions will be projected on screen. You just write down the answer in that. There will be 15 start questions. In case there's a tie between the team, the start questions will be considered for in case of a tie break. When you're writing your answer, whenever I tell you that this question is start, mark the star beside the number of that question. So that when it is being corrected, it makes it easier for us. The stars are not marked in the answer sheet. You have to mark it in the answer sheet when I tell you which one is a start question. There will be 40 questions. You just have to write option 1, 2, 3 or 4. Once we finish, you have to exchange your sheets and correct it. I'll be reading out the answers. You do the correction. Once the correction is done, you please take back your sheet and check whether there are any mistakes. And once that is done, we'll announce who is going to qualify for the finals. We're planning to have 8 teams for the finals. But since this is on infinite bones, in case there is a very bad tie, we might either go ahead with a tiebreaker, even if the start questions don't work, or we might take in some extra number of teams for the finals.
So no negative marks, sir?
There are no negative marks. You can attempt everything. Shall we go ahead?
I think we can. Are the teams ready? You have 1 minute after the question is there on your screen and sir or me have explained it. After that, we'll go into the next question. So I think we are ready, sir.
Show it here. First one, which of the following incretin-based therapies demonstrated approximately 24% weight loss in phase 2 trials? Option 1, tirzepatide, 2 is retatrutide, 3 is survodutide, and 4 is pemvidutide. Have you finished?
I think 1 minute is too much. I think we can after 10 seconds.
Half a minute should be good enough.
Even 10-15 seconds also, sir, for these questions.
The longer ones will give 1 minute. Second, all of the following are predictors of type 1 diabetes progression except 1 is multiple islet autoantibodies, 2 is HLA DR3 DR4, 3 is low C peptide, 4 is an elevated serum uric acid.
Next question, sir. 30 seconds on the clock, please.
Third, which mutation is the most frequent cause of inherited dysharmonogenesis with permanent congenital hypothyroidism? The first one is TPO, second is JOX2, 3 is SLC5A5, fourth is TG thyroglobulin.
Next question, sir.
This is a start question, so please mark a star before the number of your question. The fourth is a start one. The TIA score predicts autoimmune thyroid disease progression in 1. Patients with Hashimoto's thyroiditis. 2 is relatives of patients with autoimmune thyroid disease. 3 is neonates with thyroid dysfunction. 4 is lithium-induced hypothyroidism.
The question number followed by the option in your answer sheets. Next.
Finished?
Next.
5th, which marker best differentiates central DI from primary polydipsia? 1 is serum sodium. 2 is random urine osmolality greater than 600 milliosmoles per kg. 3rd is a water deprivation test result. 4th is plasma copeptin after hypertonic saline. Just give them some time for this.
We can go to the next question, sir.
6th is again a start-up question. Which outcome of GnRH analog therapy in central precocious puberty remains the least predictable? 1 is adult height gain. 2 is delay in menarche. 3rd is psychosocial benefit. 4th is ovarian cyst prevention.
Next.
Mark a star. This is a start. 6th one is a start one, so mark a star, please. The next one. Which food group did the DGAC propose to list first in protein foods category according to the 2025 report? This is the American Nutrition Group. The first one is meats, second one is eggs, third is seafood, 4 is beans, peas and lentils.
Next question, sir.
8th, which complication is most characteristic of generalized versus partial lipodystrophy? 1 is hypertriglyceridemia, 2 is hepatic steatosis, 3 is cardiomyopathy, 4 is insulin resistance. This actually means something which you would find more in generalized, less in localized, partial lipodystrophy.
But most characteristic.
Of generalized lipodystrophy, which is not very common in partial lipodystrophy.
5 more seconds to the clock. And I think the question can be changed.
9th is again a start question. Which is the most valid criticism of the paleo diet's underlying evolutionary premise? 1, the hunter-gatherers had uniformly high dairy consumption. 2, Paleolithic diets were homogeneous worldwide. 3rd, genetic adaptation to starch and dairy occurred post-agriculture. 4, there is no evidence of plant consumption in ancient diets. Which one of these 4 arguments actually is the single most important criticism of the paleo diet?
We are into so many diets, food fads. It's so important for us endocrinologists to keep a tab on all of that.
Change. Clock. Wait. Let them read this.
Oh, okay. It will take a bit of, but take the correct answer, please.
This is again
Sorry.
a start question, so please mark a star. The next one. In which scenario is surgical resection considered a first-line alternative to dopamine agonist according to the recent guidelines? Young women desiring, this is in prolactinoma, young women desiring future pregnancy. Second is microprolactinoma with normal vision. Third is well-circumscribed micro or macro, that is NOSP 0 or 1 prolactinoma when surgery expertise is available. Fourth is recurrent macroprolactinoma after radiation therapy. Another 10 seconds.
Change, sir.
40 ko aane do. A According to the 2023 guideline on PCOS, AE-PCOS guideline, what is the minimum time post-menarche before menstrual irregularity can be considered diagnostic of PCOS in adolescents? First is 1 year, second is 2 years, third is 3 years, fourth is 5 years. It's fairly straightforward. Twelfth is again a start question. Ezetimibe is the drug of choice in treatment of A-beta lipoproteinemia, hyper-alpha lipoproteinemia, dis-beta lipoproteinemia. D is 4. Don't mark it A, B, C, D. Mark it 1, 2, 3, 4. Fourth is cytosterolemia. Next, this is 12th was a start question, so please mark the star. 13. Which nuclear medicine scan requires dexamethasone suppression before imaging to improve specificity? The first one is 18F FDG PET. Second is NP59 scan. Third one is I-123 MIBG scintigraphy. Fourth is 68 gallium dotatate PET.
Like it's a part of the protocol.
If you can understand why they're asking for a DEXA suppression, then you'll know the answer. Fourteenth, according to recent consensus on sick day rules in adrenal insufficiency, which is correct? First, during febrile illness, adults should triple hydrocortisone dose for 48 hours. In children, double the dose is sufficient. Second, for minor illness without fever, no change in hydrocortisone dosing is required. In gastroenteritis with vomiting, oral hydrocortisone should be increased to 4 to 5 times daily. Fourth, mineralocorticoid dose must always be increased during illness. This refers to fludrocortisone. We'll give them some time for this to read through this. Only one of these 4 is correct. Next question.
Change.
Which statement best reflects the current status of oxytocin replacement therapy? 1. Routine parenteral oxytocin injections are recommended in all patients with pituitary disease. Second, intranasal oxytocin is under investigation for lactation failure, social bonding disorders, and hypothalamic injury, but long-term efficacy remains unproven. Third, oxytocin tablets are widely available and used as standard replacement therapy. Fourth, Endocrine Society guidelines recommend universal oxytocin screening in hypopituitarism. This should be fairly straightforward.
We can change, sir.
Sixteenth is again a start question, so please mark the star. Which of the following is now recognized as the most common cause of hypophysitis in contemporary practice? One is primary autoimmune lymphocytic hypophysitis. Second is granulomatous hypophysitis. Third is IgG4 related hypophysitis. Fourth is immune checkpoint inhibitor induced hypophysitis. Switching over, this is again a start question, so mark a star. 17th, which of the following statements is correct regarding drug-induced adrenal insufficiency? First, etomidate and ketoconazole cause adrenal insufficiency by suppressing ACTH secretion. Opioids, second is opioids, immune checkpoint inhibitors and megestrol acetate have been reported to cause adrenal insufficiency via central suppression. Fluticasone at standard inhaled doses never causes adrenal insufficiency. Rifampicin commonly causes insufficiency by direct adrenal cortex toxicity. Read carefully through this. It becomes very obvious once you read through it. Another 5 seconds to go. 18th. Which of the following is not a part of the FRAC score? One is smoking, two is spine BMD, third is parental hip fracture, fourth is rheumatoid arthritis.
Something which you frequently use in your bone clinics.
Next. Palmar xanthomas are most characteristic of, one is familial dysbeta lipoproteinemia, two is familial hypercholesterolemia, three is ApoC2 deficiency, four is hereditary hypertriglyceridemia.
I think we can change.
20th. Which of the following best reflects current guideline recommendations regarding testicular adrenal rest tumors and fertility in men with CAH? 1. TARTs are rare and do not significantly impact fertility outcomes. 2. Routine screening of testes is recommended in adolescence, adulthood, as early detection and optimized glucocorticoid therapy may reduce TART progression. Testicular biopsy is mandatory in all men with CAH to confirm diagnosis of TARTs. 4. Surgical resection of TARTs is first-line therapy for fertility preservation. Long question, easy answer. Next. The typical oral bioavailability of semaglutide when co-formulated with snack is 1 is 0.1%, 2 is 1%, 3 is 5%, 4 is 10%. Fairly straightforward answer.
I think we've been to umpteen sessions and lectures where we've seen this slide and data point being included.
22. This is again a start question. In grading of Trosser's sign, which grade represents typical carpopedal spasm? The so-called obstetrician's hand, the one you see this way. One is grade 1, grade 2, grade 3 or grade 4. This is a start question, so please mark the star. 23rd, glucose enters the pancreatic beta cell via GLUT1, GLUT2, GLUT4 and SGLT1. When we are asking for a single answer, we want the portal through which the maximum glucose entry occurs. There can be some amount of controversy in this. We want the portal through which the maximum glucose entry occurs.
You can change, sir.
24th, which of the following is a feature of vitamin D dependent rickets type 2? 1. Response to physiological doses of calcitriol. 2 is associated with alopecia. 3 is caused by CYP27B1 mutations. 4th is associated with FEX mutations.
Sometimes the answers may be obvious, sometimes they may not be.
Very obvious answer. Which imaging, 25th, which imaging signs suggest malignant thyroid nodule? ThyroidS 5. Isoechoic pattern, taller than wide shape, peripheral rim calcifications or spongiform appearance. This is again a sixth start question. You must have heard a lot of people talking about Brazil nuts, because our patients want to use everything other than thyroxine for hypothyroidism. Jeera water, Brazil nuts, so many other things. Coriander, everything's been used. This is one of the recent facts. But there is something known as too much of a good thing. Excessive consumption of Brazil nuts may cause selenosis. Which of the following features is not typical of chronic selenium toxicity? 1 is hair and nail brittleness. 2nd is garlic odor in breath. 3rd is peripheral neuropathy. 4th is central diabetes insipidus.
We can change, sir.
This is a start question, so please mark your star. 27th, if you have been reading your Williams properly, you should get this. Which among the following is the correct approximate weight of an adult non-pregnant pituitary gland? A is 200 mg, B is 600 mg, C is 900, D is 1100. Mark the keywords: adult, non-pregnant pituitary gland. '28, which is again a start question. Which diagnostic parameter is not in the current international ISS criteria, idiopathic short stature criteria? Height less than -2 standard deviations below mean for age. Normal GH stimulation test. Third is a normal bone age. 4 is absence of systemic cause. Start question.
We can change.
29th, again a start question. Look at this carefully. All the following genes cause Bartter syndrome except one is bumetanide sensitive NKCC2, 2 is ROMK, C is calcium sensing receptor, and the fourth one is CLCK alpha. Only one gene does not cause Bartter syndrome. Which one is that?
I think we can change, sir.
Finished? 30th again is a start question. This will give them time. Read very carefully. Which of the following statements is true about transgender athletes? A, first one, a maximum testosterone level has been introduced that must be met by individuals born with XX chromosomes. Second, the muscular advantage of transgender women over cisgender women is only minimally reduced after testosterone suppression. Third, estrogen preparations and cyproterone acetate are prohibited substances. Fourth, transgender female athletes eligible to participate as females in their sport require a TUE for GnRH analogs. TUE is like a permission for GnRH analogs before they can be allowed to compete competitively in sports. They can be allowed to participate competitively in sports. This is a bit tricky. Read all through the options.
And it's a start
Wait
question.
for the full minute. This is the start question. 28, 29, 30, all three are start. Once I'm done, I'll just do a brief run through of the 1 to 40 questions and then you can go for the corrections. Once Ani finishes with the next 10 questions.
With that, we go into the 31st question. So according to the recent ATA guidelines, which of the following is the most appropriate management for a toxic autonomous functioning thyroid nodule in a young woman planning pregnancy within 6 months? A1, radioiodine ablation with immediate conception after treatment, long-term low-dose methimazole until delivery, surgical lobectomy of the affected lobe, or ethanol ablation of the nodule as definitive therapy. Again, straightforward if you are aware of the literature. This is a start question. Which of the following statements regarding Addison's disease is the most accurate according to recent guidelines and cohort data? 1. Plasma ACTH is a reliable biomarker for titrating glucocorticoid replacement. 2. Mineralocorticoid replacement is usually unnecessary if the patient receives adequate hydrocortisone. 3. Modified release hydrocortisone improves circadian mimicry and may reduce metabolic complications compared to conventional dosing. Or 4. DHEA replacement is recommended for all women with Addison's disease to improve fatigue and quality of life.
You've got another 10 seconds. This is a start one. 32 was a start question, so please mark.
Low AMH with a high FSH-LH indicates A. Androgen insensitivity or 1, 2, 5-alpha reductase deficiency, 3, gonadal dysgenesis, or 4, 17-beta HSD deficiency. Again, kind of an obvious question. Next, we go into another starred question. According to the 2014 European hyponatremia guidelines, what is the maximum recommended correction rate of serum sodium in SIADH to minimize the risk of osmotic demyelination? Is it 112 millimole in 24 hours and 24 millimole per liter in 48 hours, 10 millimole per liter in 24 hours up to a maximum of 18 millimole per liter in 48 hours? Or is it 10 millimole in 24 hours and 8 millimole per liter thereafter every 24 hours? Or is it 6 millimole per liter in 6 hours irrespective of the baseline sodium? Again, we manage hyponatremia all the time in medicine and thereafter in endocrinology. If you're cognizant of it, you'll be able to answer it. Maybe another 5 seconds. Which of the following statements regarding newer therapies for thyroid eye disease is most accurate? 1. Teprotumumab, monoclonal antibody against TSH receptor, is approved for thyroid eye disease and reduces proptosis by more than 3 mm in most patients. Number 2, rituximab has shown consistent superiority over IV glucocorticoids in RCTs for active, moderate to severe thyroid eye disease. Number 3, teprotumumab targets the IGF-1 receptor pathway and has demonstrated sustained benefit in both proptosis and diplopia in phase 3 trials. Or 4, tocilizumab, which is an IL-6 receptor blocker, is considered first-line therapy in active thyroid eye disease per current UGOGO guidelines. According to the 2024 ISPAT guidelines, what is the recommended HbA1c target for most children and adolescents with type 1 diabetes using modern diabetes technologies? Is it number 1, less than 7.5%? Is it number 2, less than 7%? Is it number 3, less than 6.5%? Or number 4, less than 6%? Again, pretty obvious. If you're aware of the guidelines, you'll be able to answer. This is a start question. Which of the following abnormalities is most strongly associated with non-obstructive azoospermia due to spermatogenic failure? Is it due to number 1, CFTR gene mutations leading to congenital bilateral absence of the vas deferens? Is it number 2, Klinefelter syndrome with small testes and elevated FSH? Is it number 3, AZFC microdeletion on the Y chromosome, which is compatible with natural fertility? Or is it number 4, balanced autosomal translocations that usually present with obstructive azoospermia? Again, recognize what's been asked and please mark your answer accordingly. And it's a start question, of course. Third last question, in ovotesticular DSD, which of the following statements is most accurate according to recent literature? Number 1, the majority of patients have a 46XY karyotype with SRY translocation being the commonest etiology. 46XX karyotype is most common, often with SRY gene translocation or other testis determining gene variants. Gonadal malignancy risk is negligible and long-term surveillance is therefore unnecessary. Or is it number 4, anti-Mullerian hormone is always absent due to ovarian tissue dominance? Penultimate question and start. Which of the following exotic fruits has the highest sugar content per 100 grams, making it less suitable for patients with diabetes if consumed in large amounts? Is it the dragon fruit? Is it the kiwi? Is it the mangosteen? Or is it the avocado? Exotic fruits which you would not recommend. Yeah, and how many of you have eaten any of these, or at least one of these, or two of these? But that's not the question.
Quite common. All 4 would be difficult.
Going into our last question then. Which of the following is a unique advantage of pitavastatin compared to other statins? Is it number 1, highest LDL-C reduction among all statins? Is it number 2, minimal impact on glucose metabolism, making it favorable in patients with diabetes? Is it number 3, exclusively metabolized by CYP3A4, leading to high drug-drug interactions? Or is it number 4, approved only for short-term use of less than 6 months due to risk of hepatotoxicity?
Again, if you know, you know.
This is again a start question.
It's a start question. Okay.
Now I'll just give you a recap of all the questions. This is 1, 2, 3, 4th is a start question. Make sure that the star is marked. 5, 6 is again start. 7, 8, 9 is again start. 10, 11, 12 start. 13, 14, 15, 16 is again start. 17, 18, 19, 20, 'No photographs. Questions might repeat. 21, 22 is start. 23, 24, 25, 26 is again start. 27, 28 is start. 29 again start. 30 is again start. Maybe the most complicated one in the quiz. 31, 32 again start. 33, 34 is again start. 35, 36, 37 is again start. 38, 39, if you've eaten all 4, you will know the answer. 40 is again start.
Should be having a total of 15 start questions in your answer sheet.
No, please exchange your answer sheets.
Now we are requesting each of the teams to exchange your answer sheet with the nearest team. So maybe on, you have a query. Bolo, I'm listening.
And please make sure you haven't got your answer sheet back in exchange.
You missed 2 start questions. They have missed 2 start questions and they have 13.
No, the person who corrects it can mark the star.
They'll mark that star for you.
When they correct it, we'll again mention.
I'm sure you've written answers for that question, right? So maybe I'll ask the teams nearest. So maybe you will change your answer sheet with the team behind you. You will be changing your answer sheet with this team. The row behind you, I think there are 2 teams, so you will be changing your answer sheets. The row behind you, you 2 teams will be changing your answer sheets. You've changed already? Okay. In that case also again 2. Behind you, there is 1 team. So you have changed, excuse me ma'am. Yeah, your sheet, who has it been changed with? Acha, and your team has been changed with? Who's taking what? Okay. Then behind that? Okay.
So have you all exchanged your sheets? Answer sheets are exchanged?
No one mark your own answers, please.
Finished?
Everyone exchanged their answer sheets?
Does anyone have a problem with the answer sheet? Have you all exchanged? Ready to correct? The first one, which is the answer? What is the answer?
Can we have audience mics also?
Retatrutide.
Thank you, sir.
Answer is 2. Second, 4, elevated serum uric acid levels.
Where would uric acid measurement be important? Any free answers? Right, Modi. Which type? Right.
Third, which is the answer? It's 1, TPO is the commonest. Geox is 2,
Second
TPO is
answer?
commonest. Second answer is 4. 1 is 2, 2 is 4, 3 is 1. Fourth, relatives of AITD patients. Somebody who already has an established Hashimoto's thyroiditis, you do the THIA score. What does A in THIA stand for?
Answers?
Amsterdam, because this was where the conference was held. This is a start question, so if somebody has got a star, at the end of the quiz, you just mark down the number of stars they've got correct.
That is?
Answer is
relatives
2.
of AITD patients.
Relatives. Fifth, what is the answer? 4, plasma copeptin after hypertonic saline. Unfortunately, copeptin is not commonly done in the country. There's only 1 or 2 centers. I think our Dr. Gururaj Rao does it in Mangalore. He's the only one, I think, as far as
The
I know.
Cryptor assay, if they're using it.
He's the only one, I think. Sixth, which outcome of GNRH? This is again a start question. What is the answer? Psychosocial benefit. Answer is 3.
Correct.
Seventh, 4. Why? They want plant proteins first. Thankfully for people like me.
Hence the answer is number 4.
8, more common and generalized is 3, cardiomyopathy. 9th, what is the answer? 3. The answer is 3. Because when you had the hunter-gatherer around, you did not have agriculture or dairy. Once they have come in, people have started getting genetic evolutionary changes in their body. They have got epigenetic changes, and you cannot handle a paleo diet.
And hence it's the most valid criticism.
10th, 3.
Correct.
This guideline must have been written by a neurosurgeon. 3rd, it's 2 years, not 3, 2 years.
2.
3 is too long, it's 2. It used to be 1 earlier, now it's 2.
PCOS in adolescents.
Ezetimibe is the drug of choice in cytosterolemia, 4. Approved in 2022. 13. 2. Why do you do it? To suppress the cortex so that the medulla can be visualized better.
But sometimes we also do a kind of, we often give our patients to reduce the cortisol to increase sensitivity on the gallium dotatate scans. But again, that's not part of the protocol.
13 is 2. 14, which is correct? 2. Febrile illness dose is always double, be it adult or a child. You don't have to increase fluorocortisone because anyway you're giving hydrocortisone. Without fever, you don't actually need a change of therapy. 14 is 2. 15. Fairly straightforward, it's 2. It is a field of interest, but we don't have evidence as of such.
I think we will be having a lecture on it in our subsequent SECon.
16. 4. It's now 4. It used to be 1, it's 4 now.
Contemporary practice.
17. What is the answer? 2. First is incorrect because it causes a suppression of the adrenal. 3, fluticasone can cause adrenal suppression. Rifampicin acts by increasing the CYP-A1 pathway. So the answer is 2. Which of the following is not a part? It's spine BMD. It should be straightforward. 18 is 2, 17 is 2, 18 is 2, 19, 1. It's familial dysbeta lipoproteinemia. It's a toss-up between 1 and 4. The answer is 1. 20.
Answer?
2. You don't operate. And what is the treatment of choice? 20 is 2. 21? 1%. It varies between 0.8 to 1.4.
What is SNAC, by the way? Anyone? Permeability enhancer.
22. What is the answer? 3. Grade 3.
Clinics are important.
23. Answer is 2. You got absorption via GLUT1 and GLUT2, but GLUT2 is the maximal one. 23 is 2. 22 is 3. 23 is 2. 24. Fairly straightforward. Alopecia, 2. 25. It's again 2, taller than white shape. 26. What is the answer? 4. 27, 600 mg. And what about a pregnant pituitary gland? 1000 mg, 1 gram. 28, 3, normal bone age. You don't have to have a normal bone age, it will be slightly delayed. This is a start question. 29, 4. What is the right answer? CLCK beta.
It's the beta, not alpha.
This is start. 30. What is the answer? 2. Read carefully. Maximum testosterone level has been introduced that must be met by individuals born with XY chromosomes. You don't have a cutoff for XX. Answer is 2. Estrogen preparations and cyproterone are not prohibited substances in women or somebody who wants to change their sex. Testosterone is prohibited. And female athletes need not use GnRH. For males, they need a TUE if they want to use GnRH. But whatever they might be, the muscular advantage remains even after testosterone suppression, because before they had a testosterone suppression, all through their puberty, they had a good musculature which will not change all through their life. So the answer is 2. 2. 1 is XY. It's mentioned XX here. C is not prohibited. D is they do not require a TUE. Male eligible to participate as males in their sport will require a TUE for GnRH. The second one, you will not require a TUE. The second one is there. Whatever they might be, the muscle advantage remains all through their life. 31. 3. Surgical lobectomy of the affected lobe. 32. 3. Modified release hydrocortisone improves circadian mimicry and may reduce metabolic complications compared to conventional dosing. This is start. 33. 3. Gonadal dysgenesis, because you don't have functioning tissue. Absence of Sertoli cells. 3. 10 millimoles per liter in the first 24 hours and then 8 millimoles thereafter every 24 hours till you reach 130 milliequivalents per liter.
3. The answer is 3.
35. And why not 1? It's not a TSH receptor antibody, it's a IGF-1 receptor antibody. So the answer is 3. 36. 2. 7. Now that you got CGMS, the target remains the same as in somebody who has type 2. 37. 2. Klinefelter is the commonest.
Not 3.
C. Answer is 2. AZFC microdeletion on the Y chromosome, which is compatible with natural fertility. It is not compatible. You need assisted reproduction. The answer is 2. The commonest is Klinefelter. That's why I said read carefully. 38.
Answer?
Answer. 2. It is 46. XX is the most common. 39. Mangosteen. What is the content? 14 grams of sugar per 100 grams. Which has the lowest? Avocado is 0.7. Dragon fruit is around 6. Kiwi is around 8. The last one. 2. Minimal impact on glucose metabolism. Are you done? Huh? 39 is 3, 40 is 2.
Once you've corrected,
Any
please.
doubts? Any queries?
SIADH question, your query is?
So you can take back your sheets and check them once again.
So we said the answer was there, hypertonic saline, plasma copeptin. That one? Sodium correction, the third, it was. So they are asking about the hyponatremia correction one.
3. 10 millimoles per liter in the first 24 hours, then 8 millimoles thereafter every 24 hours. Which one?
Total correction, they are saying over 48 hours, sir.
The correct one is you look at 3. It is thereafter every 24 hours. It doesn't give you a total correction.
Every 24 hours.
No. What I'm trying to tell you is, you are calculating it totally. This guideline says, in the first, option 2 says in the first 48 hours it will give you 18. Option 3 says you have to keep correcting it. Even day 3 it will be 8. It has not mentioned. The complete answer is given only in option 3. Thereafter, every 24 hours. If you look at the guideline, you will make sense of it.
That's why the guideline name has been mentioned as well. I think that's where your confusion is arising.
Any other doubts? So can you exchange sheets?
Have the original sheets been returned to the original owners? Okay, how many have 40 correct answers?
No, just let them check their sheets.
Tally them.
Finished? And have you marked the number of start questions, right?
The total number and
the
then the
start
number
question,
of start questions.
Finished? Still checking.
We hope your friends and colleagues have done a good job at checking. And no changing marks after it's been put. And if they have marked you low, don't hold it against them. Be friends.
Finished?
I think
everybody's done.
Some are still looking through their pages.
When you get your answer sheet back, just check if the corrections are done properly. Check whether the total is correct and whether the start questions are also marked properly. Have you finished?
Is everyone finished with checking their answer scripts?
I'm not getting an affirmative yes. Can I get a yes, please? So I think they have.
Finish. So how many got 40 right? 39? 38? 37? 36? 35? 34? 33? Please come here. Just give me your sheet.
Congratulations. Please come up. Unbiased. No questions were leaked beforehand.
Mixed team. Thankfully.
They are a mixed team, sir.
Thankfully. Who got 32? Can you please come here?
One of you come up. Yeah. Congratulations.
31.
The team from PGI.
31, please come here. Both of you. You also please write down 2 phone numbers. Two numbers. Phone numbers.
2 phone numbers. 2 members.
How many got 30 right?
Please come up. One of you. One member from each team. There were actually, I think a 4th team is still writing. No, wait. Another team was given to write down their phone number. Which team was it?
Who got 33 right? I'm just recapping.
Yeah. That's the paper. Thank you. So we have a team from Osmania as well, sir.
I'm not responsible. I don't go to Osmania very big. How many got 29 right? Now we'll have to use the stars in the tiebreak. Can you please come here? One member.
29.
9 stars.
10 stars. 10 stars. 9 stars.
11 stars.
11 stars. Yes, the
11 stars. We've got 2 teams with 11 stars, 2 teams with 9, and 2 teams with 10. So we'll do one thing. We've got 7 teams, right? We'll take 9 teams for the final. Both the teams with 11 stars will be taking them for the final. Is that fine?
Acceptable to all.
So we finally got, I'm going to read out the team names. Nameless team. They are from UCMS Apollo, Ankitesh Kumar, Lavina Patnaik and Simran Thakkar.
Congratulations.
You got a PGI team, Vivek Jha, Karthikeyan and Benjamin.
Congratulations.
You got AAA from KEM, Archana, Aditya and Anvi.
Congratulations.
And the 4th is Anurag Leela. One team from IPGMER, which is Arundhati Das, IPGMER and Goa Medical College. You are there.
Congratulations.
They were the toppers. We got Telugu Titans. So are you an Andhra team or a Telangana team? Telugu Titans Andhra or Telangana? AMC Andhra.
Congratulations.
We've got Twin City Titans. Oh, the Twin City is not our Twin City, thankfully. It's Cuttack and Bhubaneswar.
Congratulations.
We've got Usmania General Hospital, Sai Subramanyam, Maheen and Sneha.
Where are you?
Yeah,
Sorry,
they're there.
Yeah.
And we've got
Congratulations.
Ajit Jagtap, Jagriti Nandwani and Maitri Doshi.
From Pune and
TNMC
Mumbai.
and Kokilaben. And Sahyadri. Uday Fatke sir student. Right. And you got a Jipmer team, Anita, Mukesh and Manjunath.
Congratulations. Congratulations to all our qualifying teams.
And all the other teams, please do come to the finals. It'll be even better.
Before the other teams leave, please submit your answer scripts. The hall and time is...
Just 1 minute. Hall and time.
Hello. Hello.
The quiz finals will be at 4:30 p.m. at Dhira Ganguly Hall.
4:30 at Dhira Ganguly. Thank you. Please submit your answer scripts before leaving.
Okay. Hello. 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 So with this, we conclude the first day of our conference, and we look forward to see you tomorrow for another productive day.